No, fa fatica. Bisogna alzare la pennetta. Bisogna alzare la fioretta.
sono contenti. Allora io non ero presente alla multidisciplinare, però da quello che mi aveva scritto lui, tu eri tra l'altro sì. Io non ero presente, no, no. Solo per essere perché lui voleva escludere la presenza di malattia più aggressiva, perché il Gaglio l'ha fatto da poco. No, scusa, lunedì. Lunedì, sì. Infatti il problema è che hanno cambiato il giorno, hanno messo il giorno in cui io stavo in ambulatorio, non sono riuscito ad andare. E adesso a questi posti multidisciplinari di fatto chi partecipa? Noi ne abbiamo due, quelli dell'endocrini e quelli del DAC, in generale chirurgi, oncologi, radioterapisti, endoscopisti, medici nucleari. Benissimo, ma di loro della chirurgia. In generale, vengono i primari o vanno all'assistenza? Io vado, quando riesco vado sempre, cioè quelle del DAC ci sono sempre, per mai altri no, della chirurgia, per esempio Nino Tambulino, oppure Giovanni Guarneri, tutte e due, prima veniva Giampaolo Mazzano, insomma per la rete. Poi il limite e il pericolo delle multidisciplinarietà. Sì. Perché sai che un demente è meno pericoloso di 10 dementi. Questa è la verità, lo vedi nel territorio nazionale quando ormai la Consigliera del Pubblico la multidisciplinarietà è assolutamente necessaria e questi poveri malati arrivano dalla provincia di Lucca dicendo le gomme, mi ha detto così, posso vedere il nome del gomma, bianchi, rossi e verdi, mi fa dare un'occhiata, pubblicazione 000. Diciamo che quelli del gastrosofalo e del collo aperto ci sono stati. Lo è un'organizzazione così dove ci sono i capi, i capi che hanno il lì, allora quello è, se no non è detto che ci vogliono dare da solo, ovviamente confrontandosi sul singolo caso con fideli. Ricordo un anno che mi ha fatto all'UCL a Londra a fare questi Okay, I think we should get started. Otherwise, we're gonna be late. So, good morning, everyone, and welcome to the San Raffaele Research Hospital. My name is Luca Guidotti, and on behalf of the Scientific Directorate, I'd like to extend a warm welcome to all of you. And let me remind you that you are in the largest and most prominent research hospital in the country, with over 2,000 scientists, basic scientists, involved in all specialties of biomedicine, over like 1,000 among nurses, physicians, and physiotherapists, and another 1,000 clinicians. They're particularly engaged in clinical research activities, as evidenced by the humongous number of publications that they produce, and the, I think, over 200 investigator-driven clinical studies that are active at present. And in this context, urological research, and particularly urologic oncology, holds a place of prominence, as I'm certain will emerge from today's lectures and work. So I don't want to take up too much of your time because we're already late. So again, welcome, and I wish you a very productive day of scientific exchanges. Thank you very much. Good morning. My name is Francesco Montorsi. I am the professor and chair of urology. Here, welcome you all. Several years ago, our rector, Professor Gerlone, and myself decided that we should do everything we could to have Andrea Necchi join in the faculty as medical oncologist here. I think we never made a most appropriate decision. Andrea has been with us for many years now. He has been building a wonderful team within the medical oncology department. We as urologists, we as surgeons are probably sometimes more medical oncologists than they are, but at the same time, Andrea and his team very often are more surgeons than we are. So this community of intentions has made the group very successful. So Andrea, I'm very happy to show you our gratitude for putting together this meeting. Enjoy it. Bye.
Good morning. My name is Michele Reni. I'm a medical oncologist. I'm the head of medical oncology department here in San Raffaele Hospital. Actually, I am a pancreatologist, so I am close by, but I am a fish out of water here. I want to thank you for being here. We are honored by your presence. And also, I want to thank and to commend Andrea Necchi and also the organizing committee for being a restless organizer of both scientific and social events. He's a great team builder and has a skill of finding talents, young talents in his team, as Professor Montorsi mentioned before. And most of all, he was able to satisfy our surgeons that, as you know, are pillars of our institute, and this was a great challenge that he got. So welcome again. I don't want to waste your time further, and I leave the word to Andrea for introducing the meeting. Thank you.
So welcome, everyone, dear friends, professors, colleagues. Welcome to the third edition of our meeting. A truly international meeting has become, you know. So many friends I see from down there. So very briefly, the structure of the meeting is consistent with the previous editions, you know. You have the highlights of the year: bladder, prostate cancer, renal cell cancer. Then we move to the partnerships that we have made during this last year. Academic partnership first, industrial partnership, and then we will move to the big part of the afternoon session, you know, that is open to hear from the colleagues, from the other groups, from the team leaders. I see so many friends, so many leaders in various disease fields in the GO space here, and they will have to learn how to improve and to do better things for our patients. So please feel free to conceive all this day as a very free meeting. Please feel free to make comments, intervention, questions. So please make this a meeting very, very interactive. This year we have expanded to South America with Fernando. We have expanded to Italy also with Professor Procopio and the Mituro team. And please don't miss the breakout session, a very special session we have made this year. We have 2 breakout sessions during the break in the morning and during the lunch. These breakout sessions are conceived and will be managed by my team with interviews with rising stars in GO oncology, and we have rising stars here from international centers and from our group. And we will have a focus on the research nurse team, the study coordinators. We are not alone as physicians, you know, we are multidisciplinary. We are conducting a multidisciplinary, multi-specialist work involving not just MDs, but also other fields. So lastly, I would like to, prior to start with the meeting, I would like to thank the patients. We have a live stream connection during the all-day meeting with YouTube, and I know that many friends and many patients are connecting, so welcome to all of you, and thanks to all of you who have already made donation to our research. You have this booklet on the outside. Please grab your copy. You are there, most of you are there already, and the patients are there, so thank you to the patients who have made donation to our research, and the donations will foster also the next editions for the retreat. So thank you again, and let's start with the work, with the session. Thank you.
Excellent, beautiful. So we are going to start with the first session, and Professor Bellone from our Department of Immunology is sharing the chair with me. Welcome, Matteo. The session is called Key Advances in Geotumors, What Have We Learned in the Last Year? And we have 3 excellent speakers from this place. And the first is Professor Briganti, who is going to discuss for us prostate cancer. Albi is a professor of urology here at San Raffaele. He has done all his medical education here, beyond the one done abroad, and he's now currently the editor-in-chief of European Urology, that, as you know, is the top-ranked surgical journal in terms of impact factor. So, Albi, the floor is yours. Welcome.
So, thank you very much. Thanks for all of you being here today. Thanks for all colleagues coming from abroad. I've seen many friends here in the audience. Monty Pal is one of the associate editors of European Urology, which is actually the journal I have the honor to lead since last January. So basically my task is actually going through the key advances in prostate cancer over the last 12 months or so. Please consider this as purely clinical presentation, since I'm going into some clinical relevant questions which have been, in a way, touched upon over the last 12 months. So the first part of my talk will be about screening early diagnosis. So basically, what we have learned over the last 12 months is that use of usual screening based on PSA is pretty much over. So what we are facing nowadays is the use of risk-adapted strategies, which is currently the way to go if you want to optimize the use of screening in prostate cancer. And this is actually feasible. But we need actually high-quality MRIs, and we need something which might implement PSA whenever we do patient risk stratification. So pretty much this is what we are implementing in clinical practice. Patients are, or men, are invited to screen with PSA and other secondary tests like Stockholm 3, a 4K score, and actually these patients can be classified upfront into low risk, so they just undergo repeated observations, or high risk, in this case they undergo MRI, and if positive they undergo prostate biopsy. So this is the most efficient way we can screen nowadays prostate cancer, or we can do risk-adapted strategies instead of having PSA-based approaches only. But of course, this is highly related to patient age, and of course, this is also based on the fact that we are unlikely to impact just with the first screening. We need repeated screening or repeated approaches over time. And this is a nice study which has been published in New England Journal of Medicine. Patients were randomized into 2 groups. Patients with elevated PSA higher than 3 went randomized to either systematic biopsy, regardless of the results of MRI, or MRI and targeted biopsies. And I like this study because it actually highlights the importance of targeted biopsy in prostate cancer, because in this case, if you go for MRI and targeted biopsy only, we can decrease significantly the number of insignificant prostate cancer they may detect. So as urologists, we are moving towards the use of targeted biopsy, eventually coupled with perilesional biopsies only. And this is true also in the early diagnosis beyond the screening settings. Is this approach of inviting men with PSA for a PSA and then undergoing MRI if PSA is higher feasible? Yes, it is feasible. And this is the first actually organized patient program which has been developed in Sweden, in Lombardia region. We are starting to do the same thing. And pretty much what we expect is that 1/3 of patients called to undergo PSA and further MRI then is compliant to this approach. And actually, by using this approach, we can decrease by half the number of insignificant prostate cancer that we detect and then we do not want to detect. Food for thoughts. Can we actually skip PSA and these kind of risk-adapted strategies and go for MRI upfront? So MRI as first screening test, regardless of PSA. And this is a nice, intriguing data or hypothesis that's been tested in the UK. This is a feasibility study which is called Reimagine. Patients will actually just be screened with by parametric MRI. Is this cost effective? Unlikely. Is this going to be practice changing? Unlikely. But at least this is the proof of concept that we may use even earlier MRI, even instead of PSA. Time will tell. What we certainly know is that if you undergo and if you consider MRI, this should be high-quality MRI. And actually, if you consider, for example, earlier or younger patient population, it is evident, and this data coming from the PROBASE study, that you need high-quality MRI because the sensitivity of repeating reading is much higher than if you don't do double reading, especially in a younger patient population. So the take-home message of this study from the PROBASE is that if you counsel your patients, especially younger ones, undergoing MRI, this should be done by expert radiologists. So what about diagnosis and treatment? So over the last 12 months, we actually we are understanding that biparametric MRI can replace, indeed, multiparametric MRI with several savings in terms of time and in terms of cost. We may use targeted biopsy only in addition to perilesional biopsy, as I was mentioning, and we are also implementing AI. This study is not yet published, but actually it will publish likely in a high quality and high medical journal. We actually also took part of this study, which is the PRIME trial, just released at the last meeting of the European Association of Urology. To make a long story short, this is a non-inferiority study, which is prospective, not randomized, but which is showing something which we knew already in a way. Biparametric MRI is non-inferior to multiparametric MRI as far as clinically significant prostate cancer is concerned. So this is the highest level evidence that we have now available, not yet published, confirming the role of biparametric instead of multiparametric MRI. What about AI? I think that this is the best publication over the last year in terms of AI, which is kind of practice changing. It has been published on the Lancet Oncology, and actually it has been shown that if you implement, and this has been done over thousands of serial MRI evaluations that have been reassessed by expert readers. If we apply AI protocols, you may end up in having even better accuracy as compared to radiologists. So actually bad news for radiologists, but the concept here is that actually AI can increase the number of the accuracy and increase the number of real positive tests. Because one of the main issues we have in MRI is not the negative predictive value, which is solved. The real issue is the positive predictive value and the specificity nowadays. So basically, using AI, we can increase significantly the positive predictive values and decrease the number then of unnecessary biopsies. What about treatments? I just want to highlight one thing, which is nowadays a kind of hot topic for us. Whenever we prescribe and whenever we actually give indications for radiation therapy, there is evidence now that, of course, hyperfractionation is efficacious and safe. But nowadays, a couple of studies have also tested the role of combination treatments between ADT and postoperative radiation therapy. And as surgeons, this is very important for us because we are moving towards salvage radiation instead of adjuvant radiation therapy. So the real question is whether it's beneficial to add on it ADT. Other studies have tested that, of course, like the RTOG and the J217, but still the Radicals HD has been published this year and actually randomized patients considered for postoperative radiation therapy to either ADT 6 months versus no ADT, or ADT 6 months versus ADT 24 months. So this is one of the two studies that randomized patients to no ADT versus 6 months ADT in patients candidate for postoperative radiation therapy, coming, of course, from the UK, and they randomized everybody, and actually 30% of these patients receive adjuvant radiation therapy. The bottom line is that according to the Radicals HD study 1, there is no significant benefit of adding 6 months of ADT as compared to no ADT in the postoperative radiation therapy. However, actually they randomize in this study the best performers. So we are talking about patients with favorable characteristics. The differences are there in the second part of the study when instead they randomize, and this was based on the discretion of the physicians and the patients to either 6 months of ADT versus 12 months of ADT, 24 months of ADT in patients receiving postoperative radiation therapy. The number of patients receiving radiation therapy in the adjuvant setting were approximately half. And the characteristics of these patients were quite unfavorable, a third having seminal vesicle invasion, a 50% having a Capra score high risk. And in this setting, there was a beneficial effect of adding 24 months of ADT in addition to postoperative radiation therapy. So the two messages from the combined study is that, I mean, of course, the use of ADT together with postoperative radiation therapies is highly likely to be beneficial according to patient characteristics and according to patient features. The higher the aggressiveness, the higher benefit of a postoperative ADT together with radiation therapy. What about metastatic hormone sensitive? There are not so much news there. The real news that I would like to share with you is the PEACE-1 study. And this PEACE-1 study has been published by our great friend Alberto Bossi and the team, just published on The Lancet. And I think you all know this study because the previous two arms in terms of systemic therapies have been already released. They opened the doors to triple therapy, as we all know. But now they just published the actually two arms results when radiation therapy to the primary was added to systemic treatments. What happens? Well, as we expected, radiation therapy to the primary together with abiraterone and ADT was able to increase actually metastatic-free progression, and actually with no benefit on overall survival. But the main message, and this study has many limitations, but there is no time to go in depth, but the main message of the PEACE-1 study to me is that radiation therapy to the primary may be offered also to patients with high volume diseases. So those patients that might benefit in terms of local symptoms, but also according to the PEACE-1 study, they may benefit also in terms of time to castration-resistant disease. So food for thoughts. I think that sooner or later, if we are not already doing that, radiation therapy to the primary, given its relative low toxicity, may be beneficial also in patients with high volume metastatic disease. One study which I would like to mention is also the upfront PSMA, which is the very first phase 2 study that tested the role of lutetium PSMA in the hormone-sensitive de novo disease. And of course, the PSMA addition study is not yet published, but still, this is coming from Australia, as many of these studies using lutetium PSMA, but it's the very first evidence that if we add lutetium PSMA together and then follow it by docetaxel versus docetaxel alone, there is a benefit in terms of at least PSA responses, but also in terms of clinical progression. So this is the first evidence that if we anticipate the use of lutetium PSMA in this metastatic hormone-sensitive disease and followed by docetaxel is better than docetaxel alone. And I think the PSMA addition will go in the direction, but we'll see. Last couple of slides I will share with you is the novel approaches in metastatic castration-resistant prostate cancer. The guidelines in 2024 actually have changed significantly because they included the use of lutetium PSMA in the earlier setting of metastatic castration-resistant prostate cancer, but also they included the use of PARP inhibitor together with either abiraterone or enzalutamide, thanks to the TALAPRO-2 study and also the PROPEL and other studies. But nowadays, the EAU guidelines in 2024 now use or recommend the use of PARP inhibitor plus either ABI or enzalutamide in patients with mutations and previously untreated for metastatic CRPC, kind of niche population of patients, but still recommended. There's a strong recommendations within the guidelines. What about lutetium PSMA? We were used to think about lutetium PSMA in the CRPC setting being reserved for patients progressing after previous lines of therapies. But nowadays, things have changed. Indeed, the guidelines include lutetium PSMA as one of the options as soon as patients become CRPC, indeed. And this is an ENZA-P study, which actually included patients not previously treated with docetaxel or any ARPI. And this is a phase 2 study in which patients were randomized, indeed, to lutetium PSMA plus enzalutamide, to enzalutamide alone. And if we look at this study, there was a benefit on PSA progression, clinical progression, and radiographic progression-free survival. So the ENZA-P has established the possible role of lutetium PSMA in patients that actually were not previously treated with neither docetaxel or any ARPI. Last study, which I'm going to mention, is again the PSMA-4 study, which actually showed the benefit of lutetium PSMA in patients with taxane-naive metastatic castration-resistant prostate cancer. I mean, this is a strange study because the second arm of randomization was a change of ARPI, which, according to guidelines, should not be done, actually. And the EAU guidelines recommend not to change ARPI in patients who progress on ARPI because these patients are unlikely to benefit. Nevertheless, there was this randomization, and actually there was a beneficial effect of lutetium PSMA as compared to change of ARPI in patients progressing after ARPI. And so this is another evidence anyway that earlier use of lutetium PSMA in the phases of early CRPC indeed may make a difference. So I'm sorry to have bombarded you with this data, but these were, I think, the most important data that have been highlighted and published in prostate cancer over the last year. And thank you again to all of you, and thank you to our colleagues coming from abroad. Thank you.
Albi, why don't you sit over here so that we will have the discussion? Matteo, would you like to introduce the next speaker?
Sure. I guess that there is no need for any introduction for Andrea. Just.
Thank you, Matteo. So welcome again. So I will try to summarize the 1 year of research development in bladder cancer. It has become so difficult task, you know, to summarize in 15 minutes what has happened in 1 year in bladder cancer. We are lucky and good for the patient for sure. I have a conflict. So let's be very schematic, you know, just a message, the highlights going throughout the clinical stage. Let's start from the very early stage, the non-muscle invasive disease. What is going on there? The field was classically managed by urologists, but is no more handled. They are no more alone in this field. I see down there many friends that have to do somehow with this kind of development, you know. Developments in non-muscle invasive disease means primarily developments for treatment for the patient who have a disease who do not respond more to BCG therapy. For this patient, there is radical cystectomy as a standard of care option, and a huge plethora of clinical trials have tested newer therapies in this patient in order to make a possible change and a possible alternative as compared to radical cystectomy alone. The Sunrise study is one of these attempts. Sunrise-1 study is part of a platform study of Sunrises using TAR200, which is something like this on the upper right side. A small silicone tube that is providing continuous release on the chemotherapy drug, on the gemcitabine into the bladder, remove and recharge and put into the bladder every 3 weeks. And it is used as monotherapy or in combination with immune checkpoint inhibitors. Sunrise-1 is a study with multi-cohort study testing various therapies. TAR200 alone as a cohort B, the main cohort, or in combination with checkpoint inhibitor or a checkpoint inhibitor alone. The primary studies, the primary results have been presented last year. This year, the ESMO, we have the latest update on this. You see the complete responses. Complete responses mean no more tumor in the bladder assessed with biopsy, with cytology, cystoscopy, imaging. 83.5% of the patients achieved clinical CR with TAR200 monotherapy. And there is an issue as regards to the contribution of systemic therapy. We will discuss later on. Most of the responses are durable, and the drug has already been granted the FDA breakthrough therapy designation. Another intravesical therapy, it is called cretostimogene, is a conditional replicated adenovirus, so a viral therapy put into the bladder in the same way, so in a way that is similar regarding the timing to BCG. Again, BCG unresponsive disease. Ashish Kamath is here. He is a master in identity, he led the way we currently define BCG unresponsive tumor and put the basis for all the research that we are doing today and the identification of the patient categories in which we can put the studies and we put our attention. The unmet needs, you know. CR rate is similar, 75.7% at any time. The drug also was granted the FDA breakthrough therapy designation. We'll have tomorrow FDA people connected in the other joint meeting, I will tell you. But this is a US-based study. Sunrise-1 was an international study. This might have an impact. Shilpa, where is Shilpa? She will have the lecture on geographical disparity. This is a big thing, a big issue. So doing international trials is for sure a value as compared to doing country-based studies. As regards the patient heterogeneity, you know. TAR210 is the evolution of intravesical therapy, putting not just a chemotherapy drug into the bladder, but for the first time in solid tumor oncology, a topical targeted therapy. So the same way, a silicone tube that is put into the bladder and releasing erdafitinib, an anti-FGF receptor, pan-FGF receptor inhibitor, into the bladder for the same tumors. This is a very initial study, initial results, very small numbers. I will not focus too much on these numbers, just to say that we could be on the right path. And the Moonrise-1 study that is opening in San Raffaele and many other countries worldwide is putting this drug as compared to standard intravesical therapy and may set a new standard of care in the near future. The summary, very complicated, I'm sorry. Very complicated slide that is recapitulating the data with regards to the clinical CR, duration of CR. I would like to see this slide more like this, that is providing an idea of duration of responses, blue column, 6-month CR rate, orange column, 12-month CR rate, with various therapies. You see on the top of the slide, intravesical therapy or intravesical and systemic therapy. There is no huge disconnection, you know. So what is the contribution of systemic therapy in this patient is still unknown. Intravesical therapy is certainly better positioned to make a change in these patients. Again, Shilpa will tell you about the geographical disparity. It's a big issue. It's a big issue. Here, a patient A diagnosed in the United States, so many therapeutic options down there as a sequence. A patient B that is diagnosed here in Milan, or maybe in Sao Paulo, or in many other countries, in Shanghai and so, will have BCG rechallenge, or gemdosi, or chemoradiation, nothing more, if his destiny is a radical cystectomy. So let's move a big step forward. The MIBC, muscle-invasive bladder cancer, the neoadjuvant studies, you know, just putting the old slide and updating with the latest numbers. The Optimus study provided the latest results with the checkpoint inhibitor monotherapy, aligning with the rest of the results, 40% PCR. So the main message here is we are good shape for making a potential change in this patient. Are these results sufficient to look at monotherapies, immune therapy as monotherapies to make a change, and when keeping the bladder intact? Maybe not. Let's see, we'll discuss it. Huge room for discussion, you know, about this. Even more controversial is the issue of combination therapy, when combining immune therapy and chemotherapy prior to radical cystectomy. Again, we made the latest step with the NUR-combo. Chiara, where is Chiara? First author of JCO paper on NUR-combo study and San Raffaele study, putting a newer chemotherapy combination as a backbone therapy, Abraxane, a taxane-based chemotherapy, together with nivolumab, as compared to all the other studies that put the classical cis-gem platinum-based chemotherapy in combination with immune therapy. Again, here, the PAT-CR issue is still controversial because we do not have any big change as compared to monotherapy. You know, there was a big change this year among the several phase 3 studies that are running and that are being releasing data, in particular from the Niagara study. The Niagara study was a huge effort made worldwide, comparing durvalumab and neoadjuvant cisplatin-based chemotherapy, followed by adjuvant durvalumab tail, as compared to standard chemotherapy and radical cystectomy, PCR event-free survival, where the endpoints of this international study clearly a potential new therapeutic option. With regards to the advantage improvements in DFS, in overall survival, in response rate. The FDA priority review was communicated by the company on December 6th. It is likely to become a newer therapeutic option in this field. Well, I would like to point that again on the focus on the PAT-CR rate in Niagara, because there is still a controversial issue here. 33% PAT-CR rate with Durva-Gem-Cis, not hugely different from the other studies, or from the study with immune therapy and monotherapy, or not that different as compared to standard chemotherapy. You see in the red box the latest data with the standard of care chemotherapy, the Vesper study MVAC, or the Coxen study with Gem-Cis. There is no disconnection, you know. So what does it mean, PAT-CR, and what is the surrogate value of PAT-CR as compared to adjuvant or compared to survival improvement? I will have the slide on discussion about this. And lastly, the way of treating muscle-invasive disease for the first time with a combination of intravesical therapy, so putting intravesical therapy beyond the boundaries of non-muscle-invasive disease and combining with immune therapy. Sunrise 4, TAR-200, you have seen it, with an anti-PD-1 antibody, or cretostimogen plus nivolumab. Nature Medicine paper, ESMO presentation. Very similar data so far. PAT-CR rate of 40%, 42% on one side, around 40% on the other side. Pretty well shaped to make a potential change in the way we treat patients. So in summary, for me, for muscle-invasive disease, the success area is clearly, for a perioperative study, is clearly survival, the endpoint, the main endpoint. So the success area is something that stands above the 80% survival. So Durva-Gem-Cis is pretty well positioned, but we do have also standard of care chemotherapy that is overcoming this barrier. But the point is that the patients are now rising the bar. We have patients connected here on YouTube, you know, and I'm sure that most of you that you are hearing my lesson are thinking about your bladder, your destiny, your diagnosis, and saying, okay, doctor, I would like to be cured possibly, but possibly by saving my bladder. And this is something that the patient have rising as an issue, in particular if they achieve a complete response after neoadjuvant induction therapy. So in order to do so putting the Niagara paradigm and removing the surgical part, in order to do so, we have to do better. We should do better in terms of the intermediate endpoint of past CR. So the rate of success, to me, it's just my take, is something that stands above the 50% bar for the success. And with all of the studies that we have put so far, with unselected patient at least, we are still a bit below this bar. So we have to do a bit better with this regard. Matt-Galsky, we will have Matt-Galsky tomorrow in the ancillary meeting. The TURBT plus chemo plus immunotherapy as a paradigm for curing patients while saving the bladder. Initial data putting on the clinical CR focus, which will be fully dedicated to clinical CR issue. Clinical CR was predictive for benefit in survival, and the RETAIN study conducted in the United States was pretty much on the same line. I put this as a 2024 highlights because this study will be released next week on JCO, and the study provided an observation in the case the patient achieved a clinical CR after standard chemotherapy, if in particular the tumor has some kind of genomic alteration. Radical cystectomy, a big focus on radical cystectomy was for Seth Lerner and colleagues from the SWOG trial. A big study, putting a surgical trial on New England Journal of Medicine, you know. So big effort, a huge congratulations to the team. Extended lymphadenectomy did not provide superior results as compared to standard lymphadenectomy. So something that is putting a big change, a big consideration for the standard of care practice when doing radical cystectomy. And the adjuvant setting, we have updates, like here in JCO with Checkmate 274, adjuvant nivolumab providing survival improvement as compared to placebo, or other studies like Ambassador study, released in New England Journal of Medicine, presented at ASCO GU this year, updated at ESMO this year by Andrea Apollo. Andrea will join us also tomorrow. Pembro as a potential new standard of care. Again, here, the Ambassador study was a US-based study. Checkmate 274, an international study. This is something to consider when dealing with potential therapeutic options. Very quickly moving to the advanced stage, platinum-based chemotherapy is still there. Gem-cis and nivolumab is there an option, and EV-Pembro is clearly, as clearly shown here with the most updated guidelines for ESMO, published in a few months ago in Annals of Oncology, is the first option to make for the patient diagnosed with metastatic bladder cancer. A focus this year was made on categories of patients within these studies, putting the light on the results on lymph node-only disease and the benefit with Gem-cis Nivo and EV-Pembro in lymph node-only disease, oligometastatic disease, potentially making a change in the way we treat patients with lymph node positive tumor when they start systemic therapy. A major breakthrough, I think, in this field will be from the GDF15 target, just released yesterday on Nature. We had Eugen Leo, the CMO of Catalin, here last year, presenting the initial phase 1 data that have been published in full in Nature. GDF15 is a pretty fascinating story in solid tumor oncology, discovered by gynecologists in Germany. Is a protein that is expressed by placenta as an immunosuppressive factor, and the Catalin team developed an antibody anti-GDF15. There was a partner drug with nivolumab in this study, and we are concluding a study putting visugrumab, the anti-GDF15 antibody, together with nivolumab prior to radical cystectomy in patients with MIBC. We are pretty much excited about the anticipated data from this neoadjuvant study. Lastly, the ADC, antibody-drug conjugate field, putting light on the targeted ADC with the potential for revitalizing the HER2 targeting. Disitamab vedotin and Pembro showed impressive response rate. Matt-Galsky presented this study at ESMO this year. Similar study had been published last week, 3 days ago, I think, on Annals of Oncology. Disitamab vedotin plus toparlimab is an anti-PD-1 antibody. Front-line therapy or second-line therapy, 73% of the response rate in metastatic patients. Or the way of putting bispecific antibodies and trying to shape again a story around the EGFR HER3 story in bladder cancer. This drug, which is a bispecific antibody, a bispecific ADC EGFR3, provided the initial data presented at ESMO by Dingwei this year, with a response rate of 40% in far pretreated patients. And Antonio will put highlights later on the role of bispecific, bicycle therapy ADCs as a potential newer ADC way. Last slide, Petros Grivas presented the initial findings from TROPiCS-04, sacituzumab govitecan versus standard of care chemotherapy in patients who received already chemotherapy and the checkpoint inhibition. Negative data, negative results in terms of the study did not meet the primary endpoint of overall survival. PFS was not met, response rate was not met. There were issues related to the toxicity of sacituzumab, partly mitigated by the use of GCSF. So the first negative signal that we gathered this year, a few days ago in Singapore from an ADC. So in conclusion, very short statements. Unmet needs in MIBC, the struggle of intravesical and systemic therapy. Intravesical is better position. MIBC, the rise in the bar of therapeutic success with clinical CR as the next focus. We will hear tomorrow with the FDA meeting. And the locally advanced and metastatic UC, the concerns when developing ADCs, pros and cons of developing ADCs, in particular in the biomarker selected patients. You will hear from, you will know, you will meet most of these guys here that made, again, steps forward in their career. Also, merit awards and merit awards. I cannot count more how many merits awards they are winning. Anyway, we are all proud of them. We will hear from them during the day. Thank you.
Thank you, Alberto. Now we switch gear and we get into the kidney cancer field, and I invite Dr. Alessandro Larcher to the podium. Alessandro is a bright example of the kind of physician this university can generate together with Alberto, obviously many others in this room. Please.
Thank you very much. Thank you, Andrea, for the invitation. So I'm delighted to discuss innovation in kidney cancer. I have selected three key studies in those major areas of interest: improvement in the diagnosis of clear cell renal cell carcinoma, adjuvant therapy in the setting of high-risk disease, and novel systemic agents for metastatic patients. So those are data stemming from our internal repository. Those are consistent with any international series, showing that basically between 10 and 20% of the patients that we elect for surgery at the end of the day are diagnosed with a benign renal mass. And this is extremely frustrating because it comes at a cost of perioperative morbidity and complication that becomes unacceptable in these specific fields. Any surgical treatment delivered to the kidney, even the best partial nephrectomy performed, imply some extent of renal function detriment. And of course, this is a waste of money. So those are the reasons why this specific investigation generated a lot of hype in the field. This trial has tested 89 zirconium girentuximab for the diagnosis of clear cell renal cell carcinoma. The compound is radiopharmaceutical with a photon emitters, which is 89 zirconium, labeled with an antibody targeting CA9. As you can see, CA9 is a membrane protein that is the most commonly used marker in immunohistochemistry to confirm a diagnosis of clear cell renal cell carcinoma. The design of the study was to test, to compare, basically, perform a comparative analysis between PET and the standard of care for imaging, that is CT scan, with a specific endpoint of evaluating sensitivity and specificity. Patient population was patient diagnosed with CD1 disease and already scheduled for nephrectomy because surgery was used as a standard of truth. Those are the images. As you can see on the left panel, a very, very small tumor with a very avid uptake of radiopharmaceutical, and that was confirmed as clear cell renal cell carcinoma. And on the right panel, instead, we have an example of a negative findings. The trial was positive, and the overall sensitivity was 86%, specificity was 87%. So a lot of enthusiasm has been generated, and this compound is under scrutiny from in the regulatory agents of Europe. However, there are some issues that deserve discussion of this specific study. Number one, the restriction of the population to patients with CD1 disease prevent generalizability in the setting of high-risk renal cancer. The second issue is that we do not have a biologic explanation for this figure here, which is kind of disturbing, because what is the reason behind a false negative result? And the third issue is that is kind of surprising. In the trial, most of the patients were not scanned with a whole body scan, but only the abdomen was investigated. And this prevented key information with respect to the utility of Kike's PET for systemic staging. So based on this premise, we have raised this critique to the journal, and thank you to the collaboration with our nuclear medicine department, we have performed a pilot experience here as first center in the country with girentuximab. And according to the protocol we have developed, we have specifically focused our analysis to the high-risk renal cancer disease. We have performed whole-body imaging with intent to retrieve information, accurate information with respect to systemic staging, and we have also we have scheduled surgical treatment when a little bit of activity was anticipated in the primary tumor in order to perform ex vivo imaging with a preclinical high-resolution PET scanner. So those are the results in our initial series. As you can see, the first patient had a very aggressive high-stage CT3 renal cancer, and the PET was able to detect very clearly the areas in which CA9 was expressed. And in our series, the diagnostic performance was virtually perfect. This is the result of the ex vivo imaging. As you can see, this is a high-grade, high-stage clear cell renal cell carcinoma. And we were able to compare expression of CA9 at immunohistochemistry together with ex vivo imaging. And it was amazing for us to observe that the overlap was virtually perfect. We have this cold area inside in which CA9 was absent, and instead a very, very high uptake of radiopharmaceutical in the peripheral region. And the implication of these findings are several-fold, because we can speculate that the biologic reason for the negative findings in the ZIRCON trial is not related to any issue of pharmacokinetics. Other key implications are to translate these findings in the setting of therapeutic use of radiopharmaceutical, because clearly instances of reduced expression have an intrinsic risk of undertreatment in case of therapeutic radiopharmaceutical. Finally, as I said, the enthusiasm and the utility of this imaging modality for imaging is going to be key. We are pretty convinced about that, and this is a very, very clear example. This was a patient with an unexpected metastatic lesion at the level of the bone that was misdiagnosed by standard imaging and instead was detected by whole body scan with this modality. Moving on, in the setting of adjuvant therapy for high-risk disease, last year was reported the update of the Keynote 654 trial, focusing on overall survival. So following a previous positive signal with respect to disease-free survival, the extended follow-up allowed for the evaluation of the impact of pembrolizumab following surgery for high-risk renal cancer against placebo with respect to overall survival. This has key implications because in our country, a patient that is diagnosed with high-risk renal cancer has a clear indication for this kind of therapy, but it is not covered by the national health system yet. So the trial was positive. Median follow-up was almost 5 years, and at the pre-specified time point of 48 months, the overall survival resulted more than 90% in the treatment group and 86% with a striking hazard ratio for death of 0.6. We have to be aware that this comes with a cost in terms of toxicity and side effect. And it's very important to bear in mind that more than half of the patients in the placebo group were alive and free from any recurrence at 48 months of follow-up. So we have to balance basically the toxicity of this therapeutic regimen with this figure, and this is the reason why it is key to better stratify the patients that will require, that are the optimal candidates for adjuvant therapy with pembrolizumab. Finally, there is a lot of interest with respect to this very, very novel systemic agents for renal cancer, belzutifan. The story is very, very nice because it is the first systemic agent that has been approved by FDA for hereditary renal cancer, and it has been tested in a very peculiar setting because it is a systemic agent that was used to treat the primary, basically, so kind of unique story. This year was reported, this investigation focusing on patients with advanced metastatic disease. It's important to have very, very clear that the molecular target of this agent is very, very high in the hypoxia pathway because this is a HIF inhibitor, so preventing the action of the direct product of the VHL gene that is involved in almost 70 to 80% of sporadic clear cell renal cell carcinoma. Very peculiar population because here the patients that have been enrolled are patients with advanced disease who have been already previously treated either with immune checkpoint inhibitors or anti-angiogenetic therapies. And the design was, again, a comparative analysis of belzutifan versus everolimus, both delivered orally. The trial was positive with respect to progression-free survival, kind of significant difference between that was measured 18 months following randomization. 24% was the proportion of patients who were progression-free survival in the belzutifan group versus 80.3%. The study was positive also with respect to objective response rate and complete response. Now, it's very peculiar to focus on the safety profile of this compound because since the molecular target is extremely different, also the toxicity is kind of peculiar. So let's start from the concept that the overall rate of adverse events was the same, and basically the overall incidence of events that led to treatment interruption was the same. But if we dive deep into the specific kind of side effect, you will see that basically all the toxicity stemming from the use of belzutifan is related to either anemia or hypoxia, nothing else. All the specific side effects that were observed were extremely uncommon. And this is, from a practical point of view, translate into a little bit wider margin of maneuver with the drug because you can just stop it and then give erythropoietin or consider maybe transfusion, and then you can restart the treatment, basically. So the discontinuation was different between the two groups. And this is very I think, important concept that we have to bear in mind when we consider all the options that we have for the patients, and very likely this is a compound that will move forward in the lines of therapy. So my keynote are that carbonic anhydrase 9 targeted PET has a very, very interesting diagnostic and staging potential for clear cell renal cell carcinoma. Indications for adjuvant therapy with pembrolizumab will be expanded, even though a better patient selection will be required. And in this specific regards, real-world data might be instrumental to better define optimal candidates. And If2 inhibitors are an extremely interesting options for a patient with advanced disease. Thank you very much.
Excellent. It was a beautiful session. Are there any questions or comments for the audience? You just stand up and you will receive a microphone so that we can make it as colloquial as possible. I would like to start by asking our host, Andrea. So you mentioned the area of neoadjuvant immunotherapy in patients with muscle-invasive bladder cancer. We have done many of these patients here, as you know. In those where we would find a complete response at the end of medical therapy, where together with the patient we would decide not to remove the bladder, and then during follow-up something comes back and it is non-muscle invasive, it is superficial. What are your views in that specific patient population? Do you think that we should counsel them to reconsider the idea of radical cystectomy, or you think that we can envisage something different?
Yeah, thank you, Professor. So a very complex area, you know, that we are facing every day with our patient, every single day, I would say, with our patient. As I mentioned, so many patients are actually raising this issue, you know. So it is something that was raised primarily by the patient. So patients are clearly asking us to do something different. And we started doing something different by being flexible enough, not just with our paradigm for treatment that we are proposing to the patient, but in our state of mind, being open enough to consider that the patient could change your plans, you know. This was a very, very good educational step for all of us as oncologists. We started with a very stringent, a very strict paradigm for neoadjuvant therapies, classical paradigm, neoadjuvant treatment, and radical cystectomy. But we clearly realized during these very few years that it was not 100% applicable today. So in order to keep the study alive and to provide the patient with a different opportunity, we should have been brave enough, smart enough to change our plans. As it usually occurs in everyday practice when you have to make changes in your treatments, in your plans. This is the same for clinical research. We should be prepared to make changes during a treatment. Going back to your point, yeah, the definition of clinical CR is complex. We'll dedicate an entire afternoon tomorrow involving multi-stakeholders, colleagues, FDA, EMA people, patient side, and so. But I still doubt that will result in a full 100% consensus on this. And in particular, what I'm pretty much concerned today, we were discussing yesterday evening with Alberto, is what is going on afterwards. So, okay, keeping the bladder when the patient achieves a kind of deep response sometime, but are we 100% sure that providing the patient with TURBT, intravesical therapy, chemoradiation, salvage chemoradiation, and so is better than doing radical cystectomy? So we are experiencing today, so it's a completely new field, so we are seeing today what is happening, so we are fully unprepared, basically, in principle. The good thing is that the majority of the relapses are occurring not as non-infiltrating relapses, high-grade non-muscle invasive disease relapse, but it's still an issue. So we are, and I'm personally fully open to see your personal viewpoints And Alberto viewpoint now, and please feel free to intervene and to make your comment based on your perspective and your research, Thanks.
I would be interested in hear Professor Kamat's views. You work in a center which is probably doing, if not the largest, one of the largest number of radical cystectomies in the US. So what are your current views in those who would receive neoadjuvant immunotherapy or chemotherapy? They do have a clinical complete response. And I'm sure that many of these patients are asking you, is it really necessary that I remove my bladder? So what are you now doing?
So this is a question that we've wrestled with for now going on 25, 30 years, right? And the issue is that our clinical staging has improved. So that's one thing we need to keep in mind. When we first started 25, 30 years ago, clinical staging was not where it is today. And if you look at the classic series, more than 40, 45% of patients would recur with muscle-invasive disease, and about 25% would recur with metastatic disease within 24 months. So clearly, if you're avoiding radical therapy and then the patient is dying, and we didn't have EV-Pembro, and even now if you have EV-Pembro, it's not like we should have that paradigm. So our clinical staging has improved, and the question that we're asking today should be asked in the context of what we have today, which is we do have ctDNA, we do have MRI, we do have better staging. So it's a brand new question in some ways. It's not like we can bank on, I mean, I do this. If I'm debating Nick James or if I'm debating somebody else, I'll use series from 5, 8, 10 years ago and make the point that a radical cystectomy still is the most appropriate curative option. But honestly, even at our center, we are seeing more patients whom we've done appropriate clinical staging on. There's absolutely nothing in the bladder. The patients are given the option of going on observation, not necessarily in a clinical trial, and they've done much better than they have in the past. So we do have to revisit this question. I think it's a brand new era.
Any questions from the audience? We still have a few minutes.
Well,
Yes, please.
Professor Montorsi, Briganti, Nike, everybody, fantastic to be here. Thank you for a third successful already retreat. Petrus Grivas from University of Aston Fair Heart Cancer Center. A quick comment on Professor Montorsi's question. I think this question is being again and again answered by, I would say asked first by patient advocates. And I think this is a major need that we hear at the Bladder Cancer Advocacy Network. I think it's becoming more and more common. The challenge we have had is what Assis mentioned, the lack of accurate clinical staging. And I think, the input from urologists is critical in that regard with looking at the bladder. Of course, with the advent of MRI, multiparametric, and ctDNA, I think we're getting better in the clinical staging and potentially in the selection of patients who may have long-term benefit after achieving what we call clinical complete response. However, we need to define that clinical complete response as stringently as possible and consistently across clinical trials, which I think has been one of the caveats so far. We're going to have a discussion tomorrow in the separate session we have regarding this question, and hopefully we can design consistently trials with harmonization of time points of DNA collection, endpoints, patient population to have a more reproducible result and interpret the data better. So that's a great question that you're asking. One quick question I have for the group here across the three super experts here. One common theme, that comes up is precision oncology. And we have over the years challenged with the lack of reproducible and reliable, accurate biomarkers. If I can ask each one of the three of you to list your most promising biomarker, kidney cancer, bladder cancer, and prostate cancer, that can define, I would say, the highest impact on patient care in the next 3 years. Thank you so much.
Let's start from RCC.
It's difficult that to answer CA9. There are multiple ways to look at that because it was also tested as a systemic biomarker, and I'm meaning measured in the blood. We're planning to measure that in the urine as well, but with respect to the intertumoral marker, nuclear medicine makes that visible. So that would be my take.
Well, my take for bladder, if we look at 2024, things may change, last year or next week, we don't know. But let's say, for a therapeutic standpoint, HER2 pathway, the HER2 targeting is pretty well promising, maybe a bit more than FGF receptor targeting with regards to the toxicity of the drugs that you are providing. And ctDNA for the current use of, for multiple use in perioperative therapies or in adjuvant therapy selection is still well positioned. The point of ctDNA is still that it's a bit imprecise today to evaluate patients with the minimally infiltrating disease. So we, guys will have a poster on the next ASCO meeting on this. So patients with minimally infiltrating T2 tumor or patients who achieve complete response or near complete response to therapy, most of the times have present with a negative ctDNA test. We will hear from Natera guys from the ctDNA standpoint. We will have a lecture fully dedicated on this. I'm pretty much interested to hear from this. So maybe urine testing may be well positioned in looking at the non-muscle invasive residual disease, let's see. But as for today, from big trials, we know ctDNA.
Well, for prostate, as you know, it's very difficult because, I mean, there is a complete failure in many instances of significant biomarkers. So, and by the way, there is Francesca De Michelis in the room just behind you. So, I mean, she is one of the major leader in the field. So maybe we can ask her a view for the futures. What I can say is that from localized disease and metastatic disease, things are really different. So as far as localized disease is concerned, I think that the most promising one, which needs to be still validated in many settings, is Stockholm 3 for me. And then there are a plethora of other genomic classifiers within the tissue, which has been tested over time. But maybe, Francesca, you may add something. I don't know if there is a microphone here, please.
Welcome, Francesca. You are the next frontier of our collaboration expansion, you know.
Thank you. It's wonderful to be here. What an amazing meeting. So, yeah, cell-free DNA, I think, you know, there's a long way to go still in terms of sensitivity. But I think that very nice studies are coming out using different features of cell-free DNA, going from physical features, chemical features, anything. And we just need to push the boundary a little bit more to get into there. And also, you know, looking a little bit forward, extracellular vesicles might also be something to track because they give components on the transcriptomics and the protein cargo that can help us. But yeah, you know, the reason why I'm working on prostate cancer for so long is because there are so many open questions for biomarkers that keeps us busy.
So, Epi, actually, you mentioned extracellular vesicles because we have, I don't know whether we have our proteomic people in the room, but we are working very heavily on extracellular vesicle, which nice prognostic features, and that, I mean, in terms of clinically significant prostate cancer in localized disease, so yeah. Happy to collaborate.
Absolutely.
I have a quick question. Oh, Shilpa, please.
Thank you.
I just wanted to make a comment on the lines of the disparity. You know, like the ctDNA you mentioned is such a huge progress in the field, but it's not even available here, right, Andrea? Like patients cannot afford it. So we have all these fancy biomarkers, and it's the same for countries in Asia that while in US we have the luxury to order them whenever we want, rest of the world really doesn't. So it would be great to discuss how we can close that gap.
That's a great point. Those ctDNA tests are mostly not reimbursed, you know, in many countries extra US. So we'll hear from Natera guy, you know, how we can improve. Yeah, please, Fernando.
It's a quick question. We showed the trials of muscle-invasive disease with immunotherapy. The Niagara trial was positive. The Checkmate 274, that update was positive as well. My question to you is that patients who achieve a PCR, despite its chemotherapy, chemoimmunotherapy, in the Niagara, they follow adjuvant durvalumab. But most of these patients with PCR are cured. So my question to you is, to patients who are treated in Niagara, I mean, on the day-by-day basis, who had a past CR, do you think they need adjuvant durvalumab, number one? And number two, if the Checkmate 274 was positive, should we reserve immunotherapy just for those who really probably will need immunotherapy after surgery?
Yeah, a tricky point. So I will not anticipate the results and talks that will happen the next meeting, but I'm pretty sure that we'll hear shortly at the next international meeting further data going out from the Niagara, dissecting a bit more in deep the role of PAT-CR and the outcomes of the patient within the studies according to the pathological response, you know. So we, in 2025, it's likely that we will get a kind of recommendation on this, on how to better shape the tail of treatment, the adjuvant period, you know. So we are using paradigm for treatment for all comers, you know, regardless of the PAT-CR. But we may be, we can discuss upon this. Also, when considering the approval and the label from the immunotherapy in the United States and in Europe for nivolumab in particular, or in the future for Pembro. So starting earlier with immunotherapy or looking at the advanced data on the adjuvant therapy is still tricky. We are still, but we have still to understand more what is actually the role of pathological response in the context of non-chemotherapy or non-chemotherapy alone regimens, you know.
Do you have time or?
2 questions, yeah.
Okay, very, very quickly.
So, I am the chair. Let's do our job. Just go ahead.
Okay, thank you. Giuseppe Procopio, medical oncologist, Milan. My question is for Alessandro. Thank you very much for the overview of the most important topic of this year in renal cell carcinoma. My question is, how do you look at the treatment in adjuvant setting with Pembro in high-risk patient having non-clear cells histologies, like papillary? In clinical practice, do you consider this suitable or not?
That's a difficult one. So what we do is to try to select candidates based on different adverse pathology following nephrectomy. And in our real-world data, when we focus on the most relevant predictors, lymph node invasion is invariably one of the features that support the indication for that. And we know that this is a feature that is more common in papillary, so my take would be yes, but I don't have specific data to answer to your question. It's always, we know that this is always the issue in renal cancer and how to deal with the other option. But I would say yes in case of lymph node invasion.
I'll run out of time, but very quick comment on Fernando's great question, and Andrea, I think you answered it perfectly. So the Niagara data, it's a very interesting data set. It has many limitations, right? Based on the design of the study, you cannot tease apart the neoadjuvant and or the adjuvant component. Do you need either? Do you need both? A long discussion, but I think until we identify better biomarkers to select patients for the adjuvant therapy, for the moment, with all the imperfections, limitations, and caveats, I would personally follow the perioperative paradigm. And yes, we're going to overtreat some patients and there's toxicity risk, but we need to know better about who needs treatment. If you look at the breast cancer similar trial, Keynote 522, that was presented at the same presidential symposium at ESMO this year, they had much longer follow-up. And they had a similar design, chemo-pembro, neoadjuvant and pembro adjuvantly. And they couldn't tease out years later whether the PAT-CR subset needs or not pembrolizumab. We're going to see some very interesting data at ASCO GU coming up in the next couple of months that may inform this dialogue. Assis?
I have to make one comment because I think we are being overrun by our medical oncology colleagues. I think the Niagara trial in some ways takes us away from personalized medicine. We're throwing everything at the patient, not really personalizing it to the patient. And although I recognize the effort gone into the trial, I personally think that that trial is leading us down the wrong road. We need to go back to our attempts at personalizing, not throwing the kitchen sink at every patient all the time. And if you don't know the contribution of components and you throw everything at the patient, you have PAT-CR that doesn't really fit in with the others as you showed, I think we're going down a rabbit hole where we should not be. So I recognize the trial, but I don't follow the paradigm.
Okay. I perfectly agree, Ashish, so don't worry.
Okay, I guess we need to wrap up this session. We are running out of time. Shouldn't we go on?
Yeah.
Okay, but anyway, as an immunologist, I'd like to add a comment on the question that Andrea raised on the pathological complete response when you compare immuno versus immuno plus chemo, right? What I think is that you always have to think that when you add immunotherapeutics, you raise a memory immune response in patients. So pathological complete response is not enough. You need to look forward to see what happens in the next weeks and months and years in these patients. Okay, anyway, thanks to everybody in this room and the speakers for this fantastic session, and we go on for the next one. Thank you.
So Francesco De Cobelli, Arturo Chiti, and Nadia Di Muzio will chair the next session, which is open to the overview of the academic partnership, please.
Ciao Andrea, grazie, complimenti.
Ehi, ciao.
Grazie, grazie.
Ma adesso
Ma nel senso che ha già preregistrato o è presente? Sì, sì.
Uno ha sbagliato, uno di quelli che doveva andare alla cena di qui, ha sbagliato e è salito sul pullman del
Eccezionale, eccezionale. Va bene. Vai, presenta lui la session. No, tu presenti la session, tu presenti... io presento Arturo.
Good morning, and I'm pleased to be here chairing the second session of today, which is going to be focused on the overview of the ongoing academic partnerships. I am Arturo Chiti, nuclear medicine physician here in this hospital, and my co-chairs are Professor Di Muzio, the radiation oncologist, and Professor De Cobelli, radiologist, again here at the San Raffaele Hospital. So I will leave to Francesco to introduce Nadia to introduce the first speaker.
I know that the Professor Schwartz is not here, but there is a connection, I don't know, but I want to introduce, it's my pleasure to introduce Professor Lawrence Schwartz from Memorial Sloan Kettering Cancer Center, and he's the chair of the Department of Radiology, and his areas of expertise are oncologic imaging, including CT and MRI, validation of imaging biomarkers, and medical informatics. Presently, he serves as the chair of the Imaging Committee of the Southwest Oncology Group and of the Alliance for Clinical Trials. He's a founding member of the Quantitative Imaging Biomarkers Alliance, a quantitative imaging network, and he also serves on other national level boards dedicated to cancer and its research. I don't know if the connection is ready.
And you, are you able to hear? Okay, great. One thing, it seems that the host has disabled screen sharing. If we could turn on screen sharing, that would be helpful. Okay, I think you can see my screen now. Well, thank you very much for the invitation to speak. Unfortunately, I was planning on coming but I couldn't make it, and I look forward to meeting you all in person. So I'll discuss some work that we're doing together in artificial intelligence to predict the response to neoadjuvant therapies in muscle-invasive bladder cancer. But first begin with a brief overview. So certainly we're aware, and we've already actually heard about the recent advances in multimodal imaging, which really is in fact changing and impacting management in bladder cancer. While CT is the imaging modality that has been standardly utilized, MRI is clearly emerging as the modality of choice in bladder cancer because of the superior soft tissue contrast, the ability to differentiate the bladder walls, enabling accurate assessment of the depth of tumor invasion and extravesical extension. And also, we're implementing multiparametric MRI using T1 weighted images, T2 weighted images, post-contrast T1 weighted image, but also diffusion weighted and dynamic contrast enhanced imaging. This multiparametric MRI really is able now to acquire both anatomic and physiologic images for qualitative evaluation and allowing for measurement of model-based quantitative parameters. And it's these quantitative parameters that I think really are going to be differentiating for us and for you in the future. So you're also all familiar with the excellent implementation of the VIRADS, a validated qualitative, we can call it semi-quantitative tool for local staging of bladder cancer. And this has contributed greatly to the standardization of the workup and disease management. This criteria calculates a semi-quantitative score for each MRI sequence that represents the overall likelihood of cancer invading the muscle and beyond, from 1, highly unlikely, to 5, very likely. An example of ours from a review article that we published last year, looking at the axial T2 weighted images where the bladder, the urine is bright, the tumor is heterogeneous and dark. You see the axial T1 weighted image, the diffusion weighted image, the apparent diffusion coefficient overlay map, and then the post-contrast, as well as the ability to acquire multiple planes, and here clearly visualize a score of 5 with extravesical invasion. Now, the areas that we're focusing on, in addition to optimizing image acquisition and using several techniques for doing that, is more along the lines of quantification. So 2 areas of quantification. First, radiomics. I show this slide. It's a term that's relatively new now. It's a term that's very popular in the imaging literature, but we do indeed have some limitations with it. Let me first explain what it is. It is the ability to extract quantitative features from medical images using data characterization algorithms, which have the potential to uncover disease characteristics that are actually difficult to identify frequently by human vision alone. Now, I'm going to show several examples so that radiomics is not in a black box where we actually can see it. And here's the first example. This is a very old study now, 20 years ago, the first targeted therapy, Gleevec in GIST. And what people were seeing is this tumor heterogeneity at baseline basically disappearing. The tumor was becoming necrotic, so to speak, homogeneous. And what was attempted to do here was to qualitatively analyze this. And again, that actually worked, but it was not really reproducible. What is new in radiomics, and this is an example, again, where we see what we like to call, but the pathologists may not like us to call, simple necrosis in the tumor, is the ability actually to quantify these changes. So here to see from a successful treatment to an unsuccessful treatment, here the changes in tumor as it evolves over time without changing in size. So again, like we've seen, including in bladder cancer, the difficulty of a RECIST type score measuring simply a tumor diameter to accurately assess response and accurately assess certainly pathologic complete response. The second thing that's changed with radiomics is really our ability to create a link between molecular diagnostics and diagnostic imaging. Early on in the identification of tumor mutations, what was identified here in this example in lung cancer was the fact that many of the EGFR mutant lung cancers were, for instance, ghosted. They weren't as dense. Now that's probably the most qualitative term that we could possibly use in imaging. And I don't blame many of our clinical colleagues for not liking their radiology reports when they had the word ghost in them. So instead, many of us turned this actual feature into a quantitative scale where we're able to segment, just like we do in bladder cancer, the entire tumor, but then differentiate those components within it based on ground glass opacification, and clearly seeing a link between the appearance of these tumors, the imaging phenotype, and actually the genetic mutations and the driver mutations within these tumors. We've done that not only at baseline, but we've also done that, and this is what we hope to apply in our bladder cancer series. We've done this at a change in radiomics, or the so-called delta radiomics. Here, where we see not only size correlating with the successful therapy and the response and overall survival, but we also see a texture feature here, delta Gabor energy, independent of tumor volume, highly correlating with the EGFR mutation. So that's enough of kind of the background of part of what we want to do. And then here's our radiomics approach. So it of course begins with the image, and we try to standardize these images as much as possible. We then go ahead and segment the images and the tumor, and then we extract the features from those images. There are many, many types of features that we extract. What I will stress is that we try to limit the feature selection to be robust, to provide valuable information, and obviously prognostic information, and we reduce redundancy as much as possible so that the feature set ultimately is going to be of limited features, so that hopefully they will be intuitive, not only based on the image, but based on our understanding and our correlation with the pathology. And then, of course, we develop the model both in a training and, extremely importantly, in a test cohort and a validation cohort. So the radiomics literature is already filling up. These are recent studies from 2019 onward, looking at radiomics in bladder cancer. You notice, however, the limited number of patients. Some patients and some of these studies actually have very, very small validation sets, which is probably the greatest limitation of the imaging literature throughout radiomics, but especially in bladder cancer. Hopefully, groups like ours here can overcome this with sharing of data, with pooling of results, and really coming up with optimal methodology, including imaging, for evaluating tumor response. So one nice paper looking at radiomics-based models for predicting pathologic complete response here looked at 477 patients. A large number were excluded. There were 235 patients. And in this, the ROC reached a value of 0.85 in the test. And in the validation set, I believe it was 0.75, looking at 6 features that were selected by a random forest classifier. These are intensity-based features for the most part. But again, I believe this literature, and I believe that this can be generalizable and further validated and used in clinical practice. Now, what we've done is develop a tool. We're calling it BLADE AI, Bladder Multiparametric MRI Evaluation Routines, and an AI toolbox. What's nice about this tool is that it uses both deep feature analysis as well as model-based analysis. We're publishing on this toolbox, and we're going to make this toolbox available, through GitHub, most likely, for anybody to use, or we're happy to collaborate with others on data sets that they may have to develop or to validate further feature selection, classifiers, and statistical analyses that will allow us to generalize some of these algorithms and feature sets so that we could all use them. You know, in this collaboration, and this has really been a wonderful collaboration with our colleagues, Giorgio has reviewed many of the ROIs, regions of interest, done by some of our fellows who are doing this in a semi-automated way, the tumor segmentation from the pure data set, and we're in the process of investigating radiomics, deep features, diffusion-weighted imaging, DCE, and we're going to all put this together to predict path CR, to predict outcomes, overall survival, and restaging. And we'll be using this Blade AI tool to do this. The main purpose, really, of the Blade AI tool is to develop a platform that we could all really utilize. Of course, that tool would have to be validated, but it's using standard models. And once validated, again, this will take out the kind of the area of doubt or question about the image analysis, and then we could focus really on drug discovery and patient care. So an example, just one example from the pure data set, excellent image quality. You see the T1 weighted images, the T2 weighted images, the post-contrast, both at baseline, that's time point 1, at time point 2, the follow-up, the first time point, and then you see really here on the post-contrast, probably the greatest change, as well as on the apparent diffusion coefficient overlap map that we see here, that's color encoded. You also note on this, obviously, that you're all familiar with, both in clinical trials and in clinical practice, the difficulty in reliably and reproducibly measuring these tumors without accurate segmentation. And these are our internal data sets that we're using for early testing and validation. Doctors Go, Hikmet, Jonathan, you know them, many, I think several will be speaking tomorrow, but these are the data sets that we've collected as an individual institution. Again, extremely helpful in the development both of the toolbox as well as in the development of early signatures, but again, really cannot be utilized without multi-center clinical trials, independent data sets to validate. And really that's what we look to do with this group and beyond. So of course, you know, as has been done, you know, in other tumor models, to begin with histopathologic correlation. And these are multiple examples from our independent, from our single site data sets where we're doing automated and semi-automated tumor segmentation, looking at staging, looking at the different semi-quantitative, but as well as qualitative, semi-qualitative, as well as quantitative scoring to make this pathologic radiologic correlation, both in common and less common tumors. Hikmet and Amita Dave are leading these efforts, and this is working out really, really nicely with these whole mounts simulations with the imaging. In this cohort of neoadjuvant therapy, here's our workflow for the statistical analysis, where we're attempting correlations with path CR, overall survival, and recurrence-free survival. These are the different techniques that we're utilizing. I'm less familiar than our statistical colleagues with some of these, but the idea really is to reduce feature redundancy and to make sure that with the large numbers of features that we actually study from imaging, that these correlations are actually meaningful. Here's our patient cohort separating characteristics by complete response, partial response, and no response. And again, you see in these two statistical tools, the Minimax concave penalty and the smooth clipped absolute deviation, that grayscale, gray level coherence matrix, the so-called GLCM imaging feature, as well as diffusion entropy. Both of these features measure tumor heterogeneity. They measure the relationship of the pixels with each other. In cases where the gray level coherence matrix change is great, for instance, in a delta analysis, you could actually see that, but in many cases you can't. So again, these are examples that we really have to validate in multi-center clinical trials. And here is our correlations with overall survival. This is very, very preliminary data, but you see the number of voxels, so basically the size and the shape and the eccentricity of the tumor, its border with the bladder wall, and the extent does correlate with overall survival. And this is the corresponding heat map of this. So then to move on to our multiparametric MR in the age of artificial intelligence. Now, we've already heard a bit about that in prostate cancer. And really, I will say that this is an area, one of the few areas, quite frankly, in imaging, despite the hype about imaging and artificial intelligence in prostate cancer, that this has really made a difference. I'll characterize this difference a little bit differently than we've heard. In clinical practice, in my practice, we actually read many, many outside studies, studies performed where patients are referred into Memorial. I will say that in the last 2 years, we've actually seen a change in the quality of the outside reports based upon the use of artificial intelligence at tools that better characterize the lesions and better characterize, for instance, in prostate cancer, the PIRAD scores. I view this as a very, very positive development. It almost equalizes the playing field across and ultimately will lead to better diagnoses, more standardized approaches, and less heterogeneity in interpretation. And we see this here in the AI approaches as well. Applications in AI for bladder cancer in tumor segmentation. I have no doubt that this is going to continue to get to be improved. You see here the use of UNET in many of the studies. We're going to see other algorithms, some of the newer AI techniques are going to be utilized here as well for tumor classification and for denoising, where in fact multiple different MRI techniques can actually be made to look much more similar from a quantitative standpoint so that we can interpret results across centers even better. So here's, again, I just show you one AI example here where this was a multitask deep learning approach based on the T2 weighted images, which we know are most frequently extremely helpful for predicting muscle invasive bladder cancer. And this model, and again, this is quite preliminary data, I would say, reached an accuracy of 0.91 in a retrospective test, and actually very similar 0.923. I always worry about that in the validation test. However, in the multi-center data, that fell a little bit to 0.84, which is not unexpected and still represents good preliminary data that needs further validation. So I'll conclude with this. How are we going to maximize the impact of imaging? Well, all of our signatures that we develop collectively really need to be validated. They need to be generalizable. They need to be deployable. When I say deployable, I mean for people throughout the world, throughout the radiology and oncology community to be able to utilize this. This is why we're proposing certain common tools that we give out for free. We'd like them to be intuitive. So some of these kind of black box approaches that use 20, 30, 40 features to come up with a composite, I'm really less in favor of, but rather a small number of features that do a better job than we're doing today, I think is optimal. This could be done on conventional imaging or advanced imaging, but also it needs to be combined with tissue and serum biomarkers, which I'm sure we're going to hear more of. And then what's very important is to socialize these results, to allow them to be redeployed and reutilized. I do think that new AI methods may have a significant impact both on diagnosis as well as therapeutic protocols, including these methods in testing new therapeutic protocols. especially in the neoadjuvant setting, in these window of opportunity studies, pre-therapy, post-therapy, post-definitive surgery, or rebiopsy are absolutely golden opportunities for us. And hopefully we could do this more. Clinical studies and trials may benefit from these new AI techniques and potentially improve quality of life, as I'm sure we'll hear about further. Thank you.
So thank you, Professor Schwarz. I think we can start with discussion because you are online. So I think that if there are any question from the audience, so please, the microphone over there.
Thank you so much, Petros Grivas from University of Washington. Great talk and fantastic team there at Memorial with Jonathan and others. My question to you is, we have this discussion even in our center about how to optimally and efficiently make the slides digital, right, for broader review. Any comments on the requirements, equipment for a more, let's say, universal way to digitalize the slides that can be used across centers? As you said, in an intuitive and kind of democratized way. Thank you so much, and congratulations.
Yeah, so that's very important. And, certainly the age of data sharing, I wish we did as much data sharing, frankly, as we talked about it, or talked about the importance of it. Unfortunately, government rules have limited this. There's a lot of work now being done in the imaging field in federated learning, where images don't have to leave a given center, and they can still be shared across centers. So, that's one approach. Our approach has been really much more kind of brute force, combining, especially with clinical trials, where the imaging is already being collected, or frequently is already being collected, or can be collected, at small incremental costs, and then have that data being shared either in the US on some common platforms, for instance, that the NCI has, the clinical trials, networks have common platforms that we could use. And, utilizing those, we really do hope to be able to, share the data more and have others post data as well.
Larry, a wonderful talk you provide, and I think all of us are very, very intrigued with where AI is going and how obviously it's going to sort of be the next evolution, how we refine our prognostic models, how we stratify patients. I think where the challenge is, I think at many of our institutions, is obviously you need very large data sets of high quality data to really develop sophisticated, I would say very accurate models. But also the challenge is, I think, to what Shilpa will be speaking to, is how applicable are these AI models across healthcare systems, patient populations? An AI model that we develop in the United States, is it reflective or will it be relevant to what's being done and seen in Italy or in India? So any comments related to generalizability of some of the AI models, and obviously how big is enough related to developing, I would say, sophisticated, clinically appropriate and actionable type of models?
Yeah, so that's our greatest challenge. So I'll break it up in a few bits. So first off, beginning with the data collection, and beginning with the kind of the reliability and reproducibility of the initial data sets, we really need to overcome that. We need to overcome that in two different ways. One is to more standardize, at least in imaging, the image acquisition. And that can be done. That hasn't been intuitive in the imaging field, unfortunately. As you know, our reporting has been, quite qualitative, for a long period of time. And, and I use this term slightly pejoratively, we've tried to create pretty pictures. Pretty pictures are important, but quantitative pictures are equally important. So we have to make that change. I think once we, and we are making that change. I think, the BIRADS and PIRADS score in GU oncology really has helped a lot. I mean, it really has. Now, you could take that bit and then expand it. And as I more than alluded to, I think we will have accurate AI for tumor segmentation, for instance, for scoring, as an example. So then you take out that subjectivity. And then you have to bring in then the clinical aspects, which you know, is going to take all of us to really work on you know, making generalizable and meaningful. Now, you know, the beauty of this, however, is that you know, if we build these models, right, we can continue to refine them, and we can continue to allow, you know, further improvement of them in certain populations. So, you know, I'll give you a completely non-oncologic example. And, you know, for years, radiologists have been measuring bone ages in hands in children. And these are models that actually had not changed for about 60 years. They were based on a population of children in Ohio, and they were attempted to be used globally. Now, that is absolutely absurd, right? So anything that we do in an AI manner actually improves upon that. With generative AI, I believe that we're going to be able to start with standard models and then improve that, be it in a population, be it in an individual center or in an individual trial, and tweak things, you know, over time. So I think that you know, there is a lot of potential here. There are a lot of potential pitfalls as well, and you've pointed out, you know, the biggest ones that we have. But hopefully, they will become actionable in the near future.
Yeah, I just have a very quick question. This is Niraj Agarwal, medical oncology. So first of all, comment on Phil's comment, ChatGPT or AI. Maybe this will allow more easy incorporation of AI-based technologies across the world, may actually help disparities rather than increasing disparities. So Dr. Schwartz, a question for you. What do you see the role of ChatGPT, something which is so widely available? We, in the clinic, we have to analyze bone scans of prostate cancer for high volume versus low volume disease. So we recently, is a small 100-patient data, not much, for GeoASCO. We looked at 100 patients. We put the bone scans on the ChatGPT, and ChatGPT was pretty good about telling who has high volume disease versus low volume disease. So just a quick question for you. Where do you think the role of ChatGPT, how it is going to evolve over next, say, 3, 4, 5 years, especially from the perspective of residents and fellows, and for us who are not radiologists?
Yeah, well, you know, hopefully ChatGPT or tools like that will be incorporated into our practice. For resident and fellows, you know, it's very interesting. We're talking about that, you know, a lot, specifically in imaging, because I think it's going to change the way we train the next generation of radiologists, dramatically change that. So I think there is an evolving role. I think it's yet to be fully determined what it's going to be, but it will be interesting to see.
Dr. Professor.
Story for with Larry. It was Larry. It was Christmas Eve of 2012, I think. I was working on. I have to tell them. I was working on the Pazzopani database, Pazzopani monotherapy in urothelial cancer, the Lancet Oncology paper, and he was reviewing centrally, reviewing all the scans, you know, all the CT scans. He was working on the Christmas Eve. And I was at work and just received the reports of the scans that he reviewed, and he had 2 more PR as compared to local assessment, you know. So you made me the biggest gift, you know, for Christmas at that time. So I cannot thank you enough. So we are deeply miss you. So congratulations for our for this thing for sure, and for everything that you are doing. So very briefly, 1 minute, do you see any major difference when looking at the AI development in the Pure One in immunotherapy setting as compared to your database with chemotherapy? Is there any impact for immunotherapy on the AI assessment? Thank you.
So I think there are going to be both similarities and differences, and it's too early to tell yet. I think that the good news very quickly is that the degrees of freedom on an image like an MR or a CT scan, unlike molecular imaging, unlike more functional imaging technique, is relatively low. And it's also a downstream biomarker. So I do think that it can be more generalizable. And that has both advantages and disadvantages. So I think it can be generalizable across therapies and also, but early on in the assessment, there may be some differences. So that'll be what we see next year. And like I told you in 2012, luckily we're not testing the radiologist, we're testing the drug. And that's the most important thing, you know, to get the most accurate results. And again, that's what we hope we could do with imaging with all these new techniques.
Professor Schwarz. I have a question for you. Thank you for your excellent presentation, first of all. But as you know, the main barrier to the integration of artificial intelligence into clinical practice is the need for clinical validation of initial proof of concept studies. And another barrier, especially prominent in radiomics, is the issue of reproducibility. Sources of noise and variation are introduced at various steps of the radiomic pathway. For example, differences in the scanner type, reconstruction parameters, and acquisition techniques have all been shown to affect radiomic feature, reproducibility, and model performance. So, given your expertise and your vision of the state of the art in these areas, how do you imagine that these barriers may be overcome? And finally, how optimistic are you regarding our potential progress in the near future? Thank you.
Yeah, so that's probably the most important issue that we face. And I'll tell you very, very quickly, a story about a paper that we ended up publishing, but not the initial paper. So we looked at a signature. We tried to develop a signature for overall survival in renal cell cancer. And we used the NCI database for that. And we did, a radiomics analysis. And then we subsequently did a much more unsupervised AI analysis. And we had developed a feature. We had started writing up the manuscript. And then when we did the AI analysis, where we really looked at everything, on the images, the feature that popped out as the highest predictability of overall survival was the slice thickness of the CT scan. And boy, that had us worried. And basically what we were measuring was a heterogeneous group of image acquisition on the NCI data set. Those patients that had very thin CT slices, which were relatively noisier, were earlier stage patients. The study wasn't well controlled. This was just at the very beginning. So, your point is extremely valid. I think there's a few ways, to overcome that. First, there is a cohort of radiomics features that are highly reproducible across the spectrum of CT scan manufacturers and image acquisition. Two, over time, if there's a need, and I think radiomics will give us the need, we will better standardize this. Certainly, this has been done with other biomarkers, and many of you have published, those papers with ctDNA and other types of standardization. And then the third, there are some techniques, combat techniques specifically, which can harmonize across sequences. But until we do this, you're absolutely correct. these tools will not be broadly applicable in the clinic.
So thank you so much. So we can move to the next presentation. Professor Arturo Chiti, who is the chair of the Department of Nuclear Medicine here at San Raffaele Hospital. So please, Arturo.
Thank you, Francesco, and I want to thanks a lot Andrea Necchi, Francesco Montorsi, and Alberto Briganti for inviting me today, and you all for being here. So today I'm not giving you a talk like my colleague, a radiologist, but I'm on the other part of the field, because I will be talking about therapy. So why are we getting here, and why nuclear medicine and radiopharmaceutical therapy has been now introduced into the therapeutical approach in oncology? So this is, as you see, what has been happening in the last year, besides the fact that many academic breakthrough has been brought to the market, then there is a big interest by the industry. And the particular interest is nowadays derived from the fact that we moved from treating rare cancer, like thyroid cancer or neuroendocrine tumors, to treating prostate cancer, which is definitely not a rare cancer. And you know, nowadays there is a lot of money going on, and luckily a lot of industry has interest in putting this money in clinical research. So this is why I'm today talking about ongoing clinical trials. You know, I'm not going to talk again on what we have. Now there is a radiopharmaceutical, which is Pluvicto. There has been a study published. You see now it's on the market in the US, and there is a lot of interest there. It's going to come in Europe, hopefully soon. You know, from this point of view, Europe is definitely not as fast as the US, so we are still struggling to have this radiopharmaceutical in this country. But so what are we expecting to have from the clinical trials? As always, we have challenges and perspectives. Some of these challenges are, of course, in common with oncology, because this is an oncological treatment. But some are more technical, related to the fact that, yes, these are pharmaceuticals, but they are radiopharmaceuticals. So there are some, let's say, slight difference from a technical, from a pharmacological point of view, not from the clinical point of view, but there are some differences. Of course, we have the target expression. We cannot treat all the patients with the same drug. Luckily, we can see what we treat, and then we will discuss if and when this will be a real advantage. Then we have the problem of micrometastasis, something that we don't see and we don't know if we can treat. And of course, then radiations, they have an impact on the immunological landscape. This has been demonstrated with external beam radiation therapy, and we have hints that most probably will work also with radiopharmaceutical therapy. Of course, then there is the lesion heterogeneity. We have some ideas on how to tackle that. And radioresistance, of course, and then clinical setting and what we call underdosing. That means giving the patient not enough radioactivity for treat his or her disease. And the perspectives are the indication. Professor Briganti already mentioned that there is the need to use these radiopharmaceuticals early in the clinical setting, in the clinical pathway of the patient. Again, this is an historical reason. Nuclear medicine comes always as the last tool to treat the patient when the oncologists say, okay, we don't know what to do. Andrea Necchi and Dr. Procopio come to me and say, okay, I don't know what to do, let's do something radioactive. So this has to be changed, and there are some trials that are going in that directions. Of course, then combination therapy, they will be the real option for our patient in the futures. Many ligands, we will see there. And then this is really technical radionuclides and the dosimetry application. So there are many fields that we can improve, and you see here some of that. We'll just listen to a very interesting talk about radiomics, so on what we can do on the imaging part, because you don't have to forget that when we are treating patients with radiopharmaceutical, we do imaging before, and there is a lot of information there that we can extract with AI. And of course, we can use different radioisotopes, and we will see how this might have a change. But then what has really changed the landscape is the biotechnology availability of all these molecules. So we have now most of the radiopharmaceuticals that are based on small molecules or peptides, but as you will see, there are also the full antibodies that are back, because they might have some advantages. Dr. Larker showed you something with girentuximab, which is a full antibody, which has some disadvantages, but also some advantages. And of course, then I already mentioned the fact that we are going to use these radiopharmaceuticals with, in combination therapy and also with immunotherapy. So what are the targets that we have? We recently generate an overview on the different targets that are available, and you see, and you will see in the brief overview that I will share with you regarding the ongoing clinical trials, that of course prostate cancer is definitely leading. You see here how many different molecules, you know, most of them, they are PSMA based. But there are also other targets that we can use. And if you look at the numbers here, the difference, the number of possible molecules that are used for diagnosis and therapy, and if you then compare with what we have for bladder and kidney cancer, you see that there is a lot of room for improvement here. You see for renal cancer, we already talked about CA9, and we have PSMA for both the bladder and renal cancer. So this prostate-specific membrane antigen is not prostate-specific, maybe luckily for our patient. So let's give it the very first introduction on combination therapies. Of course, what we can do is to upregulate PSMA expression. We are talking about, of course, prostate cancer, but there are trials also on the use of PSMA. There is actually one trial in kidney cancer. And of course, since we are targeting mostly PSMA with different molecules, but again, the target is still PSMA, we like to upregulate PSMA expression, particularly in those cancers that they might not express PSMA in very high. And of course, this is very early, but we would like to see how we can induce and modulate immune response, and of course then have a combination of cytotoxic effects. There are many trials. We already talk about the ENZA-Ps that has been very successful, but you see here that we have, of course, standard of care, enzalutamide, the ENZA-P, and then also trials combining radiopharmaceutical therapy with external beam radiotherapy, and also the external beam radiotherapy and androgen deprivation therapy. Many other trials are using cabixacital, olaparib, pembrolizumab, and other molecules in order to see if this combination will be a benefit for our patient. Of course, we have to wait for the data, but there are already data with some molecules that indicate that there is the rationale to have synergic effect with these radiopharmaceuticals. We can also use different targets, although PSMA is definitely the mostly used target, and it has a rationale. We can work to have other targets. Of course, the first steps is to identify a target and then to see if we can have a molecule that can bring some radioactivity on the target itself. But as I mentioned before, the real advantage, so what we really benefit for in the last year is the biotechnology capacity to produce these very highly selective molecules. And you see here, this PSMA INT is, let's say, almost the same of the PSMA 617, and this is really pharmaceutical that is going to be in the market, let's say, very close. This is the full antibody that I was mentioning before, this rosapatamab, that might have some advantages related to the fact that the full antibody stays more in the bloodstream. So this means that you can reduce the amount of radioactivity given to the patient, but then the targeting, it really requires a lot of time. So we don't know. We will see again. We have phase 3 trial here. And then we have other targets that are expressed, and they are more in an early phase. You see phase 1, phase 2 studies, but we don't know what is going to be the efficacy, because we have to remember that in order for radiopharmaceutical therapy to be effective, most of the time we do need the target to be internalized. This is the success of the peptides as small molecules that has been put on the market in the last years. The big molecules or molecules that cannot enter the cells, sometimes they tend to detach. And in order to have a cytotoxic effect, the radiation burden has to be not only attached to the cell, but also has to stay there for a reasonable amount of time. And you see here other targets like the gastrin-releasing peptide receptor or neobombazine. So there are many radiopharmaceuticals that can be used to target, and also I would like to mention this FAP, which is very trendy nowadays, which is the fibroblast activating protein that is expressed on the tumor microenvironment. But for instance, here we have a huge problem of keeping the molecules and the therapeutic molecules on the cells, because they, again, this is an external cell target and they tend to detach. Very nice for imaging, but we still don't know if it will work for therapy. And then this is the most technical aspect. So, you know, we have, we play with different radioactive sources. There are those for imaging, these are for therapy. You see, we have these beta minus emitters that are particularly represented by lutetium 177. Then we have this alpha therapy, the alpha particles that have the big advantage of releasing a lot of energy into a very short space. This means that you can reduce the crossfire for the other organs, that most of the time is something that you don't want, but sometimes it might be useful. And you know, nowadays the most represented is actinium-225, but don't forget that in order to have these radionuclides available for the market, you need to put in place supply chains that are capable not only of producing but also of delivering these radiopharmaceuticals. And in this case, most probably in next year, you will see astatine 211. Why? Because it is easier to be produced and to be implemented and to use in the clinical practice. Then we have these OGL electrons, which are mostly promising for the small metastatic disease, and particularly terbium-161 is the one that is most studied. So what we foresee for the future, that according to the burden of the disease that we can assess with imaging, we can design clinical trials in order to use the most, let's say, efficient radionuclides labeled to the same molecule. So that means that one patient might be treated with lutetium 177 PSMA, and another patient might benefit more for an astatine or actinium labeled PSMA or even terbium. So there are, you see here, as I mentioned before, most of the radiopharmaceutical used now are labeled with actinium, but with actinium we still have a problem of supply. Maybe it's going to be solved, but this is the case now. And of course there is something going on with the terbium 161. This is something that I think it's going to be very promising. So the last part, the last two slides of my talk are related to dosimetry, in which we don't see any clinical trials, but this is very important. So what we are doing now is that we are using radiopharmaceutical with a fixed activity. So this is definitely easier also to understand from the pharma agency to have a fixed activity. So you just change from milligram to megabecquerel, and that's it. But doing this, we are losing the possibility to really perform the what we call personalized medicine. So we demonstrated with the VISION trial that a fixed amount is effective, but most probably sometimes we are underdosing the patient or we are overdosing the patient because we are not using the information that we have. So talking about the possibility to have the really personalized medicine, we can use dosimetry, and of course here AI is going to play the major role because we are not going to implement dosimetry in the clinical practice without AI. And there are several studies that are demonstrated, of course, not on the clinical trials so far, that it is possible not only to adjust the activity given to the patient, and talking about the dosing, but the real dose, not the activity that we can deliver to the tumor, but also we can really adjust the therapy using very specific molecules, different nuclides, and these models, we can adjust the therapy for each single patient. This is going to be tremendously difficult. Maybe we will never get there, because then imagine how you have to design all the organization to do this. But this is theoretically possible, and I think that it's correct that we aim at going that. Again, unluckily, nowadays, we don't have clinical trials on the use of dosimetry. So to come to an end, what we have today is that, of course, we have these biotechnological developments that are really driving the change. We can play with molecules, and this is something that we are not only doing in oncology, but also in radiopharmaceutical therapy. Personalized treatment, well, like dosimetry, is not there, because we are really, let's say, underusing the tools that are available. As I mentioned, prostate cancer is definitely leading the research, mostly because of PSMA. There are 2 studies on PSMA therapy in renal cell cancers, and no studies on bladder cancer, unfortunately, so far. Early use in the disease course should be promoted, because you know, nowadays it's after 2-3 lines. In these countries we are talking about to use Pluvicto as the first line, which is not going to be useful. And combination therapy, I wrote it's promising, but I really think, or maybe also believe, that it's going to be something very useful for our patient. And we will see how we can use all these different radionuclides for a better treatment of our patients. So thank you very much for your attention, and I will be happy to accommodate any question.
So thank you, Arturo. Very, very impressive presentation. So any questions from the floor? Here?
I'm not sure where the microphone is.
Yes.
It's coming.
Hi, everyone. Jeff Ross from Foundation Medicine and Upstate Medical University in New York. Wonderful talk. I have a question about renal cell carcinoma and PSMA imaging and PSMA targeted therapy with radioligand. Clearly, the renal cell, clear cell carcinoma cells are not expressing PSMA. It's the endothelial cells of the neovasculature, and a very high percentage of them are positive by imaging. And do you think that the therapeutic event might be by causing thrombosis of the neovasculature with the targeted therapy rather than actually hitting the cancer cells themselves and then causing ischemic necrosis of the tumor? And there's so many other cancers that have neovasculature PSMA expression, because as we learn from all this research, PSMA is a biomarker of the actual endothelial islands in the developing embryo, and that the blood vessels of tumors express it in a kind of a retrograde, primitive dedifferentiation. Feria, do you think it's going to work in kidney?
You know, my personal opinion is that no, it's not going to work. So it's really, so using PSMA therapy, we have used it for imaging, you know, but for imaging is a different job. But for therapy, I don't think that it will be successful. But there are 2 trials trying to do that.
Thank you.
Any other question? So I have a question regarding the personalized dosimetry. I think it's an issue because we learn from our experience in hepatocellular carcinoma and radioembolization that the results of yttrium therapy is depending on the personalized dosimetry. So do you think that the personalized dosimetry in prostate therapy, for example, will, let's say, change the results so dramatically as we have seen in the liver? Because, I mean, you said that there are no running trial on that, but I think it's one of the most critical issue in the success of this therapy.
Yeah, so thank you for the question. You know, so far we were not able to generate evidence for many of the tumors that doing personalized dosimetry is going to increase the survival of the patient, which is different from the brilliant example that you mentioned and with which you have experience in hepatocellular carcinoma. But anyhow, if you look at the marketing authorization of the few radiopharmaceuticals that are available, the only thing that they say is that you can reduce the activity if the patient has renal problems or something like that, which is, from my point of view, no sense, because then why you reduce in half, or why don't 25% or 30%? So we don't have evidence to say that we are going to change the fate of the patient using personalized dosimetry. But what is sure is that we have a tool that we are not using. And this is a pity. The real problem with personalized dosimetry is that you need skilled physicists to do that. And from an organizational point of view, it's going to be a nightmare. Because nowadays you have a patient to Pluvicto, you pick up the phone, you call a Novartis, and they send you a vial, and it's done. If you have to do the dosimetry, then call Novartis and say, okay, I need not this bunch, but a half for 27% or 145% more. So it's it's going to be difficult. So this is why most of the dosimetry studies that are published, they are based on in-house production of radiopharmaceutical. Having said that, yes, it's complicated, but life many times is complicated. I think that we don't have to give up. So it's something that we have to really try to implement. And I'm really happy that Professor De Cobelli mentioned his experience on how dosimetry can actually change the efficacy of a radiopharmaceutical therapy.
Short question. As I am a radiation oncologist, I want to ask you if in this scenario you can consider also radiation therapy in association with the...
Yeah, of course. There are some trials that are in prostate cancer that are putting together, let's say, different kinds of radiotherapy, so external beam and internal radiotherapy. Yeah, of course. So combination therapy can be an option.
Okay.
Last week, very quick question.
Very quick question. Great talk, Arturo. We're actually running a trial in Seattle for Heart Cancer Center looking at the epigenetic modulation of PSMA expression using an HDAC inhibitor, and we have some early data. The trial is ongoing. Any comments on that? You showed in your slide that the expression and overexpression is a goal. Any comments about the epigenetic modulation, with HDAC inhibitors or other strategies? Thank you for a great talk.
Oh, thank you. I have no direct expression, but experience on that. But I definitely think that from a theoretical point of view, it's going to be a great trial. So, the moment that we have this bullet that we can use, increasing the number of target cells that we can do, that we can really hit, it's going to be of benefit. And we have, on parallel, on another tumor, which is completely outside of the topic today, but on thyroid cancer, there are a lot of data that demonstrated that it is possible to redifferentiate and to have the expression of the symposium importer for the introduction of the iodine 131. So again, a different setting, but the clinical results might be comparable. Thank you.
So thank you so much, Arturo. Great talk, great discussion. And so we...
Ceci est une lettre pour toi, à la mémoire de notre amour, sur l'île magique.
You can relieve my pain. You can relieve my fear. You can relieve my soul. You can relieve my tears. You hold like you hold.
please take a seat. We are starting next session.
Can you please take your seats? Un po' basso. No. Could we ask that you please take your seats and also call in the people who are outside? We're running late. Parto? We should start. Okay, welcome back everybody. Yeah, okay. It's just 1 minute, just 1 minute. We'll just introduce you. So it's my great honor to be here today and co-chair this session, which will be great. So this will be the first keynote lectures session of today's retreat. My name is Rosa Bernardi. I'm a basic scientist. And I work in this institute, and I'll be co-chairing with a clinical oncologist.
Good morning, everyone. Welcome to this session. I'm Brigida Majorano. I'm a medical oncologist just hired by Professor Necchi. Very, very happy and very grateful to be here. This is my first San Raffaele Urological retreat. So I'm pleased to co-chair this session with Professor Bernardi. Welcome.
Okay, so we will have now 2 great talks, but by 2 amazing oncologists and physician scientists who will tell us all about emerging trends in prostate and renal cancer therapies. So we start with the first speaker, Professor Sumanta Pal. Please take the podium. Welcome.
Thank you so much. This is such a wonderful meeting, and I have to tell you that I just came to Milan with my family about 2 or 3 weeks ago. It's such a phenomenal city, and it's wonderful to be here now in a more academic capacity. So my task today is to talk about conquering renal cell carcinoma and really discussing the way forward. So Dr. Larcher gave you earlier this morning an excellent overview of key highlights in the field over the past year, and I'll just talk about maybe forward steps in terms of what we can do from here. This is an overview first of the adjuvant space in renal cell carcinoma, and I wanted to tackle this first. Dr. Larcher had highlighted the Keynote 564 study, which is on the top left, and that's a clinical trial that led to the approval of pembrolizumab, as he described. There are 3 other studies in this space, and for all the fellows and trainees in this room, it's probably not so critical to know them because they're all negative studies. But what I was going to mention is one study in particular, which I was involved with, looking at atezolizumab as adjuvant therapy. This is known as the Emotion 010 study, is not by any means notable for its results. So this study had entry criteria that were very similar for the most part to the Keynote 564 trial. But when it came to the underlying result, it was just dead negative. So we really saw no difference in terms of disease-free survival. How I think it helps us pave a path forward, though, is looking at this biomarker called KIM-1. So earlier in today's session, folks were asked about what they felt the most promising biomarker was in the field. This is something that my colleague from Gustave Roussy, Laurence Albiger, has presented from our study at ASCO this year. And KIM-1, as you can see in this volcano plot, really stands out as a biomarker that seems to be enriched in the context of disease recurrence. And when you look a little bit further, this is really the interesting part here. When you look at patients that are KIM-1 high, those are individuals that seem to benefit from atezolizumab. And the converse is actually true too. So if you see that patients have low KIM-1 levels, they seem to perhaps fare a bit better with placebo. That's maybe a bit more of a controversial statement. But nonetheless, I think KIM-1 is emerging as an incredibly promising biomarker in adjuvant therapy. And for the fellows in the room, for all the junior faculty, I mean, it would be amazing to see a study that uses KIM-1 as a potentially predictive and selection biomarker for adjuvant treatment. Nonetheless, as Dr. Larcher had highlighted, adjuvant therapy with pembrolizumab is really the current standard of care. That's based on this really incredible benefit in terms of overall survival seen in the KEYNOTE-564 study. Tony Choueiri presented this at ASCO GU last year, and it's since been published in the New England Journal. So, if I were to very quickly summarize the landscape of therapies in the adjuvant setting, pembrolizumab clearly is the standard of care. There are regimens like nivo-ipi and perioperative nivolumab that have been explored in the adjuvant setting. The challenge with those strategies really stand in the face of toxicity with nivo-ipi, and in the context of perioperative nivolumab, many issues with patient selection. I think those are kind of beyond the scope of this talk. But in terms of the way forward, I certainly would love to see KIM-1 utilized as a predictive tool for adjuvant therapy, and this is definitely an area of unmet need at this point. I don't know of any studies presently that are actually using KIM-1 as a selection biomarker for adjuvant. We could spend the entire 20 minutes talking about frontline trials in RCC. There's been this huge evolution dating back to about 7 years ago with the advent of nivo-ipi. But frankly, I think that a lot of these developments are well known to the audience in this room here. I will say that when I think about how to allocate therapy in the frontline space, I tend to lean pretty heavily on quality of life data. I will say that quality of life metrics are imperfect, and one of my former fellows, Chris Bergeron, is doing a lot to revise quality metrics for renal cell carcinoma. But if you look at the regimens that are currently available, nivo-ipi and cabo-nivo really seem to stand out from the standpoint of quality of life. And I will say that if I were to sort of offer my algorithm for managing frontline metastatic disease, it's pretty simple. Most patients in the frontline space who have good risk get cabo-nivo up front. If they have intermediate or poor risk, if I'm not considering nephrectomy, cabo-nivo is my standard. If it's a patient who's moving towards nephrectomy, I tend to favor nivo-ipi. So this is a very sort of simplistic overview, but that's the current state. Dr. Necki asked me to discuss really the way forward here. So one thing that I've been very pleased to contribute to is some knowledge around this practice of immunotherapy rechallenge. Immunotherapy rechallenge is something that we talk about a lot in the context of not just renal, but bladder cancer, lung cancer, et cetera. If you look at practice patterns in the United States, it's amazing how pervasive this is. It's almost like using trastuzumab in breast cancer. People hang on to immunotherapy in the second, third, and fourth line setting. So in this CONTACT-3 study, what we sought out to do was to test whether or not it would be reasonable to continue checkpoint inhibitors in patients that had received frontline immunotherapy for renal cell carcinoma. So this was a very, I would say, clean study in terms of the design, A versus A plus B, where you have a TKI plus or minus immunotherapy. And this study showed really no benefit with the approach of adding further checkpoint inhibition. So at this point in time, I would say that there's more harm than good from this approach. We did see added toxicity with the addition of IO. Certainly no benefit in terms of overall survival. This past year, Tony Choueiri and colleagues presented the results of TNEVO-2, which was a very similar effort to characterize the impact of continuation of immunotherapy, this time with the tivozanib base. Very, very similar results, I would say, with no real benefit with the addition of nivolumab to tivozanib in the second-line setting. So with all of this in mind, what's our next step? We've had multiple TKIs developed in renal cell. Dr. Larcher had highlighted belzutifan, which I consider to be at least somewhat vertical in terms of the strategy of blockade mechanistically. So I wanted to kind of focus the way forward here, first and foremost on microbiome and immunotherapy. And you're going to hear something about this from Dr. Disman, my superstar fellow who Dr. Necki kindly invited to this meeting. This whole focus that we have in my group was actually born out of a conversation with a biostatistician. One of my biostatisticians worked in the agriculture industry and came to me one day and said, look, Monty, we actually spend so much time investing in understanding the microbiome of chickens, of cows, right? Why don't we spend more time understanding the microbiome of humans and how that pertains to longevity and outcomes in cancer therapy? So about 10, 12 years ago, we started focusing on doing some basic microbiome work. But I think our focus really took off with this triumvirate of papers that came out in Science. These are all from different places. If you look to the left, this is a study that was done out of Dr. Kamat's group at MD Anderson. The paper in the middle is actually a paper from Gustave Roussy in Paris. The paper on the right comes from the University of Chicago. But they all came out simultaneously in Science and really suggested that the microbiome could be linked to clinical outcomes with immunotherapy in melanoma and lung cancer and kidney cancer. The results were all slightly different, suggesting different bacteria that would actually lead to a linkage to clinical outcome. And just to show you a snapshot of this data, and I focused on the RCC subset of patients here that were embedded within one of those science papers. If you look on the right-hand side, this tornado plot is actually something like what we see in the context of genomics, right? So, if you look to the green bars, those are specific bacterial species that seem to be enriched in patients who are responding to treatment. The bacteria that are highlighted in red are those that are negatively associated with response. So I thought this was really quite stimulating. And we started thinking about different strategies that we could use in order to manipulate the microbiome. So I always make sure that I show this picture after a snack break or before food is served, right? But this is the strategy of fecal microbiome transplant. So right before lunch, there you go, yeah. So this is a labor-intensive process, and I have to tell you that a dedicated cancer center like City of Hope, we're actually not really equipped to do this, so it really requires a lot of robust GI infrastructure. But basically, you take stool from donors, it could be a single donor, multiple donors, and you administer this to patients, and the impact on clinical outcome has been pretty dramatic in certain cases. So these are two papers from Science. The paper on the left is from colleagues in Pennsylvania, the paper on the right from colleagues in Israel. And if you look at these two data sets that are based on melanoma, you can see that if patients are re-challenged with a checkpoint inhibitor, and in the context of the patients on the left, these are patients who had primary progression, so they're burning right through checkpoint inhibition. And if you give them a fecal transplant, you can actually see that at least some patients, not every patient, but some patient actually has a distinct and protracted response to therapy, which I thought was quite fascinating. I'm going to get back to the concept of fecal microbiome transplant later, but as I'd mentioned, it's something that, at least at our institution, we haven't developed the technical capability of doing. We've taken a different approach looking at live bacterial products, and I give Nazli a lot of credit in really shaping this program at our institution. But if I were to explain this very simply, we've looked at a product called CBM588. So this is a strain of what's termed Clostridium butyricum. It's a bacterium that actually deposits in the mouth as a spore formulation and only starts to proliferate when it gets into the lower gut. So if I think about simplistically how it works on the left, we think that C. butyricum replicates in the lower gut, starts secreting short-chain fatty acids like butyrate, and then you have proliferation of favorable microbiota. What I will say is that now we've done two studies in this space. The study on the left was championed by Nazli several years ago. The study on the right by Hediye Ibrahimi, one of my current postdoctoral fellows. And both of these studies looked at the principle of using a base of immunotherapy. On the left, Nazli's study had Nivo-Ipi, on the right, Cabo-Nivo. And what you see across these two studies is at least a signal of benefit, particularly in Nazli's study with Nivo-Ipi with CBM588. And when you look further at response rates, there's a very common signal here. If you look at the two bars on the far left and the far right, what you really see there is that there seems to be a signal of increased responsiveness when you look at Nivo-Ipi with CBM or Cabo-Nivo with CBM. So, these are two, I think, really important, very preliminary efforts. I always caveat this by saying that these are small 30-patient experiences. That being said, this is one of our first looks at the microbiome, and one of the things that we need to do is a big phase 3 clinical trial. So one of my dear friends and colleagues from Case Western University, Pedro Barada, is actually championing this study through SWOG. I'm very proud to say we actually just got our NCI approvals to carry out this phase 3 trial, which will look at a base of immunotherapy plus or minus CBM588. So look for this study in the relatively near future. We hope to open by quarter 3, quarter 4 of 2025. So we'll see how this goes. Beyond that, I think we've got to think of new ways to deliver CBM588. One principle with the microbiome is getting to that sweet spot in terms of dosing. So one of my junior faculty, Dr. Raffaele, is doing a study looking at dose escalation of CBM. That's a study that's ongoing at our institution. And just by show of hands, anybody here in the room hear of Camu in the past? A couple of folks who have been to my talks before, I think. But Camu is a South American berry It's actually something that I hadn't heard of before coming across this terrific paper in Cancer Discovery that I've highlighted here. And this actually shows that an extract from camu-camu can actually synergize with checkpoint inhibition. And this is what we might term a prebiotic. We think it modulates the gut in a manner that might increase proliferation of ruminococcus and other species. So we have an ongoing study looking at nivo-ipi with or without camu-camu. The study only has about 7 patients left to enroll, and we hope to report out late next year. I'd mentioned this concept of FMT, fecal microbiome transplant, and I view this as being highly supportive data. This was a study led by our dear Italian colleagues, Dr. Accavelli and others, and this Tashido study looked at axitinib and pembrolizumab with or without FMT, and this was just reported out at ESMO recently. I have high hopes that this will be published in an impactful journal. What we see here is that there's actually an improvement in their primary endpoint, which is one-year progression-free survival. So I think now we have some mounting evidence that manipulation of the microbiome works. Beyond the microbiome, looking forward, I couldn't help but just throw in some of my other personal interests here. So we have a really emerging CAR T program at City of Hope in solid tumors. And so one CAR T study that we looked at a construct called CTX130. This is a CAR T targeting CD70, which is a very pervasive antigen in renal cell carcinoma. And we did a phase 1 study that we reported out about a year ago now. And this actually showed some very early signals of promise. In contrast to many solid tumor CAR Ts, this study elicited almost zero in the way of toxicity. There wasn't a lot of cytokine release syndrome. We didn't really run into any macrophage activating syndrome or any of the things that you worry about in the CAR T space. We did see that there wasn't an overwhelming number of responders, but if you look at the patient on the top there in the swimmer's plot, that was actually one of my patients who actually remains disease-free 4 years now from the time of the initial delivery of CAR T cells. So I think there's probably a patient population out there that deserves this type of therapy. Right now, we're working on the next version of this, which is called CTX131 on the left-hand side, so we're enrolling patients to that study now. And it's so interesting. So Dr. Chidi gave this terrific presentation on radioligand therapy, and he'd mentioned CA9, and it got me thinking, especially after Dr. Ross asked his question around CA9 and its relevance and sort of targeting, PSMA, excuse me, and its targeting in renal cell carcinoma. So PSMA is actually an antigen, as Dr. Ross had mentioned, that's expressed quite widely in the context of renal cell neovasculature and the neovasculature of other tumors. So we have a CAR T construct, AB2100, that actually uses PSMA just to route the CAR T to tumor. And then there's actually secondary presentation of CA9 to actually latch onto the tumor cell and elicit cell kill. So this is an interesting phase 1 study that's ongoing at our institution. We have BITE studies looking at other, I think, interesting antigens for renal cell as well. So just wanted to give a glimpse of some of the stuff that we're excited about in particular. My summary is as follows then. In the adjuvant setting, I think that KIM-1 is a very interesting biomarker that could potentially guide therapy. In the frontline space, I really think that a long, hard look at quality of life is well deserved. I do think that the concept of re-challenge at this point in time is kind of dead in renal cell carcinoma. I love the idea of focusing on the microbiome, and clearly we need new drugs and other agents in this field. With that, I want to thank all of my collaborators, and I want to thank Dr. Necki for this brilliant invitation. I love the fact that you're highlighting your junior faculty, and these are pictures from a recent trip that we took to Milan as a family. Thank you.
So excellent talk as always, and I learned so much listening to you talk on this topic that it's really amazing. We've talked about this offline before, but just to share with the audience, I'm seeing a lot of patients that come into clinic and they're going on Amazon or somewhere and they're getting this probiotic or they're getting something, they're taking it. In the clinic, what are you telling patients? Continue, stop, potential harm, potential benefit? How are you addressing this in your day-to-day practice?
You know, actually, some of the data that informs my practice there comes from MD Anderson, from Christine Spencer and Jennifer Wargo, and they have this nice paper in melanoma that retrospectively looks at use of probiotics and actually fiber intake. The key message from that was that fiber intake, probably good, but general use of probiotics in a non-specific fashion, probably not good. So I ask patients to really exercise a lot of caution because we still at this point haven't optimized the dose of CBM-588. We think that there may be a deleterious effect from other sort of random probiotics. So at this point, I exercise a lot of caution in recommending anything there.
I admit I have to learn a lot from you, from the RCC guys. I'm here to learn for RCC. My question to you, I'm sorry if it's pretty much naive question, but what is missing today when designing neoadjuvant studies in the way we conceive neoadjuvant studies like in bladder cancer? Let's say for organ-confined tumors, what is the major limitation to you that's prevented us to get, since so far at least, important data from neoadjuvant studies in kidney cancer? Is there an issue of the clinical staging or a clinical model that is not shared in the community? What is your thought?
Yeah, and certainly I appreciate input from Dr. Briganti, other surgeons in the room, because I have to tell you, I think the answer here is actually pretty easy. I think it's a uniform definition of response. Because I've sat in a number of rooms talking about designs for neoadjuvant trials, and the thing we can't agree on is what defines an appropriate response to therapy. Tumor downsizing, is it an official RECIST-based CR? Is it, for instance, necrotic sort of appearance of tumor following initiation of a neoadjuvant TKI strategy? So at this point in time, there's no consensus in my mind regarding what constitutes a reasonable endpoint, especially for a small sort of pilot neoadjuvant trial. If we're talking about a big phase 3, which I don't know of any plans for that are imminent, you would look to traditional endpoints like DFS or OS, but in the context of smaller trials, we have no clue.
Monty, great talk. It's interesting, you bring up a point that's so relevant, right, is we're seeing these patients who are intermediate risk, some poor risk patients who have these dramatic responses to therapy. And obviously that conversation is always challenging, when or if you should ever operate on those surgical patients, right? Is sometimes they've had a dramatic response, the primaries has not responded like the other sites of disease, the patients are highly motivated, they clearly see my primary is still in situ, whether they're symptomatic or not, and it can be challenging to know when the trigger point of operating on those patients is. I saw a young 45-year-old patient with brain mets who had a phenomenal response. All sites of disease regressed. Now they're 2 years out. They're presenting with a 12-cent renal tumor. It's still enhancing. It's still viable cancer. And you sort of ask yourself, are you going to sort of burn down the barn basically by operating on those patients? And lo and behold, that cancer, which is essentially stable, is now going to regress. What's your thoughts on that?
And what systemic regimen is that patient on?
He was on Nivo-IP.
Yeah. So, it's interesting because I do think that in the current era, sometimes surgery for me in the context of metastatic disease becomes more of an afterthought, right? The goal is really to get them on effective systemic therapy and then think about the surgical decision at a later time. I will say that if I see a scenario like that where really it's just that kidney left over and the remainder of the metastatic response is phenomenal, I will encourage that patient to go to the operating room. One of the caveats, though, is if the patient's on a TKI IO-based regimen, I have been burned in that scenario where I take that patient off the TKI for 2 weeks before, 4 weeks after, and then boom, their disease comes right back, right? So, I think the reason I asked about the systemic strategy for your patient is that if they're on Nivo-IP, probably no harm, no foul taking them to the OR, but you could really run into a lot of risks with a TKI-based regimen. Just combining this with some of the themes from this morning, when I was listening to Dr. Larcher's talk, I will say that CA9 imaging is one of the things that I'm really interested in looking at in the context of this primary tumor response. Because I do think that if it can give some semblance of tumor viability, then it might guide whether or not you really need to intervene with surgery or radiation for residual disease of the primary site.
It was interesting when we did a study with Jason Abel as a cohort with Jose and others, and I think it was about 100 patients who basically had received IO combinations, and we operated on. And one of our take-homes of that study is 50% of those patients never got back on some form of therapy following subsequent surgical resection. and the morbidity of surgery is really quite low. You know, as we all hear these thoughts of like Cabo, for example, where you get these dramatic primary tumor responses and those surgeries are a little more challenging. That being said, those surgeries are highly feasible with really very acceptable morbidity, like you said, so it's always an important consideration.
Yeah, absolutely. I mean, it's interesting because initially there were these conflicting reports around. I saw your series, then I saw a series from Europe suggesting more of a desmoplastic fibrotic reaction around the tumor. I think, you know, the jury has kind of probably swung towards safety in this setting, right, of operating in these cases. Yeah, first of all, I always think of Dr. Procopio when I think about rare tumors because, you know, whenever people say to me, you know, you can't do a study in collecting duct or in renal medullary, you know, he's really done it very successfully several times now with, you know, initially his studies of chemotherapy and now targeted therapy in that space. But, you know, essentially, I mean, just to put it very simply, I think that we need to get these patients on clinical trials. I know that sounds very cliche. But at this point in time, you know, really stating that we have a standard of care based on a single-arm phase 2 study, no matter how good the data looks, I think is very, very difficult for me. So, you know, when I see a patient in clinic with papillary disease or translocation, et cetera, you know, we do have trials for that. So we have the Stellar 304 study, which is enrolling at many sites here in Italy as well. And the study randomizes to sunitinib versus XL092 plus Nivo. You know, some people say, well, why is sunitinib control arm? You know, to be fair, you know, when we did the PAP-MET study, we saw, looking at sunitinib versus Cabo, no overall survival benefit. If you look at the update that we just published in JCO, you can see the PFS benefits are pretty marginal, actually. So at this point, no true standard. I think clinical trials like yours, like the ones you're running, are the way to go.
Hi. Thanks for the wonderful talk and really interesting data. I had a question, maybe a quite naive question on the microbiota part of this talk. So you have all these beautiful data that are coming out about microbiota and the amazing effects it can do to tweak the therapy response, but they never find or pinpoint to a same single strand or probiotic. Are we acting upstream of a common pathway downstream, or how come do we always find something different? Is it different populations? Are we talking again about like geographical variations in the populations studied? And how can we standardize this to go further? For instance, also like fecal transplant with donor variability and differences in the donors.
Yeah, it's a great question. It's actually a terrific question. One thing that we started to talk a lot about in our group is the whole principle of false discovery, you know, because, you know, out of these big data sets that we have pertaining to microbiome, as you point out, and as I highlighted in my slides, you're coming up with different bacteria that might be responsible for an IO-based response in different clinical settings. You know, one thing that I think would help harmonize things is to actually report out false discovery rates. So beyond a p-value, there's the q value that we've started reporting in our papers, right, Nazli? And then the other thing that I think might help harmonize things is, as opposed to focusing on one bacterium, there's a recent paper in Cell from the Gustav Rusi group, from Zitvogel's group, that actually looks at a signature of dysbiosis. So this dysbiosis signature actually looks across multiple pivotal studies and has generated a common thread of bacteria, amounts to, you know, about a dozen or so species that together seem to define a healthy gut versus an unhealthy gut. And I think that what we'll probably find down the line is that, you know, maybe some of these microbiome-based strategies turn an unhealthy gut into a healthy gut. And I also think that that patient population with an unhealthy gut from the get-go are the ones that are going to benefit most from a microbiome-based intervention.
So thanks, Professor Pal, for this flattering intervention. It is now the time for moving from one giant to another. It is a pleasure to introduce Professor Agarwal from Salt Lake City with this speech about innovative therapeutic strategies for androgen resistance in prostate cancer.
I was telling Monty, like microbiome is going to be a parallel therapeutic universe So we'll talking to patients about kidney cancer therapies and then microbiome modulation for pretty much all cancers. So exciting. So let's switch gears. Where is that mic? Yeah. So let's talk about prostate cancer. So I was told by Andrea and team to talk about androgen resistance and how to mitigate, how to address androgen resistance in prostate cancer. So I have no conflict of interest in last 3 years. These are all industry funding to my institution. So I'll be talking about the advancements in 2 aspects. Number 1, attenuating or prolonging the response to AR. So how to delay androgen resistance, and then what to do once the androgen resistance has already kicked in. So let's talk about these new therapeutic targets. Finally, prostate cancer is catching up with bladder cancer, with lung cancer, and it's so nice to see so many new agents which are being approved. We just heard Capitolo trial is positive, so first time we'll have a drug available in the clinic for PTEN deficient patients or patients with PTEN deficient tumors, and we already have targets, other molecular drugs being approved for different targets in the coming years. So this is the snapshot for efficacy of PARP inhibitors, and we can see here, if you use them after AR failure or AR targeting failure, the most of the efficacy is for months. So 4 to 5 months, 6 months, 7 months, that's what we get for most of these PARP inhibitor monotherapies. How would you combine them? So if you combine them, can we delay AR resistance? We know there is a lot of cooperation between AR pathway and the HR pathway, and they crosstalk. There is a crosstalk going on. So for example, I talk to my patients, like if you are inhibiting AR, the PARP comes to the rescue of the cells. And if we combine them, and we saw with the BRCA trial, a small IIT studies we reported led by Maha Hussain, that if you look at the single-arm responses, abiraterone or olaparib, 8 months, and you combine the drug, the radiographic or progression-free survival was 39 months. So those were striking results, even though it was a small study. And we saw the phase 3 results from the multiple phase 3 trials. This is just a schema, the summary of all these trials. And what we saw is remarkable improvement in radiographic progression-free survival with all these combinations compared to monotherapy with enzalutamide. And we just reported overall survival improvement with TALAPRO-2 trial, which hopefully we'll present in a future meeting in next few months, hopefully. So there is no doubt that PARP inhibitors have a role to play in patients with metastatic prostate cancer, and they have the potential to delay the onset of AR resistance or allow patients to continue the AR-targeted therapy for much longer. So now, in the similar theme, let's look at PEACE-3 results presented by Dr. Gillison just recently. There was a 30% reduction in risk of disease progression or risk of death just by combining radium with enzalutamide. And again, this is another proof of principle or example of how radioligand therapy can allow delay of AR resistance in our patients. Now let's switch gears to come to lutetium-177. Everybody's very familiar with this class of drug. So I'll come straight to the results of the trials. So we saw VISION trial and the PSMA-4 trial after chemotherapy, before chemotherapy, and we see radiographic progression-free survival to be significantly improved in both settings. Overall survival was improved in VISION trial after chemotherapy, likely because of crossover of 80% patients to the lutetium arm. PSMA-4 did not show overall survival benefit, and I'm really hoping that it leads to approval of lutetium-177 for our patients in pre-chemotherapy setting, because a lot of patients don't stay alive to receive lutetium-177 by the time we see they have been exposed to chemotherapy. So there is a 50% attrition rate in each line of therapy for metastatic CRPC. So I'm really hoping these drugs move up front. And in this context, we just saw the results of lutetium-177 with a different carrier molecule, PNT2002. And if we just compare this PSMA, 2 different types of PSMA carriers, we can see that looks like the INT drug is less efficacious than the PSMA-617 carrier molecule drug, which is Pluvicto or lutetium-177, PSMA-617. And I think likely because the dosing was different with in the SPLASH trial. Less dose, I have summarized all the dosing here. I don't have to repeat it. But we can see here that dosing matters with lutetium or radioligand therapy. And SPLASH trial probably used less doses of lutetium-177, leading to less pronounced efficacy with this molecule. And in this context, we saw another trial press release, just reported like a few weeks ago. And this trial, ECLIPSE trial, which used, again, lutetium PSMA INT molecule, the sponsor is Curium. They reported that this trial is positive. So I'm sure we are going to see multiple lutetium-177 drugs with different carrier molecules being available in the clinic in a near future, and we'll have more options to treat. Now, again, the last approved therapy I'm going to talk about is obviously cabazitaxel. This is a very well-known trial to all of us. And in this trial, patients were randomized to cabazitaxel versus alternate ARPI. I'd like to bring your attention to the fact that these patients had to have poor response to first ARPI. And this is often not discussed in our meetings. And obviously, we'll be comparing cabazitaxel with lutetium-177, which is available, which is not available. In many countries, lutetium-177 is not available. Cabazitaxel is a pretty decent drug, but it's good to know these data in and out, that these patients had to have poor response to first-line ARPI. And despite that, we saw a median PFS, and please note that median PFS included radiographic PFS, symptomatic or pain progression or death. And that was about 1.6 months improved with cabazitaxel, even though OS was improved with the 2.6 months. So there is a OS improvement. So cabazitaxel is a valid option. But again, it has to be the PFS benefit with cabazitaxel is so important to discuss with the patient because lutetium-177 clearly seemed to have a better PFS benefit in this context. So having talked about the approved trials, let's go on talk about the investigational therapies. And these are right in front of you: PROTACs, T-cell engagers, CAR T-cells, ADCs, new radioligands, EZH2 inhibitor, and CYP11A inhibitor. I think pretty much all these drugs will be approved for our patients, all of them, I think, in the next 5 years. Whether they are approved in the same form or they are approved in a next generation form, we are going to have a barrage of newer targets being utilized, being exploited in our patients with metastatic CRPC. So let's look at the PROTAC. The way I explain to my patients, the PROTACs capture androgen receptors and basically push them to proteasomal degradation. And PROTACs do not necessarily require inpatient hospitalization compared to T-cell engagers, CAR T-cell therapies. These are very easy to use drugs in the clinic. And in this context, we have these 3 drugs which have been used in the trials. We have some data. And of these 3, ARV-766 and BMS drug are being tested in the phase 3 trial right now. And we can see here that the efficacy is obviously prelim. These are phase 1 trials. But I remain very optimistic about these PROTACs moving to upfront setting in the metastatic prostate cancer setting and being combined with either one of the approved ARPIs or being combined with therapies with different mechanisms of action. Talking about T-cell engagers, the way I explain to my patients, T-cell engagers act as bridge between the T cells and the tumor cells. So they are bridges, and there are different types of bridges which can be used. So we can see multiple bispecific T-cell engager cells which have been used in the clinic. Most of them are associated with pretty marginal efficacy, high rates of cytokine release syndrome. So I'm not very enthusiastic about many of them, but I feel very enthusiastic about the drug zeluratamig, if that is the right pronunciation. And we saw PSA 50% response in 50% patients. And this is probably the most exciting T-cell engager in the clinic right now. Phase 3 trials have already started. one in actually earlier line of therapy when patients didn't have to go through chemotherapy to be eligible for the trial. So I remain optimistic that xaluritamig will be approved for our patients, hopefully in the near future. But overall, my take on T-cell engagers is they are likely not going to be used as monotherapies. They are probably going to be used in combination with other agents. I think obviously we'll have to establish the toxicity profile first, but these T-cell engagers will be used more as adjunct molecule in conjunction with drugs with non-overlapping toxicities, such as radioligand inhibitors or radioligand therapies or many other targets which we are discussing just now. Let's look at CAR T cells. CAR T cells, the way I explain to my patients, is like putting the GPS on the T cell and telling them where to go, where the cancer cells are. So as we know, prostate cancer is notorious for fooling our immune system, and our immune system is not able to recognize. The MHC presentation is pretty low in prostate cancer, PTEN expression is high, and there are many other factors which make prostate cancer cells an immune unrecognizable tumor, if you will. So CAR T-cell therapies allow prostate cancer cells, because of the GPS, the chimeric antigen, to recognize prostate cancer cell antigens. Again, they are in very early phases. I feel less enthusiastic about CAR T-cells at this point in time than T-cell engagers, but I think they have potential. Looking at antibody-drug conjugates, pretty early. I know several antibody-drug conjugates are being developed. They are already in forefront of therapy in bladder cancer. They are already being developed in many other cancers. Prostate cancer is finally catching up. And almost on a monthly basis, I hear from a drug company about developing a potential antibody-drug conjugate. So I think I'll skip this slide, which is kind of old, which is good news. This slide is from like 1.5 years ago, and all the new antibody-drug conjugates, which are obviously confidential, there's a lot of confidential information out there which is being developed, but I think ADCs are coming to the forefront of prostate cancer therapy, and they have the advantage compared to T-cell engagers or CAR T-cell that these are over-the-shelf available, they don't have to be personalized, and they can be delivered really quickly when patients having progressive disease. Lastly, in the RLT, I won't repeat the lutetium-177 rosapatamab. I think somebody has already talked about rosapatamab-based lutetium-177, which we are conducting right now. The trial, phase 3 trial is ongoing. But I really feel excited about actinium-225, mainly because it has much less myelotoxicity compared to lutetium-177. And it is very much possible that actinium-225, although right now is being tested in post-lutetium-177 setting, it has the potential to move to frontline setting in oligometastatic therapy setting, in newly diagnosed metastatic hormone-sensitive prostate cancer setting. And these are quite encouraging responses we observed in a recently reported trial, which was reported by Mike Morris in ASCO GU. So again, very exciting, one of the most exciting RLTs we have in the clinic right now. Before I conclude my talk, I'd like to talk about EZH2 inhibition. The way I explain to my trainees and my patients, EZH2 pathway allows prostate cancer to undergo lineage plasticity, which basically means it allows prostate cancer to allow AR indifferentiated state when it is no longer affected or dependent on AR stimulation, or AR doesn't have to be driven by the AR. So EZH2 inhibition has a lot of potential in patients with metastatic prostate cancer. In this context, Mike Schweitzer reported a phase 2 trial, which, and here is the data. If you look at the combination of enzalutamide with EZH2 inhibitor mevrometostat, if you look at the median PFS, that was 17 months. And if you look at patients who received abiraterone in the past, their median PFS was, these are striking PFS results. Again, early trial, hopefully we'll see more data in GU ASCO, but I'm happy to report that a phase 3 trial has already started with mevrometostat in combination with enzalutamide in patients who have been failed by abiraterone, whether used in metastatic hormone-sensitive setting or metastatic castrate-resistant setting. And this trial has already started accrual. worldwide. There are many multiple countries which are participating, and I really hope that EZH2 inhibition will become one of the standard of care drugs in next 3 years. Finally, I will conclude my talk with this new drug, opevesostat. It used to be called as MK5684 or ODM208, and this drug targets CYP11A1. This is the first enzyme in androgen biosynthetic pathway. And if you inhibit this enzyme, it is like medical removal of adrenal gland. So these patients require prednisone. These patients require some aldosterone or corticosterone-based therapies, but otherwise, surprisingly, they seem to tolerate this therapy pretty well, as you won't imagine looking at the target of this drug. So in the early trial, just published in NEHM Evidence by Dr. Karim Fizazi and team, these patients who had metastatic CRPC progressed on earlier therapies. There were quite encouraging responses, but most of the responses were present in patients who had AR ligand binding mutations. The responses were not as common in patients who did not have AR ligand binding the mutations, which makes sense that this drug wipes out all the testosterone in the blood. So obviously, if there is residual testosterone, which is still propelling those prostate cancer with AR ligand binding mutations, if the ligand binding mutations are not there, the drug is likely not going to work because it is ultimately working through the ligand, which is testosterone. So there are 2 trials which are ongoing in this context, and I'm really hoping that these 2 trials will lead to approval of this drug, opevesostat, in the near future. So I'd like to complete my talk by saying we are looking at an impending revolution in the treatment paradigm of metastatic CRPC. I believe 4 of these 6 drugs I just discussed will be approved and will be available in the clinic. And this is a time where I think I can safely say that we have started the personalization of medicine in prostate cancer, and it is only going to move forward, hopefully in conjunction with microbiome manipulation. Thank you very much.
Thank you, Professor. Please take a seat for discussion. Is there any question from the audience?
Neeraj's fantastic talk. You know, I didn't ask a question to Monty, and people were wondering what's happening to me, so I want to reassure them I'm still alive. So, fantastic talk, both of you, of course. What great revolution in the field. Neeraj, you're leading amazing phase 3 trials. You're transforming the field, of course. If you can think about the next 3 years in prostate cancer, what do you think will be our standard of care treatment in localized disease and in metastatic hormone-sensitive disease 3 years from now? Theranostics, PARP inhibition, other combinations. Thank you, my friend.
Metastatic hormone-sensitive prostate cancer therapy will be very personalized. Comprehensive genomic profiling should be done in all patients. Patients who have PTEN deficiency, they should be considered for treatment with capivasertib if we see the data. After we see the data, obviously, patients who have HRR mutation, I'm really hoping that Amplitude and TALAPRO-3 trial will be reporting positive in the near future. Obviously, we have patients who will need radiation therapy, who will need surgery in metastatic setting. I really hope SWOG trial is positive, establishing the role of surgery in metastatic hormone-sensitive setting. I think we are going to look at very personalized form of medicine in this setting, as opposed to right now where everybody starts ADT plus ARPI and we pray after that, right? Also, de-escalation trial. We have started de-escalation trials. Libertas trial is going on. So I think de-escalation trial will allow us to stop treatment in many of these patients because these patients are going to be living longer, hopefully a decade after onset of metastatic hormone-sensitive setting. The localized setting, I will be really quick. I think all of this will also move to localized setting. The use of adjuvant therapy, patient selection, RLTs are moving to high-risk setting, I think. We'll see patients who have high-risk localized prostate cancer and they have residual disease. They will be treated with, hopefully, RLTs avoiding androgen deprivation therapy or castration therapy. So this is a very exciting time for our patients. Yes?
Going to be approved in the M1-CRPC are going to be studied and may be approved for M1-CSPC. But there is a number of patients, and they are not that small, that probably or do not need systemic therapy, or if they need, maybe RP alone may be sufficient for those patients. So how can you view the field looking for the population based on the volume, based on the sensitivity to the RP alone, that is going to grow and we're going to, again, to de-escalate treatment, or do you think, we are not appropriate, studying this patient population?
Which setting is this, Fernando?
Sorry?
Which setting?
The patients with M1-CSPC.
Yeah.
So a patient who had a prostatectomy done, radiation therapy done, 3 years later had 3 spots in the bone, or even patients with, low volume disease at diagnosis. So how do you think the field is going to move forward for these patients?
I think field should talk about delaying castration. Nobody wants to be castrated. Nobody wants to lose their testosterone. That's the number one objective, I think, which should be the, I admire the non-muscle invasive bladder cancer field. Obviously, Ashish is there, Phil and everybody else, Andrea. You really have set new endpoints in NMIBC, and which has led to new drug approval. Prostate cancer field is still, every setting we talk about overall survival, which is going to be unachievable. I just wanted to make that editorial comment before I answer your question. So we need newer endpoints. How to get drug approved if you don't want to get away from castration? How can we allow treatments to emerge one day which doesn't require castration? So answering your question, oligometastatic setting, I think number one goal should be avoiding castration. Can we use RLTs? Can we use radiation therapy to oligometastatic sites? Or intermittent ADT. So even if we start ADT, can we just do it for 2 years? Can we do it for 1 year? So recognizing those patients who can safely discontinue ADT, get their testosterone back, have a normal family life, have a normal muscle mass and bone mass, should be the goal, and will be the goal hopefully in the near future.
Very nice talk. I have a question for Dr. Agarwal. I was thinking about the CYP11A1 inhibitor that you mentioned, and especially given your background, I was wondering if you see any specific benefit for subclasses of prostate cancer, meaning the ones that are SPOP mutated, that there is a lot of data showing specific sensitivity to ADT and or potentially sensitivity to ADT.
Yeah, great question. I think in metastatic CRPC, we'll be profiling the AR. There are several papers which are being published even by this group here. So AR will be profiled, has to be profiled. So I think patients will be getting 3 therapies at the same time. They'll be getting probably RLT, one of the backbone of therapies. They will be getting T-cell engagers. Again, very speculative. I just want to express that. And then AR will be profiled. We'll be seeing whether it is wild type AR, what kind of mutation is there. It is ligand binding domain mutation, it's an N-terminal mutation, it's another like just wild type AR. So we will basically come up with the AR targeted therapy in that patient. So patients who have AR ligand mutations, they will be ideal patients for opevesostat. But patients who have wild type AR, they'll probably not respond to this drug. So this will become the new AR backbone instead of enzalutamide or abiraterone. And then we will throw in T-cell engagers, we'll throw in, targeted drugs like PARP inhibitors or capivasertib like AKT inhibitors. And ultimately, prostate cancer patients will be treated like we are treating myeloma patients right now. 3 or 4 drugs together, developed in very personalized fashion.
Thank you.
May I ask a very naive question? So you mentioned that you would prefer, or you think that T-cell engagers in the immune microenvironment would be more promising than CAR T-cells. Is that right? So why do you think mechanistically, so prostate cancer is kind of a cold tumor, right? So why do you think that engaging T-cells, where are these T-cells coming from? And why do you think it would be preferable to engage already existing T-cells rather than introducing a T-cell that is armored, you know, to recognize that specific tumor?
Yeah, thank you for the question. I was just talking about near future, in next 3, 4, 5 years. Ultimately, immune system in conjunction with microbiome. Microbiome will be one of the pillars. I'm trying to get started. It's very hard to get started on those studies. But again, microbiome is immune stimulation or immune therapy, in my view. So CAR T cells are less promising right now because it takes so much time and energy. We don't even have hospital beds in the US, and I think it may be very similar to other countries, to admit those patients even for CAR T cell therapy. This is logistically so difficult to do, and then CAR T cells take much longer to manufacture unless they're off the shelf. And I think the cost issue will be there. If you combine all of that, and then while patients have rapidly, like their disease is progressing during this time, it takes 2 months to do that. The disease has already progressed. T-cell engagers are available off the shelf. You can actually just give it right away. So there are multiple factors. I'm not pessimistic about CAR T cells. I just feel more excited about T-cell engagers than CAR T cells.
Okay, thank you for both speakers and, you know, people in the audience for this great session. We will move on to the next.
So, welcome to this session, focused on research projects, a flavor of the ongoing industrial partnerships. My name is Maria Picchio. I'm a nuclear medicine physician here in San Raffaele, and I'm sharing together with my colleague Martina Sollini. And we have today 2 outstanding speakers, and I'm very honored to introduce Jeffrey Ross. I don't think he does need much introduction, but we know that Jeffrey is a professor of pathology, urology, medicine, oncology, and he is a medical director at Foundation Medicine in Cambridge, Massachusetts. So he is a leader in the field of molecular diagnostic, and he will present his insight in Foundation Medicine, comprehensive genomic profiling in GU cancers. So please, Jeffrey.
Thank you very much. Specifically, my presentation is on homologous recombination deficiency signature and PARP inhibitor efficacy in GU cancers. So let's see. My disclosures for you all. This 82-year-old man presented 13 years previously with prostate cancer. As you can read his history, low grade to begin, but he relapsed with high grade disease, ultimately having a radical cystoprostatectomy. When he presented for genomic sequencing, he had widespread metastatic disease, metastases in lung, liver, and multiple lymph nodes and bone, not central nervous system. His sequencing results revealed a complete loss of BRCA2, with a TMPRSS fusion and a TP53 mutation. Based on the CGP findings 13 years ago, this man was treated with a combination of cytotoxic agents and early PARP inhibitor therapy. He had dramatic response to the PARP inhibitors, PSA of more than 600, dropping down into very low levels, metastases disappearing from lung and liver, bone healing, had several complications of toxicity from the therapy he was on, but ultimately was on maintenance PARP inhibitors for more than a decade. This opened our eyes for the first time that there's a difference between a BRCA2 homozygous deletion and a BRCA2 inactivating mutation, or BRCA2 inhibition by methylation of the promoter gene. And one of the goals of this talk is to alert everyone. We must sequence prostate cancer patients early and know if they fall into the BRCA2 homozygous deletion group, because without the gene, you cannot make a PARP reversion mutation in BRCA that confers the resistance, and the patient stays sensitive for prolonged periods of time. I say this because we want to talk about what BRCA means in terms of homologous recombination deficiency. And you see the well-known cancer types that have been linked to PARP inhibitor benefit based on BRCA mutations, such as ovary, prostate, and more breast, of course, and more recently pancreas, and now other tumor types. And focusing only on BRCA1 or 2 inactivation, whether it is a inactivating mutation, which is preponderant in every cancer type except prostate cancer, which has a 20% frequency of complete loss of homozygous deletion, which then confers that PARP inhibitor benefit that's prolonged and robust. We also have to differentiate biallelic BRCA inactivation from monoallelic inactivation. Biallelic activation is the HRD signature that will lead to PARP inhibitor benefit. Monoallelic loss rarely, almost never, is associated with a PARP inhibitor benefit. And you may see in reports a BRCA mutation, but you always need to know, is that monoallelic or biallelic? Because if it's not biallelic, it's probably not a very strong predictor of PARP inhibitor efficacy. More recent data, some coming from the Flatiron real-world clinical outcome database, showing in other settings the extensive benefit of BRCA1 or 2 homozygous deletion versus BRCA2 inactivation by a single short variant mutation. You can also detect homozygous deletion in a liquid biopsy, but only when the tumor fraction is very high. I think many of you know that doing liquid biopsy work depends significantly on what you're looking for in your result. Short variant mutations, base pair, missense mutations, truncating mutations are very easy to find. You don't need high tumor fractions to find them. But as you move into copy number changes, like amplification or homozygous deletion, it becomes a different story where without a significant amount of DNA in the extracted blood from the extracted DNA from the blood, you won't be able to find copy number loss, and in many cases you can't find copy number gain or amplification. In prostate cancer, however, ctDNA tends to be very high in patients with castrate-resistant disease. Over 20% is common, so you can, in most cases, use a liquid biopsy in a prostate cancer patient in order to be able to determine something as important as a BRCA2 homozygous deletion. So what is homologous recombination deficiency, or HRD? It's really a setting in which a pathway of genes, the HRR, homologous recombination pathway, has one or more members altered. Without any question, as you look at the list, and I know you're familiar with it, the BRCA genes 1 and 2 are by far the most important. But you can have homologous recombination deficiency in a BRCA wild-type cancer. It's not as frequent, of course, as a BRCA mutated cancer, but it is still apparently important to detect these because of their responsiveness to PARP inhibitor-based therapies. As you look at the pathway there for the HRR pathway, you see that you need to have an assay that can detect the PARP inhibitor susceptibility without being dependent on only being able to find a BRCA1 or BRCA2 mutation. And so we needed a robust biomarker that could be applied both to tissue-based testing with extracting DNA from formalin-fixed paraffin-embedded material and a liquid biopsy sample where the DNA is extracted from blood. And this led to the development of the so-called HRD signature, which I'll tell you a little bit about in a moment. But the whole reason for doing this is to see whether or not the current standard of care that was in place for ovarian cancer, the genomic loss of heterozygosity, the GLOH score, whose cutoff was established by the FDA in clinical trials at 16%, identified all or only some of the HRD signature positive cases. HRD signature was developed based on a literally artificial intelligence machine learning assay of copy number changes across hundreds of thousands of cancers over time. The idea was, as copy number changes could be calculated, so-called genomic scars could be found, where tumor cells had DNA breaks or injuries, and because of their HRD status, whether it was BRCA-related or not BRCA-related, they couldn't completely repair that defect in their DNA, and they left a scar. Essentially, they left a tombstone in their DNA that could be calculated by changes in the copy numbers. And that, with the AI assistance, led to the development of the so-called HRD signature. The development was first done, as you see here, on over 250,000 cases. And the frequency of a positive HRD signature initially was in the 10 to 20% range, more in the high teens, like 17, 18%. So not an insignificant number for this so-called discovery set, and followed by a training set that led to different frequencies of HRD signature positive tumors, with of course the ones you would expect having the highest, but not absent in other rarer tumor types, which I'll show in a minute. So here we see the overlap of a positive HRD signature and a biallelic BRCA mutation. And clearly it dominates but does not exclusively define an HRD signature positive. We'll always have an HRD signature positive in a biallelic BRCA mutation, BRCA1 or 2. But if the BRCA1 or 2 is a monoallelic mutation, like you see in cases of hypermutated states and a lot of other rare high mutation burden tumors, where only one allele of BRCA1 or 2 is mutated, you will not get an HRD signature positive score when it's monoallelic. And for some clinicians, when they get back a report that shows a BRCA1 or 2 mutation and they immediately think PARP inhibitor, when they see HRD signature negative, then they're re-alerted to the fact that this patient is very unlikely to benefit from PARP inhibition, and maybe other therapy choices should be in mind. So here's the list of the different tumor types. And no surprise, ovarian cancer, high-grade serous carcinoma of either the ovary or the fimbria of the fallopian tube are the highest frequency of an HRD signature positive tumor type. Breast cancer is, you can see, highly on the list. Prostate, a little lower than breast cancer. And if you want to look down the list, you can see where the urothelial bladder at 4.5% is. And finally, the least. Unfortunately, as we know, biomarkers are tough in renal cell carcinoma. It has the lowest of the GU major tumor types. We've done 3 studies for ASCO-GU on HRD signature, and one of them we included was penile squamous cell carcinoma. We're looking for patients who might benefit from PARP inhibitor therapies in which that therapy is never thought of in the routine management of patients with advanced metastatic disease. So there are diverse mechanisms associated, and BRCA can be inactivated by non-sequence altered states, mainly methylation. And a test like DNA sequencing, whether it's blood or tissue, will not pick up BRCA methylation and inactivation, but the HRD signature will. So it's increasing the number of eligible patients when you do calculate the signature. Even though you're only sequencing DNA, you can predict with this method the methylation status and add more patients to the list. And when looking at GLOH versus the HRD signature positive, we'll see as we go forward that it increases the number of eligible patients by, depending on tumor type, anywhere from 10 to almost 20% of cases. Here's a list again of the main utility of PARP inhibitors: ovary and breast first for approvals, prostate shortly thereafter. There's still a germline BRCA mutation indication for PARP in pancreatic ductal cancer, actually. But whether other tumors can ever become on label for PARP inhibitors requires, I believe, a test like this HRD signature in order to correctly identify the patients and only treat those likely to respond to show that response is high enough for possibly an expanded registration study. So the current status, as I just mentioned, ovary, but also pancreas for germline. Over time, I think we'll be able to not restrict germline and use HRD signature as the biomarker rather than a specific mutation in BRCA1 or 2. Then we don't have to worry about is ATM mutation as originally in the rucaparib label in prostate cancer, should it still be there? Instead, we hope in the future it'll be based on HRD signature as to whether the patient is eligible or not for PARP inhibitor, not a mutation in any one particular gene, but reversing back. If it's a biallelic mutation in BRCA1 or 2, it's always going to have an HRD signature that's positive. So in summary, and I try to speed up a bit because I know we've been falling behind, this new HRD signature biomarker has been developed using machine learning as a type of artificial intelligence from the raw sequencing data focused on copy number change in a pan-tumor setting. The actual cutoff is 0.7. In any case with an HRD signature score of 0.7 or higher is called HRD signature positive, and if it's under 7, it's called negative. It's highly correlated with BRCA1 or 2, but it does identify a large series of patients with BRCA wild-type genomic sequencing who either have BRCA1 or 2 methylation silencing, and that's why it has HRD signature positive, or it's positive because mutations in other HRR pathway genes are sufficient to create a score greater than 0.7. You will see that when you have no BRCA mutations and an HRD signature positive, it's either methylation of BRCA or it's a mutation in other pathway members. The biallelic loss, 2 to 3% in prostate cancer. We have to find those patients. They probably need a very individualized treatment because their PARP inhibitor sensitivity is so high and the durability and duration of response to their PARP inhibitor is so long. To not have the knowledge that our prostate cancer patient with metastatic disease has a BRCA2 homozygous deletion, to me, is just unacceptable today. We know too much how different they are biologically, and we need to treat them earlier and perhaps for years or even decades with PARP inhibitors because they won't develop the reversion mutations that confers the resistance. But for the other genes like BAP1, RAD51, they can also be associated with durable when they have a homozygous deletion, but it's extremely rare to find homozygous deletions in non-BRCA HRD-associated genes. But it will happen, and when we do a full sequencing, we'll find them, and then PARP inhibitors are going to be beneficial in a major way for them as well. So finally, HRD signature status, although less frequent in prostate cancer without a BRCA mutation, may also predict strong benefit. And now we want to expand and look at urothelial bladder cancer, look at clear cell and non-clear cell renal cell carcinoma, and penile squamous cell carcinoma to find more patients we can intervene with PARP inhibitors in a setting in which we never ever thought before that these drugs could have benefit. Thank you very much.
Thank you very much. If you stay with us, we'll have the discussion at the end of the two presenters.
So we can move on. It's my pleasure to introduce Adam Elnagar. He is the medical director of oncology in Atera, and he will provide a talk on the emerging role of ctDNA in genitourinary cancers.
All right, thank you. Thank you. I'm excited to be here in person. I got, for the first annual one, was invited to present virtually at 4 a.m. on Thanksgiving Day. So to be here, happy about that. There's my conflict of interest there. I work for Natera. So cell-free DNA, the idea of it, we've known about it for about as long as we've known about DNA, right? That people with cancer, pregnant women, all have higher amount of cell-free DNA, and then we discovered ctDNA, and it was, how do we operationalize this? How do we get it into use for cancer care? And it makes a great biomarker, right? Like if you have the DNA, it's coming from actively shedding cells. So it serves as a real-time biomarker of the presence or absence of cancer or their treatment response. And then the amounts of ctDNA you would expect to fluctuate throughout the patient's treatment journey. And this is where it can be helpful for minimal residual disease after treatment or treatment response monitoring. So specifically within muscle invasive, there's a number of opportunities where this can play a role. The neoadjuvant setting, the post-surgical, monitoring for a recurrence, or monitoring response on treatments. I think one of the earliest data is looking at a tumor-informed ctDNA was in this study with Christensen et al. And in that study, there was a biobank of about 68 patients that all received neoadjuvant therapy, surgery, and then serial testing after that in the surveillance setting. And so what we saw was just looking at baseline ctDNA, so after TUR and diagnosed, you can see that baseline ctDNA negativity versus positivity was extremely prognostic of outcomes. And then in the next KM curve there, that's after neoadjuvant therapy prior to cystectomy. And you can see that some of those positive patients went on to have a clearance event. So we're not only looking at prognostic value, but now we're starting to look at predictive value. And then in the longitudinal setting, if patients remain serially negative, none of those patients went on to have a recurrence, whereas if they became positive, that's the group that you were seeing recurrences begin to happen. And that correlated with overall survival too. Next was in looking at InVigor-10, which I'm sure a lot of you are familiar with, is after cystectomies, patients were randomized to atezo versus observation. And when we look at the intent to treat population, you can see there was no significant difference in those survival curves. And even if you looked at them by the biomarker eligible population, so TMB, PD-L1, there was still no significant difference there. But then when you introduce ctDNA in it, those faded lines there at the top, that represents the ctDNA negative group. And you can see there wasn't a benefit to treatment versus those that were ctDNA positive, and now you see a significant benefit with the addition of therapy. And then that also held up in the updated overall survival. This was from EAU a couple years ago. It's also now published. And you can see that the overall survival benefit of treating the patients that were going to have the events persisted. But I also want to draw your attention to that ctDNA negative groups. You're seeing those curves start to cross. While it doesn't reach significance, you can see a continual trend in worse survival in the patients that were negative and received treatment. And that's not a new paradigm. It's the idea that patients who don't need therapy, it can actually be detrimental to them. And so we see that Dr. Ross represented the PARP data in ovarian cancer. That would be one. Patients that were HR proficient did have approval for PARP therapy, but the data over time showed that that was actually harming survival or trending that way. The other piece was then to begin to look at it from a clearance perspective. So these were patients that were CTA positive after surgery and then received treatment or did not. And then looking just at cycle 3, day 1, we're showing patients that had a clearance event, so they cleared on therapy, was predictive of their response to therapy, as shown by those survival curves for both the DFS and OS. And you're also getting an idea of the specificity of the test in terms of positive patients going on to have a recurrence because you had less than 4% of people, so 3 of 79 just spontaneously clear without therapy. When we talk about predictive biomarkers, so we were just showing just ctDNA alone as a predictive biomarker, but how can it overlap with some known biomarkers like HRD, for example? So in this setting, we know that TMB high is a known predictive biomarker of response to atezolizumab. And so in this curve, what we're looking at is just the ctDNA positive population. And you can see in the TMB high patients, there was a significant benefit to the addition of atezolizumab. And I point this out just to indicate, as we're talking about the use of ctDNA in trial designs, is you have to have an effective therapy. So in that KM curve on the right, your TMB low, so you already have a poor predictive biomarker of response to therapy. Yes, they had the events and they had a poor prognosis, but they didn't derive a benefit from atezolizumab. So we can identify the patients with a bad prognosis, but we also need to have effective therapies for them. And the same thing was shown with PD-L1. And then, of course, this data went on to inform, let's do the confirmatory study in IMvigor011. And in that study, similar design, except for only the ctDNA positive patients are getting randomized to treatment versus observation. Another interesting piece that's been added to the study is the idea of serial testing in the negative group. And if any time they become positive, then they jump into that randomization arm. And so that gets into two questions that are getting asked is there a role for delayed adjuvant therapy, so let the patient kind of identify themselves as someone who needs it. It also starts to get into treatment on molecular recurrence type idea. And similar in modern, this one's acknowledging, hey, if you're CTA positive, you're at high risk of recurrence, and so you need therapy. So the study design is in the positive patients, Nivo versus escalation with relatlimab. However, in the CTA negative group, that's when you get into that non-inferiority design. And it also includes that serial testing in the negative group, and then they can go into therapy if at any time they become positive. Now, this was not pre-planned to look at the ctDNA negative group within IMvigor11, but it became kind of desired to look at that safety data of saying if patients receive serial testing and remain negative, are they receiving any harm in overall survival by avoiding therapy in that group? So here's the schema again. In the ctDNA group, you had to have at least one ctDNA negative test and 12 months of follow-up. So this isn't their enriched full cohort or includes those that truly had multiple time points. You had at least one and 12 months of follow-up. And so you can see here, of that 171 patients that met that criteria, at 1 year, 92% of the serial negative group had not had a disease event. And then when you move over to the overall survival, 100% were still alive at 12 months. And then when you move to 18 months, there were only 2 events, only one of which was cancer-related. So strongly suggesting that, yes, serial testing in this negative group does not harm survival and can probably be, hopefully, the positive group we can demonstrate the benefit of treatment. The same idea of serial testing and treatment upon positivity was also presented at ESMO with Tambola. In that study, very similar to the Christensen group, it was, partly because it's also out of our house, was the neoadjuvant therapy followed by cystectomy and then serial monitoring. And if at any time you were positive, going to treatment. And they showed a similar finding. So when you look at that landmark of 1 year, very few patients that remained serially negative had a recurrence event, and then 100% survival at that 1 year mark. So very similar results. What's interesting as we dig into this study relative to some of the others that we've looked at is post-radical cystectomy. So these patients had received neoadjuvant and surgery. They had a 56% positivity rate, which is a lot different than the prior biobank cohort where it was only 13% after neoadjuvant and surgery. And then also the Volga study was presented at ESMO, and this is just looking at detection after neoadjuvant alone. While they also had a high baseline detection, it was only 23% prior to surgery. The other thing is when we get into the predictive biomarker, 61% of patients cleared on treatment, so suggesting that there was a treatment benefit, but this is also higher than what we see in many other studies where it was about 18% with atezolizumab in this group. And so the Volga study also got into the idea of using it as a predictive biomarker. So this is a very small study, only about 17 patients, and so they got durva-tremi plus EV, followed by durva-tremi. And what they looked at was just, this was a safety run-in, but also let's take a look at the ctDNA data in that. And so what they saw was about 62% were positive at baseline. And then when they looked at, of those 10 patients, 7 of the patients cleared on the neoadjuvant therapy. And then when you correlate that with what was found at the time of surgery, you can see that clearing ctDNA strongly correlated with also response in the disease states, with more downstaging or pathologic CRs in that group. Again, very small numbers though with 16 patients, but also suggested, pre-RC after neoadjuvant clearance or serial negativity was extremely prognostic. And so we see that a lot, and so then it becomes, how do we start to use this into therapy? One was just presented last week, was looking at the idea if you were ctDNA negative at baseline, do you even need neoadjuvant? And showing this group of patients, if they were negative and went straight to surgery versus positive and went straight to surgery, that the negative groups did very well by going straight to surgery. And so this really drives ctDNA as a prognostic biomarker that might help stratify patients to escalation, de-escalation strategies, as well as a sensitive and predictive biomarker of treatment response. And so that starts to feed into like early drug development of treatment efficacy, or also stratification for like escalation upon positivity. And that's it. So I want to thank you for being here. And this crew of people up at the top that are holding it down while I get to go hang out in the lawn.
Thank you. Thank you for your talk. And now we can open the discussion. Is there any question from the audience? I have a question about the assessment of ctDNA in the follow-up, especially for patients with a negative assessment at the beginning. So how often do you suggest the assessment?
So I would say the assessment, most of the studies that we're doing, it certainly within the clinical trials, are about every 3 months. So to correlate with clinical assessment in terms of office visit, things like that. InVigor is enriching in that early part, so for the first 3 months, having more tests within that, about every 6 weeks. Oh. Do I need to say that again? Yeah, about every 3 months to correlate with clinical assessments, as well as sometimes more frequently in the beginning event, to give you more shots on goal immediately after surgery to identify the positive patients.
Thank you.
I promise I will ask a question. Of course, great talk, Adam, and really exciting. And Jeff, fantastic talk as always. I learned a lot. A couple of questions for the ctDNA, which is such a promising biomarker and really amazingly prognostic. Number one, can you comment on how frequent or infrequent it is to not have enough tumor to design the plasma assay, because a tumor-informed assay, of course. And the second question, which is, I think it's exciting to see this reproducibility of the prognostic role. The question is, in terms of the logistical operations of ordering across different cancer centers. I know this is getting easier and easier, but can you comment on that and how easy it's now implemented in medical records if people want to order the test? So tumor-informed question and the operational ordering question. Thank you.
Okay. So from a tumor-informed perspective, obviously you need the tumor to sequence to make the personalized assay. For most tumor types, we're very successful. So for like colorectal cancer, when we look at circulate, it's about a 10% inability to make the assay. If you take that to purely a lab issue, so specimens were sent right, they were set in the right kit, everything, it goes down to about 4% of the time in colorectal. Same thing in bladder. You know, you're getting a TUR with a very adequate specimen, or you're getting the surgical specimen, so they have much higher success rates. Where we see low success rates is like in prostate cancer. So you're doing serial core biopsies, and so getting enough tumor content from that or fixation of those biopsies can be difficult. So that would be a disease site where we start to approach like 40% of the time we can't make that assay. Now, if they get a prostatectomy and a bit much larger specimens, then that drops significantly. And in terms of like an operational piece and ordering, I think, you know, as it becomes, obviously, this room's very diverse in terms of like countries, and so the approvals vary all over, so I can't comment everywhere, but I would say in the US, it's becoming much easier with approvals and then also integration within the EMR now at a number of places.
Yeah, no, just to follow up on that and what Petros asked, Adam, I mean, I remember chatting with the folks from Natera 8 years ago, right? And sort of like sitting down and where's this going to go? And now you're literally like every patient is getting the test. It's such a remarkable achievement in a relatively short lifespan of a company like this. So congratulations. Jeff, again, I just want to tell you, every time I hear you talk, I learn so much. For the young folks in the audience, if you want to look up to a mentor, you have great mentors here in Italy, but Dr. Ross here is really, truly a phenomenal mentor to get to know. He really supports anyone at any stage, so contact him during the lunch break. Don't let him have lunch, talk to him.
I think one of the things that characterizes me is was and have been close friends with the other speaker's father. So it just shows. I just make a comment quickly, and I'm not trying to, we don't want to get into promotional, fights here. And as everyone knows, Foundation Medicine was a partner with Signatera for a long time, is no longer. And I'm not sure what the answer to this is about informed versus uninformed. And in a setting where you can't get the DNA sequence from tissue and thus can't do an informed, do you then reflex to uninformed and just do a high sensitivity liquid biopsy and see what you get? The one advantage that has is if you're far in the course and a resistance setting has occurred, the uninformed may pick up something that helps design the next treatment regimen that you can't when you go back to the original informed on the earlier tissue biopsy. So for some cases, it may be a combination of informed Natera type testing and uninformed just NGS out of the blood in order to follow the patient through the whole course of their disease.
So that was one of the questions I was going to ask both of you actually, so thank you for preempting that question. The other question I wanted to ask you is slightly more broader, right? Because with all the work that you have led in the field with molecular subtyping and getting into the depth of the issue, where do you think the field is going? Because all of us have been doing this, not as much as you, but for the last 10 plus years, right? But it looks like histopathology still rules for the most part in most of what we do. Where do you think the field is going? Is it going to be taken over by machine learning and we're not going to have to look at histopathology? Where are we going to be in 2 to 3 years?
Well, if I answer first, it would be tissue histopathology, our core capability. Still critical in the early phase of a cancer patient's course, but less and less important in patients with metastatic disease, relapsed metastatic disease, where the drivers are what the treating doctors want to know about. But early in the disease, when the urologic surgeons are still trying to cure the patient and removing all of the tumor DNA in the operating room, pathology is so critical for even what operation you want to do or whether neoadjuvant should be done before the surgery. So it still plays a big role, but its role in later stage treatment of cancer has really diminished now, given the fact that genomics is so driving patient treatment decisions.
I think both tests are going to continue to evolve more and more within the treatment paradigm. In terms of just treatment response monitoring alone, the FDA is really struggling with all these escalation trials, right? We know EV Pembro is a very effective therapy. So now let's give it as a maintenance. That's just extended adjuvant therapy to me. And so the FDA is having to really struggle with these all-comers approach. So like Niagara was brought up, the idea of giving it neoadjuvant and maintenance. Well, we just talked about 2 randomized phase 3 trials with ctDNA as an integral biomarker to say patients after surgery don't need therapy, but now we're going to give it to everybody. So I think like a use for CTA in that is to say ctDNA pre and post neoadjuvant therapy and see if the addition of durva was beneficial. Maybe what you'll see is that there's more clearances with ctDNA. So that's where it can come into play as a surrogate biomarker. If you see standard of care clear ctDNA in 30% of patients and then the experimental arm does it in 70%, it's a strong indicator of that therapy is effective and go to development. Then if you're negative, we'll probably see the same paradigm and maybe durva neoadjuvants alone. It clears more patients, but then we get into that do you need maintenance or not type decision. So I think trial designs are going to be really important, that we get smarter and more economical about them and improve quality of life.
Any correlation, just curiosity, between lymphovascular invasion and CT circulating cells? It's a clinical value thing, because lymphovascular invasion sometimes is not asked from pathologists, but I think it's very important in order to know if it's a systemic disease or not.
Oh, without question, that is a very important finding. We have diseases like pancreatic ductal carcinoma where lymphovascular invasion is not common, and perineural invasion is common with no communication of the perineural space with the bloodstream. And we see you have to get fairly advanced in pancreatic ductal cancer before ctDNA tests are positive. Whereas other types of tumors that particularly invade the bone and bone marrow, like prostate cancer can do, you have access to a rich endolymphatic system in the bone marrow and get apoptotic and necrotic cells to release their DNA into circulation. So it does make a big difference on the tumor type, whether or not you'll see a positive test of any kind during the course of the patient's treatment.
I would say that lymphovascular space invasion is important, and it also is a poor prognostic biomarker in and of itself, a bad pathologic biomarker. Therefore, you also see higher rates of ctDNA positivity. So larger tumors, higher grade, more aggressive histologies, LVSI, node positivity, you see much higher rates of ctDNA in it. The question of, does lymphovascular space invasion itself drive that increased shedding of ctDNA in there? I don't know that that's the case, but the fact that it causes the tumor, associated with the tumor being more aggressive, increases the amount or the detection rate.
Yes, the tumor type with the highest ctDNA prevalence is small cell undifferentiated carcinoma of the lung. And maybe there's some trends in some other small cell carcinomas of other organ types also having early high levels in the blood. But the number one has always been, since the first studies of circulating tumor DNA, has always been small cell undifferentiated of lung.
Just to conclude with fantastic lectures, with the note of cautious, Jeff, you are the part of the core business of the GUR3. I see on the booklet your face under the DNA. Please, you are all invited to, the faculty is invited to make a picture with the largest group, under the DNA. A note of question, a note of caution is about, Shilpa has mentioned this, the availability of and affordability of the test worldwide. United States guys are facilitated as compared to us because we do not have access to any reimbursement for a ctDNA test, for an NGS test, and we desperately need companion diagnostic. It's crazy that we have today olaparib approved without any companion diagnostic test. So everything is in charge of the hospital, is in charge of the healthcare system. This could not be affordable. So I would like, when all of us will go out of this room, go into the lunch, that keep with us the challenge, they're thinking about the retreat 2025, having solved part of these issues for the patient, so the affordability and sustainability for the treatment of the patient in order to get patients getting closer and closer to newer therapies and targeted therapies. Thank you so much for your talks.
So, thank you very much. Thank you, presenter. Thank you for attending. I have a very important information to give you, that the lunch is in the Hotel Raffaele in front of the hospital. So, enjoy.
Thank you.
Scusa, ma non
So let's restart. Brigida, please invite all the rest of the team inside so that we will try to keep on time to save a bit of time. So it's a pretty exciting session, you know. I think it should be one of the most dynamic session, usually one of the most dynamic session of the retreat, because from now we open the door to the rest of the world and to the rest of the collaborations that we are ongoing. We aim to do with the colleagues, and we will see what is going on from the other side and from the other groups, collaborative groups in terms of clinical trials and in GU cancers. I'm very pleased to co-chair this session with Chiara, our next PhD candidate, a rising star in GU oncology. You know, you have met already her. You will meet her further. She has already a brilliant career in GU oncology. So we are very happy to have her on the team. Phil, frontline, we are waiting for you. So let's start, Chiara, with the first one.
Yes, thank you, Professor Necchi, for having me here today. So it's a pleasure now to invite Dr. Giuseppe Procopio from Istituto Nazionale Tumori Milano, which is the president of the Mituro group, in collaborative group from all the oncologists in Italy. Thank you.
Thank you very much for giving me the opportunity to talk about Mituro in network in this very, very outstanding event, and I would congratulate with Andrea for this organization of very, very fantastic details and amazing faculties. So very, very congratulations and thank you for these opportunities. Next slide. Okay, so here are my disclosures. Mituro is a network. Mituro is a network that would promote spontaneous, academic, no-profit research, clinical research in terms of urological disease. So we would try to define clinical programs, clinical project able to answer at some need, potentially. Need in terms of clinical outcome of the patients, in terms of collaborative research in a multidisciplinary team. Multidisciplinary team will be the key to define a project more able to answer at some questions in favor of the patients. The mission of Mituro is to support and to start a clinical project in a multidisciplinary team. We would to try to define also a networking able to support patients, able to support families, and able to answer at some questions, including unmet medical need and the availability of new agents in less common histologies. The activity of Mituro starts in May 2017, and Sandro Pignata was the first president. He's a well-known scientist in gynecological disease, but not only. And subsequently, I was elected as president, and then Ugo De Giorgi, and currently I have the position of president again of this networking. But we have a continuous growth of this networking. Overall, more than 400 members, the majority of them are medical oncologists, are part of the Mituro. And overall, more than 130 sites, the majority are medical oncologist sites, are part of the Mituro. In the whole Italy, the distribution is quite homogeneous, more in the north, but all Italy is covered by this networking. The organization of Mituro is flexible, is quick. We have a president, a scientific secretariat, and the board member counselor are well-known physicians involved in the treatment of this type of disease, and also are investigators able to analyze approach inside of clinical trials. We have 4 different teams of research, including prostate, kidney, bladder, and a special focus on rare tumors. We have 2 coordinators of all team in order to select the potential trial to analyze and to permit the activation of this type of study. So 4 areas of research, and the method is to try to start with a prospective multicenter trial having specific need, to try to personalize approach when possible, to assess novel prognostic biomarkers or novel prognostic factors, and try to define a new treatment approach for rare and less frequent histotypes or for orphan disease. What about our activity in these last 7 years? 38 clinical studies were undertaken, and in this table I have summarized some of these clinical studies, recruiting now or ready to start in different settings. And shortly now I would put your attention of some of these studies. The Bonsai trial was an example of a good working in a multidisciplinary team and in a good working in different sites in Italy. It's a rare histotype, 23 patients enrolled in 18 months to test the hypothesis of the activity of cabozantinib in these rare histotypes, and the study meets the primary endpoint of objective response rate. Unfortunately, as you well know, the prognosis is very poor of this type of disease, but according to the Mituro study, recommendations, guidelines support the recommendation of cabozantinib as alternative therapeutic option for collecting that disease. This is another clinical trial that represents an example of a good interaction in different sites. It's a multi-omic program in renal cell carcinoma designed in a prospective, to assess in a prospective way the role of machine learning and artificial intelligence in order to balance well the information of radiomics and multiomics, including transcriptomic, to try to understand if we may select the best treatment according to some factors. As you well know, in renal cell carcinoma, there are several therapeutic options without a predictive biomarkers of response. The question is, what is the best candidate to multi-kinase inhibitor alone, or IO combo, or double IO? And this study would try to answer at this question. The accrual was completed last month, in November 2024, and the analysis of multiomics is ongoing to try to add knowledge supporting our decision-making in clinical practice. And the approach trial is an example of a multidisciplinary team, how to have to work in a multidisciplinary team. This is a clinical trial ongoing in a phase 3 randomized trial to test the role of locoregional treatment in metastatic hormonosensitive disease, and to try to understand if locoregional treatment, including also cytoreductive prostatectomy, may improve radiographic progression-free survival in patients with metastatic disease. This clinical trial involved more than 40 centers. The majority are medical oncologist institutions, but also urologists are involved, are part of this clinical trial. And up to now, in this year, so at December 2024, after 1 year of the activation of all sites, more than 100 patients were enrolled, 111. So it's a trial, and we hope to try to understand if cytoreductive prostatectomy could be useful, feasible, but also may improve the outcome of the patient. Another innovative point in favor of this study is the timing of locoregional treatment. Not immediately, but after 6 months of medical therapy in patients who do not progressive after hormonal treatment. What about for the next year? Of course, we have to grow, we have to improve our activity, we have to try to design a project useful for the patient. And so I would to put shortly your attention on these two trials, REPRINT and CARE1. The question is, Nectin-4 could be detected in collecting duct renal cell carcinoma. Recently, there is an important publication of Andrea and the team demonstrated the expression of Nectin-4 in different histotypes of genitourinary disease. Here, we had reported that 30% of collecting duct had an expression of Nectin-4, and we designed this study. Is a prospective frontline trial designed to test the combo pembrolizumab plus enfortumab in collecting duct and renal medullary carcinoma. The goal is objective response rate. We designed this study of course, in order to offer a potential useful therapeutic option for the patient in this rare disease without a standard of care. In the same time, we plan an intermittent administration of enfortumab vedotin in order to reduce the cost and the toxicity for our patients. And this is an example of good cooperation in international networking. It's a clinical trial led by JETUG Group, by PIs Lorenzo Biges. It's a clinical study designed to test the hypothesis of the PDL1 as a predictive biomarkers in first-line advanced renal cell carcinoma. The question is, may we use PDL1 positivity to understand what patients are the best candidates, for example, to receive double IO, in comparison with a patient potentially more benefit from the IO plus tyrosine kinase inhibitors. More than 1,000 of patients will be enrolled in this clinical trial. The trial started some months ago in France and will start in Italy in January 2025. And what about, this is my last slide, what about for the next year? Of course, we have to try to cooperate, in rare histotypes, but also in other, in the majority of genitourinary tumors, because academic research may add value in favor of the patient. The key questions of academic research often is different from the questions of the randomized pharmaceutical company-oriented clinical study. So we have to try to add value at our research in favor of our patients, and I would suppose a good cooperation with charities and would permit a major patient empowerment in our decision making and also in the planification of clinical trial. Thank you very much.
Thank you very much, Giuseppe. Please sit on the podium. For the sake of time, we'll leave all the discussion at the end. So we'll jump to the second speaker. We are so happy to open a focus on South America, and who better than Fernando Maluf could guide us in Brazil, bring us in Brazil. So please, Fernando, let's see what is going on with the LACO team, Latin America GU Oncology Group. Please.
So first, I'd like to thank Andrea Necchi, Alberto Briganti, Professor Francesco Montorsi, and the whole team that invited us for such a delightful meeting. I'm going to present the the results and the ongoing trials of the LACOG GU studies and also the other ARO studies in GU in Brazil. This is my conflict of interest. And so we start with prostate cancer, the investigator initiative studies. And the first trial is a trial focused on localized or locally advanced disease. It's called COACTION trial. And this trial is a phase 2 randomized trial, including patients with unfavorable intermediate risk disease or high risk or very high risk disease. And the patients were randomized between 3 arms. 2 arms were monotherapy, one darolutamide, one ADT, both for 24 weeks. And the second arm is the combination of both agents for, again, 24 weeks, followed by radical prostatectomy. The hypothesis behind this trial is to evaluate if the combination arm can increase the pathologic complete response rates or the pathologic almost complete rate in the surgical specimen. And this trial is already started this past month. The second trial is a trial in the M1-CSPC space. This is the LACOG 0415. This was the largest trial evaluating in advanced disease the role of non-ADT-based regimens. This trial was accepted for oral presentation at ASCO 2020 and randomized more than 120 patients with metastatic disease or high-risk biochemical recurrence or local regional relapse not amenable to curative therapy between 3 arms. The first arm was the control arm with ADT plus ABI. The second arm was apalutamide alone. The third arm, apalutamide and abiraterone. And the endpoint was to evaluate the proportion of patients who achieved an undetectable PSA at week 25. 2 arms achieved the endpoint, ADT plus APA plus ABI and APA plus ABI. APA alone did not by 5%. However, when we see the waterfall plots, even APA alone was very active. And this trial had a foundation for us in our group to make several proposals. And there was one proposal that may be accepted for a bigger trial evaluating in patients with low volume disease and patients who are very sensitive to RP alone, the RP alone as a potential standard therapy for this select group of patients, trying again to avoid ADT, which is of course a concern for many patients, and the question is to know whether the patient that can be safely be spared for ADT. This trial now has a longer follow-up, and we are doing a lot of translation analysis in the tumor samples, and one of those is led by one of our leaders in GU, Dr. Denis Jardim, with Artera multimodal AI, evaluating patterns of resistance and sensitivity to APA alone and to APA and abiraterone. In the M1 CRPC space, it's another trial called representation. And I think this trial, for me, it's really, really important because our group is evaluating the race impact on a very well-known regimen of niraparib plus ABI plus prednisone in patients with homologous repair deficient, so patients that were evaluated in the magnitude trial. So this trial divided patients in 2 cohorts. One is a Brazilian cohort for patients with Black origin, and the second cohort is the Latino patients, the patients that are going to be recruited in Mexico and probably Colombia as well. So the idea behind this trial is to evaluate if race has an impact in efficacy and safety in this regimen for M1-CRPC patients, particularly because in the magnitude trial, these patients were super underrepresented. So that's an important question, and it's a very nowadays question of many of the international agencies regarding diversity. The second trial, called XBAT, has been led by Dr. Diogo Bastos and Pedro Isaacson, is again a trial in M1-CRPC space, evaluating the role of the extreme bipolar androgen therapy with darolutamide and testosterone replacement for these patients. PFS, radiographic PFS at 1 year is the endpoint, and the results is going to be presented at this next ASCO GU. We are also doing trials in collaboration with another big groups or international multi-center trials. And one of the examples is the DORA trial, where André Faith, another leader in our group, is in the steering committee of the DORA trial, comparing docetaxel plus or minus radium-223. The second trial, the well-known P3, that was just presented last ESMO by Silke. Dr. André Soares is also part of the steering committee of this trial, comparing ENZA plus or minus radium-223. So the LACOG structure now has been mature enough to collaborate with international groups and also to be part of these international multi-center trials as an example. Regarding bladder cancer, we are about to start in the next month an investigator initiative study with a government fund. So all the trials were for pharma funding. This is a government fund. And this trial is called Redemptor trial. I think for me it's one of the most important trials with a question that has never been adequately answered. For patients with muscle-invasive disease, T2, T3, or T4A, and patients with N-positive disease can also be included if the lymph nodes are within their surgical and radiation field. The patients, 336 patients are expected to be randomized between two arms. The first arm is neoadjuvant chemotherapy with cis and gem for 4 cycles, followed by maximum 2-RBT, followed by chemoradiation with cisplatin. The second arm is the same neoadjuvant therapy schema, followed by radical cystectomy. We are including only public hospitals, and why is that? Because in the public system, patients have very limited access to radiation. So in the trial, they have a 50-50% chance of having chemoradiation or radical cystectomy. And that's what the reason that this trial was trying to be done many times all over the world, but patients did not want to be randomized. But in the public system, unfortunately, because of the lack of radiation facilities, this trial may be possible to be done. And we're looking for non-inferiority, metastasis-free survival, and overall survival of chemoradiation versus radical cystectomy. Another area of interest of our group is penile cancer, and this trial called Hercules trial that was accepted for oral presentation last ASCO was a trial, a phase 2 single-arm study in patients with metastatic disease or locally advanced disease or local regional recurrence, again, both groups not amenable to curative therapy, evaluating the role of cisplatin or carboplatin in the investigator discretion plus pembrolizumab for 6 cycles, followed by pembrolizumab as maintenance for those who had a CR, PR, or stable disease. The primary endpoint was confirmed overall response by investigator assessment. So this is the patient population that was part of the study. 13% locally advanced disease, 21% local regional recurrence. Again, both groups not amenable to curative intent therapy, and 2/3 metastatic disease. The response rates were 39.4%, and the response rate by central review was even higher, 42.4%, and the clinical benefit was 45.5% over 24 weeks. PFS 5.4 months, OS 9.6 months. We found a correlation between high TMB tumors with response and HPV-16 positive tumors with response. We did not find a correlation between PD-L1 and response to the Hercules regimen. Treatment was well tolerated, very low incidence of grade 3 neutropenia, 1 case of febrile neutropenia, no treatment-related toxicities, no new safe signals related immune-related adverse events. And the conclusion of the Hercules trial is that there was the first trial to demonstrate efficacy of immune checkpoint inhibitors with chemotherapy in advanced penile squamous cell carcinoma with a manageable safety profile. And we conclude that this regimen could be considered a new treatment option for advanced penile squamous cell carcinoma and was accepted to be included in the NCCN guidelines in the past few weeks. There's another study that we're about to start in the next 2 or 3 months. It has the same criteria of the Hercules study. It's called the Brava study. Again, advanced penile cancer patients, but with a different strategy. Patients receive chemotherapy, platinum-based for 4 to 6 cycles, and for those who had a response or a stable disease, they are randomized between maintenance cemiplimab versus best supportive care, looking at PFS as the major endpoint. So the design is quite similar to the Javelin Bladder 100. What are the future directions regarding penile cancer that unfortunately is epidemic in the north and northeastern part of the country? Explore the role of the Hercules regimen in a phase 3 trial. And Andrea Necki, Philip Spies, Joaquin Belmet is part of this global steering committee. So we are trying to push the pharma for the first randomized trial ever been done in advanced disease. So we are looking forward. We are with purposes to be evaluating the role of ADC, such as EV and immunotherapy in locally advanced setting, focus on improving event-free survival, and of course, trying to avoid penile amputation, where Brazil is the highest incidence worldwide. We're also exploring the role of new ADCs in the second-line therapy. We just have a proposed approval with sacituzumab tiromotecan in second-line therapy for penile cancer, and we are doing studies, again, to evaluate other biomarkers than TMB and HPV. We are doing epidemiologic studies, led and as example by Dr. Milena Tariki in adrenocortical carcinoma, 150 patients, to characterize the clinical epidemiologic aspects in the Brazilian population. And there is another study, it's a very interesting one, that our group is leading to evaluate the outcomes of patients with M1-CRPC treated in the public system or in the private system. In the public system in Brazil, the last drug that was approved was sunitinib, trastuzumab, and rituximab. So we're evaluating what's the impact of outcome comparing public versus private. Is going to be presented at this ASCO. So I'd like to thank you very, very much for the kind invitation, and hopefully we engage together more trials.
Thank you, Fernando. Now let's move from South America to US with Professor Ashish Kamath from MD Anderson, Houston, USA, who will present us a quick update from the EBCG and EBCN groups.
So thank you so much, as always, for the kind invitation to be part of this, Andrea. It's always a pleasure to be here with you and your fine team, and to see how you've grown it from what it was 3 years ago to now. I mean, it's just exponential, and hats off to everybody that's been involved, but especially for you, for your vision and leadership. I'm going to give you a few updates from the International Bladder Cancer Group. Many of you in the room know a lot about what we do, many of you don't. So just to take you through a little bit of our journey, the mission of the IBCG, when we founded it in 2006, was essentially to improve bladder cancer outcomes through evidence-based treatment, right? We were not in the business of actually conducting the trials, but to take the evidence, distill it, and to make practical tools that are applicable to the global society. I grew up and did my medical schooling in India. I came to the US, many of my friends from all different parts of the world, and we want to get together people. And initially, it was a relatively small group. You can see here the founding members. Maurizio Brossi, sitting right here, was part of the original partners in crime over there, and you recognize some of the other faces as well. And then over the years, from 2006, when we founded it, it's obviously grown to be huge and large. I mean, we have so many of you that are members in the audience, and so many that are joining us. Fernando's a member, Andrea, of course, Petros, Shilpa's on the board, Phil is a member and an advocate, Jeff Ross is. I mean, there's so many partners in crime that we have as part of the IBCG that it's truly amazing to see the global membership and the global impact we make. Because this society is about you. It's not about us, it's about you. It's actually to take what we know about urothelial cancer and translate this to the global community. We have a health services research arm. It's led by Steve Williams and Yair Lotan. You can see the members there, again, Shilpa and Petros. Your pictures are showing up too much. We have to edit some of them. On the screen, they're essential part of this group as well. And then we have this alliance between the Global Society of Rare Tumors and the International Bladder Cancer Group. It was an idea that was born actually here in Milan over some aperitifs, right? And we said, let's get the two together so we can address the rare variants and subtypes of bladder cancer specifically. We do have a newsletter and welcome any of the young investigators in the audience to contribute your articles to the newsletter. Our chief editor is Fred Vitches, and as I said, Petros Grivas is on too many panels, but we appreciate all the hard work that you do, and Petros is one of our associate editors. We have partnered with Yair today, and I want to thank those of you that have reached out to me to offer to be parts of videos that we do and also to give us your feedback. This is an idea that came out during the COVID pandemic when we were sitting in our homes, and obviously people couldn't go for meetings, and we said, why don't we interview people who are experts in their field, not just in bladder, across the globe, and again, release it to people that don't have access to the meetings and can't come. We've done forums at the AUA, again, every year, and you can see here a lot of my current and past fellows have been very helpful and instrumental in participating in these forums that we do. But of course, that's not all we do, right? If that's all we did, then what's the point? It'd be a great time to get together and camaraderie, but we also publish, and you can see starting from 2008, where Maurizio led some of the efforts, Fred Witches, Don Lamb, you can see our publication record throughout the years. Many of these publications are cited in guidelines by the AUA, the EAU, the NCCN, of course the FDA, and I believe the EMA, although I have not seen that publication. And over the years, you can see the definitions and the JCOs, as Dr. Agarwal was saying earlier. In bladder cancer, we were frustrated that drugs were not being approved, or they're being approved for the wrong reason. So we got together along with the AUA and the ASCO GU group, and of course the IBCG published this, and it's referenced in the FDA guideline document. So what we've tried to do over the years is to essentially take the data, distill it down, and then partner with each other to educate regulatory bodies and to help pharma, for example, to fund trials that will actually have a good chance of succeeding, but also of getting approved. The most recent such large effort that we launched is a joint effort between SITC, so the Society of Immunotherapy for Cancer. I had the pleasure of leading it for 4 years, and it overlapped with what we were doing. So we put forward this definition, endpoints, and trial design across the spectrum of bladder cancer. So from non-invasive disease all the way to third-line metastatic disease, what should be the appropriate time points? The promise here was that if you design a trial and follow sort of these benchmarks and these guidelines, hopefully it'll make it easier for you to get this approved through the regulatory bodies. We have gone to Chile and other places, but this is a recent example from us being in Chile, working with the Ministry of Health there to update their guidelines in bladder cancer. And then we have an effort that's going to be launched in Mexico and also in Morocco that's coming up. We have a retreat that initially was just 10 of us. Maurizio, remember that? It was just small, it used to travel. Obviously, as it became bigger, we had to find a centralized location. So we have a retreat. Last year, we had it in Houston, and the topics that we considered were bladder conservation and muscle-invasive bladder cancer, and of course, BCG unresponsive recommendations. And Andrea, thanks a lot to your leadership in taking what we did in 2023 and having what you're going to be doing tomorrow, which is the joint workshop to address a very critical part of what was discussed back there. This year, we tackled two topics, which was essentially the intermediate risk non-muscle invasive bladder cancer, because again, it's a largest group of patients, right? We focus on metastatic disease, we focus on other diseases, but the largest group of bladder cancer patients that you will see if you deal with bladder cancer is that intermediate risk group of patients. And there's not much written about what to do for those patients, so that's what we tackled. And of course, optimal sequencing of drugs and therapies when it comes to muscle-invasive disease. A little bit about the Global Society of Rare GU Tumors and our collaboration. like I said, this is an idea that was born out. We came together, and we've done things in the last 2 to 3 years already. For example, we had this with Karima Wala in Morocco, a joint session where we participated in February of this year. It was well received, very different audience, different patient population. It was eye-opening for us to recognize that, yes, we may talk about EV-Pembro, but they will likely never see EV-Pembro, at least for another 5 years, right? We talk about all these drugs that we have available in the US and elsewhere, but they will never see that. So how do we translate that to different populations? We also had a master class at the SIU recently in New Delhi. Those of you that were able to join us in New Delhi, hopefully you enjoyed the Indian hospitality and the Indian culture when you were there. And as part of that effort in India, we did launch the Global Registry Project for bladder cancer. And Ekta was asking me about this a little bit earlier. So this is a global project that looks at registry across multiple countries and collects annotated data on patients with bladder cancer. Initially, we were focusing on the non-muscle invasive group, but we also are focusing on patients that had radiation therapy. Vedang Murthy, who is over there, is the PI of the BART study, the adjuvant radiation after radical cystectomy, and he has a huge data set of patients that he's treated at Tata Memorial with radiation therapy. So this is what we launched just recently, a few months ago. And again, if any of you want to participate in the registry project, just reach out to me or anyone that you see on the screen, and we'd be more than happy to have you be part of this. The goal of this project is for the data to be shared and not owned by anybody, but also owned by everybody. So if you contribute, then you can propose a question to this registry, and then you can answer that question, or we will answer it for you, and then you can publish and present on that. Of course, we are here, right? This is the collaborative group. This is us looking down at the camera many years ago. I mean, this is the dream that got us here. And like I said, Andrea, thank you so much for taking that and making it into this, what I think will be very, very important tomorrow, the effort that we're doing in the workshop. It's not all work. We also play a little bit. We've had our IBCG dinner at this restaurant in Houston, Musafir. It's owned by 2 of my friends who actually came to the spice route of India, down from Africa up to Dubai and then in Houston. And actually just a month ago, it got the first Michelin star for an Indian restaurant in Texas. So, you know, I think they might owe some of their starness to us having the meeting there, right? Because they can say, hey, you guys come there and do stuff. Just some examples of pictures from our last retreat, folks having a good time. You can see Fernando, you can see Petros. I mean, you can see all of us having a good time over there. Jeff, as usual, probably just told me a story about the opera, and I just looked vacant, and I had no idea what he was talking about. I don't know what's going on here. I have no idea if you're yelling at him, or you're trying to control him, or what's going on, but he looks scared. He looks a little scared in that picture, doesn't he? Yeah. And of course, you know, the team that got the band together. So we do have a good time in general, but back a little bit to work, right? So this paper in 2016 essentially helped advise the field, along with the work that Seth Lunner and Colin and the others did at the GU ASCO meeting as well, that I was fortunate to be present with. And then the FDA adopted this definition in their guideline statement that came out in 2018. And this really led to an explosion of clinical trials in this space, right? So we have a lot of trials being done, a lot of drugs potentially going to be approved, which is great. It's great for the field, it's great for what we do, but it makes it complicated. So because it's so complicated, one of the things that we tackled was how do we sequence these drugs now that we have multiple drugs available? And just in brief, to highlight some of the points from the paper and the retreat, it's very important that every time you're offering bladder conservation therapy to your patient, stage the patient properly. It really pains me when I see a patient with non-muscle invasive disease coming to me with their bladder pristine, but metastatic disease to their liver, lung, or lymph nodes, right? We've saved their bladder, but now they're going to die of their cancer. So stage them appropriately. The bladder being clear is not a guarantee that the rest of the patient is clear. Always stage the patient properly. Once you stage the patient, then you can move forward. But as we're doing these recommendations and these guidelines, and Albie, thank you so much for allowing us to publish that in an expeditious manner, because that is really important for the community. But the question that we then ask is, well, what's relevant to the patient, right? The patient then asks, am I giving up long-term cure for short-term gain? Do I still need to participate in clinical trials if I have these drugs available? What about the logistical challenges? Do I want to keep coming to the doctor's office every week, or should I come and have the pretzel put in every 3 weeks or 3 months? What about repeated testing? Yes, I can come in, but what about cystoscopies? What about the financial toxicity? Is the quality of life better? There are just so many questions the patient keeps asking that sometimes we forget when we're designing these clinical trials, when we're doing these things in publishing, et cetera, et cetera. So because of this, the other thing that we've realized as a group is that we really need to focus the efforts of the global community to patient-centric care. That's care that's based on the patient's values, preferences, and expressed needs, not needs that we think the patient has, but the patient's actual expressed needs. Ask the patient, ask their caregivers, find out what's relevant to them. And we did do a global survey, which was across 45 countries. You can scan it, or you can go on, again, the journal. I don't know why European Urology features so much on here, but it's in the journal, and it's a really good resource for you to know what's relevant in different parts of the world. But because of this effort, what we've launched through the IBCG, and again, it just got launched 2 weeks ago, and I urge any of you that want to take part in these kind of studies, empowering patients, AI-driven technological advances, holistic approaches, et cetera, reach out to us. We would welcome your participation in this newly launched initiative, which is essentially patient-centric care, part of International Bladder Cancer Group. And we do have activities planned at the ASCO general meeting next year. I'm not at liberty to disclose exactly what they are, but stay tuned. And with that, I thank you for your attention.
Thank you, Ashish. Great talk. So let's move virtually, because we unfortunately missed the opportunity to have Johan in presence for the first time. Johan is another member of the core business for the retreat. Let's see if he's connected via Zoom, otherwise we will proceed with the next one. Johan, can you hear me? We cannot hear you. We have to fix some problem. We deeply miss you, Johan. The metro station in Paris is not good enough, like in Milan.
Okay, can you hear me?
Yeah, now quite clearly, yeah.
Okay, great.
In Milan, we are facing a lot of strikes, but when there is no strike, the metro are working. So.
No, so it was a pity because I faced actually a shutdown in the metro, so I wasn't able to reach the airport. But it's a pity because this year we are very lucky. There is no strike in Paris in December, the first time from maybe 20 years.
But we are pleased to have you virtually connecting. So please, the floor is yours.
Okay, thank you. So thank you again for your kind invitation, Andrea and Alberto. So I'm so sad not to be here with you. But anyway, so my task today is to provide you some update of the GETUG and ERTC activities here for the GETUG as a board member, and for the ERTC as the new chair of the group. So here my disclosure. So the GETUG has a new board that was elected in June this year. So it's a clearly multidisciplinary board that gather medical oncologists, radiation oncologists, pathologists, urologists, nuclear physicians, and statisticians, because we want to develop a lot of different trials across different tumor types. Just maybe to remind the perspective of the group, the goal, clearly the group want to develop a practice-changing phase 3 trial, that the main interests. We want to reinforce international collaboration within Europe, but also outside Europe. One specific interest, like many other groups, is to try to develop trials also in rare tumors, and try to leverage some data that we generate from past clinical trial, and, for example, share data for performing meta-analysis, and to develop more and more biology-based trials. So and of course, at the end of the day, like here in Milano, to try to attract young investigators is clearly very important. So over the last two years, as I said just a few seconds ago, we tried to develop a lot of biology-based trial that try to address very basic science questions. Here an example with the role of bacteria in bladder cancer and in patients treated with immunotherapy in neoadjuvant setting with the Pandora trial. Or another example with the bionic trial. So it's like a precision medicine trial in first line metastatic setting for patients with clear cell renal cell carcinoma that was reported now 2 years ago. So that, as I said before, I think it's more and more important to collaborate, not only, of course, in France, in Europe, but also outside Europe. So we have a lot of collaboration for performing a trial with SOGUG, with the UK, with URTC, with the SAC, for example. And we try to share this data for doing analysis on a big question like meta-analysis. So we share data from the G2 15, 16, and more and more. We will. It's one pillar of the strategy of the group. So maybe for the update, here's some example of big trials that are ongoing. The first is the CARE1, conducted by Laurence Albuges, my colleague here, in kidney cancer. It was described a few minutes ago, and just to remind everyone, the goal of this very pragmatic trial is to demonstrate that the doublet immunotherapy can improve overall survival compared to the combination of immune checkpoint inhibitors and TKI in PD-L1 positive patients. So very pragmatic trial conducting in many countries in Europe and funded by the European Union. So there is a very ambitious translational program plugged on the CARE1 and conducted by Ronan Flippo, and the ambition is to collect a lot of samples of plasma, serum, and tumors, of course, and to address important questions in kidney cancer science. Another trial example here in bladder cancer is the ALBAN study that I'm conducted with Morgan Roupré, that you know very well, I guess. So here the goal is to assess whether or not atezolizumab can improve the outcome of patients treated with BCG for high-risk non-muscle invasive bladder cancer. So patients are treated with either BCG induction maintenance 1 year or the same regimen plus atezolizumab given IV for 1 year. So far, 516 patients were accrued, and now we are waiting for the events to conduct, of course, a primary analysis. So it was initially in a French study, but we developed the trial in other countries in Europe, mainly in Belgium and in Spain. Unfortunately, we were not able to open the trial in Germany. And like in CARE1, there is an ambitious translational program also plugged on the trial. In prostate cancer, as you may know, there is a large portfolio of trials reported historically by the G2 in prostate cancer in localized setting, but also in metastasis setting. And now we're trying to move to the next step with the new consortium, the PEACE program, so the Prostate Cancer Consortium in Europe. As I said before, it is very critical for Europeans to collaborate. So just to remind everyone what is a PEACE program. So the goal is to conduct academic trial at European level and phase 3 trial for prostate cancer. The sponsor could be any academic group. It could be group, hospital, university. The budget is trial by trial and come from academic grant, industry, or charities. And there is clear publication rule set in the consortium agreement. So we have now 10 phase 3 trials that has been conducted in over the last 10 years. So, and 10 phase 3 trials have been secured for budget. So 5 have already completed their accrual, 3 are still ongoing, and so accruing patient, and 2 are about to start and have just opened in some country. So overall, 3,000 patients were accrued in the last decade, and importantly enough, 2 trials have been reported, and both, we think, are practice-changing. The first is a PIS 1 that was described earlier this morning, where the first question of the role of abiraterone combined with ADT in the context of chemotherapy. The second question was the role of radiotherapy in this setting. So a lot of countries participate to the trial, as you can see here on this slide. So PIS 1 were reported and published by Karim Fizazi 2 years ago in Lancet, and showing that 3 drugs are better than only 2 in upfront metastatic prostate cancer. And very recently, the data from the question about the role of radiotherapy was reported by Alberto Bossi and published again in Lancet this year. And one of the main take-home message from this trial is that upfront local radiotherapy can prevent the onset of several local events and cancer progression in this particular setting of prostate cancer. So again, as many other trials conducted in the J2 and the PIS, we try to provide some data about biology. And here for the PIS 1, again, there was some translational sub-study that was reported by a PhD student, Cedric Pobel, regarding the phenotypic and genomic characterization of this patient and the correlation with the outcome of this patient. So what are the other trials from the group? So PIS2 in high-risk localized prostate cancer that address 2 important questions. Again, the role of chemotherapy when you combine ADT and radiotherapy, and number 2, the extent of the radiation. So pelvis or not pelvis, or just focusing on prostate. So PIS2 has completed the accrual, and again, we are waiting for now the event. Other trial ongoing is PIS 4. So PIS 4 is a very pragmatic trial that try to address the question of the role of aspirin and statin in patients with early metastatic castration-resistant prostate cancer. So M0, sorry, or M1 CRPC. The trial is still ongoing, so very simple question, very pragmatic trial. And now we are moving to the PIS program. So there is, as you can see here, is like a platform trial with different questions addressing in this population of patients with upfront metastatic prostate cancer. So the first question is addressed by the Oligo PIS3 trial conducted by Pierre Blanchard. And the question is here the role of radiation to metastasis in patients with oligometastatic prostate cancer. So again, the trial completing the accrual. So of course we have to wait for the event to be observed before reporting the first analysis. Second question is the role of darolutamide combined with standard of care in vulnerable patients. So vulnerable mean patients who are not fit enough to receive like abiraterone or enzalutamide. So this trial is ongoing. And another trial is the poor responder, actually, so conducted by Karim. So here the role, the question is, should we intensify the treatment if the patient have a poor response after 6 to 8 months of hormonotherapy? So after 6 to 8 months, if PSA is still quite high, the question is, should we give another treatment? So should we intensify the treatment here with lutetium PSMA? And this trial just opened here in France. Another trial is PIS7 in high-risk prostate cancer, so very high risk. So here, patients with high-risk localized prostate cancer, and at least 2 of the following criteria, lesions 8 or more, at least T3 stage or PSA more than 20. And again, here, different question, the role of darolutamide when combined with standard of care, and the role, second question, the role of boosts on the prostate with SBRT. So, and again, this trial is ongoing. And the last trial is a PIS 8. So this trial just started again, and here we are in a patient with metastatic castration-resistant prostate cancer, but oligometastatic prostate cancer defined by functional imaging, so mainly PSMA PET scan. And here the role is the question of adding radiotherapy to metastasis on top of ADT and darolutamide. So, as I said before, there is also an interest in conducting trial in rare tumors. So, we built on previous trial and a successful trial like the JETUNG 13 in germ cell tumors, and more recently, SEMITIP trial that showed that we can de-escalate chemotherapy in good prognosis seminoma based on PET scan. So there is a large portfolio of trial in germ cell tumors in early stage in metastatic disease that address different questions, quality of life, biology, but also still de-escalation. And here 2 examples with the EDEN trial. We are here in low volume metastatic seminoma. Based on PET scan, the patient received 1 cycle of EP, and then a new PET scan is, interim PET scan is performed. And if the PET scan is negative, there is a randomization between radiotherapy or just 1 single infusion of carbo. So the trial is ongoing and accrue very well with patients. And another trial that is funded but not yet implemented, the MIRAGE study conducted by Natasha Naoun here, you can see on the slide. So MIRAGE study is address the question of treating MRD in localized or stage 1 germ cell tumors. So it's not ctDNA, it's miRNA. So you can see here, if miRNA is positive, but other marker negative, the patient are randomized between surveillance, so meaning the standard of care, or 1 single infusion of BEP. So we hope to open this trial Q1 next year. Moving to the ERTC, as you know, ERTC struggled in the past with some difficulty in terms of clinical trial, but now, so we have a new board since this year, actually. So you can see here some name that you may know. So we try to, so I'm the new chair since September, and we recruit a lot of young investigators. And we started with the think tank that tried to address the more important questions for clinical research in kidney cancer and in bladder cancer. So a lot of trials are coming and are about to be funded. So again, the strategy is clearly to try to develop de-escalation trial, so pragmatic trial, but still developing some trial in rare tumor or small proof of concept trial. And again, it is a platform for young oncologists. If a young oncologist in Europe want to develop a new idea, the ERTC will welcome this young oncologist to support his idea and to develop the trial. So, but anyway, we have some very good success with the PIS3 trial that was described earlier, so reported by Silke and Bertrand. And so you know this data they were reporting during last ESMO. So this year, so I think it was a good success for the group, for the patient. Also, another trial that we will conduct at URTC is the de-escalation in the context of the PIS program. So here, URTC is a sponsor within the PIS program. So you probably know this trial conducted by Bertrand Tombal and Guillaume Griset. The goal is here to assess whether or not de-escalation treatment is feasible for the patient who achieve very good response after 6 to 8 months of treatment with hormonotherapy, and for a patient for whom PSA is not detectable. Another idea and trial that will be implemented early next year, as we discussed this morning in kidney cancer, the role of PSMA mutation. So you know that there is some trial. So another one here conducting in the URTC topic. So the patient with kidney cancer and with a PSMA positive PET scan will be treated with PSMA mutation. Another trial that we try to develop with the leadership of Michiel van Eyden and Tom Pauls is to assess how we can maybe de-escalate enfortumab vedotin and pembrolizumab in metastatic urothelial carcinoma. So here the approach is to give a 6 cycle of treatment, so EVP, and then just maintain pembrolizumab for the patient versus the standard of care, so EVP, pembro 2 years, and EV until progression. So, so we made a lot of progress for this trial, and we hope that we will have good news early next year. Another important trial that we want to develop, and we hope to start next year, and I think it's very relevant regarding the discussion we will have tomorrow. This trial called Starburst. So Starburst is for assessing how we can do de-escalation treatment in patients with MIBC, and to maybe provide patients more opportunity to do bladder preservation. So in Starburst, there is basically two cohorts. The first cohort is, the goal of the first cohort is to define the clinical response signatures, and we discussed earlier, there is no very clear consensus on how to define clinical response after neoadjuvant treatment. So here the patient will be treated with neoadjuvant treatment and will perform, of course, MRI, but a lot of different biomarker. And all the patients here in this first cohort will proceed with cystectomy, and the goal will be to correlate the complete response, the pathologic response, with a lot of different biomarker that we will collect. And the second cohort is called Starburst 2, and clearly here is a platform trial that will address different questions about how to do the escalation for the patient for whom a clinical response has been observed. So we will use Twix methods to randomize a patient between standard of care or the interventional, and each interventional address a new question about how to do again the escalation. It will be a platform trial, so we can envision different trials conducted in parallel in this setting. Thank you so much.
Thank you, Lorio. And now let's move to the presentation by Professor Philip Spies from Moffitt Cancer Center in Tampa, Florida, who will present us the updates from the Global Society of Rare Genital Urinary Cancer. Please.
Thank you so much. Well, thanks everybody. It's San Rafael is a special place for many of us, and this has become an annual tradition. So congratulations, Andrea, the exceptional team at San Rafael. You set the stage, and you set the precedents related to how to conduct a retreat and how to be very successful. And the Global Society of Rare Genital Tumors, I would say, is a Moffitt-San Rafael hybrid model, in the sense that this is I would say, a conception that Andrea and I came up together through our many collaborations as an opportunity to elevate the quality of care for our patients in rare cancers. In addition to the multitude of areas that Andrea leads, you know, he's always had a focus in germ cells and in penile cancer. So I'm very excited. And Chiara is holding a legacy now in the many of the research she's conducting in rare cancer. So congratulations. So, you know, I'm going to give you just a very brief glimpse, because many of you know, related to what the Global Society represents, our mission. And I just want to talk to you a little bit about what we're working on presently. And I would tell you that many of the bright stars in this room have led many of these projects and initiatives. So congratulations to you, and thanks for all that you do. So next slide. Do I have a, oh yeah, here it is. So historical perspective, again, this started back in 2020 as a concept, and really it has been, I would say, much like Ashish, I'm sure, when he looks at what we accomplish in our careers, you know, establishing something which advances the field and the care for our patients, I would say, is a legacy, and is really probably the greatest achievement we can sort of have when we kind of look at what we can sort of ultimately do in trying to move the field forward. So, you know, I think from where we started back in 2020, I think we've accomplished a lot. You know, the concept of rare geotumors, as we talk about often, it's a relative term, right? You know, we were just in India a few weeks ago. Penile cancer is not a rare disease when you go to Tata Memorial or you go to many centers in certain parts of South America, like Fernando sort of highlights through some of these wonderful projects and initiatives he's led. But really, the mission of the Global Society is really to advance the management of rare genetic tumors through a global scientific community. And clearly, this is in partnership, I would say, with patient advocates. We learn from our patients, but also our patients help us make sure that we steer on the right path related to what has greatest relevance to them. And I know tomorrow will be a very exciting day because I think it allows us to really try to advance the field related to when we try to assess ultimately treatment response, ultimately what do we need to sort of take into account as a 360 holistic approach, both as a clinician as a patient. So our early efforts really related to advancing, I would say, education. So this is part of what we initially did. We conducted virtual meetings. We clearly know it has great relevance, particularly during the years of COVID when we couldn't physically be in a room. And we conducted meetings really dedicated to penile and testicular cancer and got some of the global leaders in this space to be able to participate. And we really got great feedback that this was really impactful, particularly in parts of the world where they may not necessarily have the expertise and knowledge and ability to do these types of educational platforms. You know, over the past 18 to 24 months, we've done a lot related to working with organizations through Euro Today and other organizations such as this. I think we've been able to disseminate our message. You know, I think education today, as we always like to highlight, is also changed. People like today to learn in various educational platforms, whether that be webinars, whether that be case presentations, whether that be tumor boards. So we're always trying to look how we can be creative and make sure we can sort of capture and sort of reach an audience which is comprehensive as possible. You know, I was talking earlier with someone related to what can we do as a global society. Well, I think it's important to understand in the rare disease spaces, oftentimes it's very difficult to do randomized trials when you're looking at penile or testicular cancer. We've learned through many efforts that we can do this, and sometimes it takes many years. And for our patients, unfortunately, that's many years without providing, I would say, clarity related to what are the best standards. And this is just an example of what we can accomplish. This is a JNCI paper we published 2 years ago, really trying to look at what the experience is with checkpoint inhibitors in treating advanced penile cancer, and really highlights that unfortunately this remains, I would say, a very ineffective treatment for most patients. Response rates are only about 14%. You know, I think one of the, I would say, really great initiatives, and this definitely came through great conversation with Ashish and myself, is we've always wanted to work on a global initiative together. So I'll give full credit to Ashish. He brought this up. He says, there should be ways that the IBCG and the Global Society can work and partner together. And we sort of came to back really that maybe variant histologies is an area where we can really put and join our efforts. And we conducted our first meeting just a few weeks ago, 2 weeks ago in Tampa. This meeting was sort of directed by several of our young faculty at our institution, but we had really global representation. We had Kurmia Walla, Ashish, and others that were there. But really, we tried to focus at defining ultimately how we should define variant histologies, how we should ultimately look at these patient populations with a really heavy input from our pathologists. You know, I think what I came out of at the last IBGC meeting in Houston last year is that even for variant histologies, we don't necessarily all have a standardization how we characterize these tumors. And clearly, that's foundational, is we need to start by characterizing these tumors, understanding what best level evidence is ultimately before we start asking ourselves clinical questions. So this meeting, again, was just conducted a few weeks ago, and it was really quite successful. I'm excited of what's to come from now what we refer to as the Tampa meeting, is really to try to define and advance the field. Obviously, looking and thoughtfully related to developing clinical trials specifically in this space, again, with patient representation and advocacy being an integral part of what we do. More to come, and I'm excited hopefully to have many of you participate either virtually or in person for this meeting. So we plan to make this an annual meeting to take place. From an educational standpoint, I just want to sort of highlight we have a committee dedicated to rare cancers from an educational platform. That's not only for physicians, advanced practitioners, nursing, healthcare workers, ultimately anyone who touches patients with rare cancers, and I think that's critical. And we really have a strong emphasis to working with strong patient advocacy, such as ORCID, for example. I would tell you one of the greatest challenges we have in North America with rare cancers, and penile cancer specifically, is we don't have a specific patient advocacy group. Many patients have come to me and saying, we're just not any resources out there for patients specifically. So I would say that I throw the gauntlet to everyone on the stage. I think if people are wanting to be involved in something related to our global society, I think patient advocacy, particular in penile, is an area we really need some young thought leaders to help us develop. So definitely those are areas. Again, we've been conducting tumor boards, journal clubs, webinars, really trying to really highlight what are the areas that are critical for patients. And from a standpoint of educational, I think Backtable has been really very interested in having us work with them, developing various educational webinars. I was able to conduct one on penile cancer, and I did one as well with Andrea. And they send you this really, I'd say it's probably the best hoodie I have in my closet that they send you afterwards. But Didier Bergodia is the person who organized specifically the Backtables related to urologic diseases. But I think for many of the trainees in the audience, it's a great resource, not only in the cancer space, but related to really looking at various topics that have relevance during your education and training. Roger Lee, many of you know, is, I would say, a superstar at our institution. Roger is focused in urothelial cancer, and he's been leading our genomics subcommittee. This genomics subcommittee has really been focusing specifically in really characterizing many of our tumors, particularly more unusual type of phenotype tumors, to characterize, identify the specific mutations, and really trying to work with a think tank group of dedicated pathologists, clinicians, both medical, surgical, to try to advance the field. And I'll highlight a few of their publications. This is one, and this is a credit. I don't know how Andrea does it. I know many of us don't sleep much in the room, but I think Andrea takes it to the next level. I think I always remember Andrea came to my institution and was the visiting professor, and I was always amazed. I had the privilege of hosting him at my house, but I could tell you that light in his room was on 24/7. So I think I sleep like a sheesh, only 3 hours, but I think Andrea does not sleep at all. So I don't know what he takes, but we need to sort of try to identify what his microbiome is. Maybe Monty can help us with that, but really understand how he does it. But this is one perfect example of a project which was very innovative, and I think kudos to Jeff in the audience. Jeff is the driving force in many of these studies we've been conducting in genomics, and Jeff, we appreciate you. You elevate our cultural level every single year by teaching us about opera, but you also help us really understand and keep us censored related to the unanswered questions related to genomic profiling of these tumors. So thanks for all what you bring to our group. And this is a perfect example looking at tumor mutational burden and characterizing this and helping us understand, particularly for rare cancers and penile cancer. So Jeff is an integral part of our genomics subcommittee. These are also perfect examples of things we've been looking at related to micropapillary subtypes. Again, unusual type of histology and characterizing them. Clearly, partnership between clinicians, pathologists, and people who have clearly focus in this space is how we're going to advance the field. And this is a publication that was just come out a few months ago. This, again, is also of great relevance. I think some of the themes of this today is how do we know that our treatment paradigms apply across our global stage? And clearly, that's a critical, important topic. And this is a perfect example of some of the projects that could be conducted, looking at how ancestry could ultimately affect treatment response and how we should ultimately approach these tumors. And this is Taylor Peak, is a fellow who graduated from my program who's doing wonderful things now at where's he at? Tennessee right now. So Hikmat Al-Ahmadi, many of you know him. He's a global geopathology leader. He leads our pathology subcommittee. I think he was integral related to helping us, making sure that we're educating pathologists across the globe on this stage. Hikmat was also an integral part of our Tampa meeting just a few weeks ago. Something I'm very excited for the current year, Axel Heidenreich, who many of you know is at the University of Cologne, who's the director of urology at that institution, has a strong interest in leading our testis cancer subcommittee. There's a few projects that are currently being planned. I would say more to come at ASCO GU related to some projects he'll be presenting on behalf of our society, and many projects planned for the upcoming year. But he just wants to sort of highlight the group that's going to be participating. Many of you know these are all thought leaders in the germ cell tumor space that are focused in this area, and really they're going to be organizing, I would say, various educational platforms, research and translational type projects, but I think I'm very excited to see some of the areas are going to be of greatest relevance, such as in the post-chemo seminoma space and other areas where clearly we need to sort of have a better characterization and I would say approach to our tumors and patients. Last but certainly not least, something I just wanted to sort of touch on is, we have an adrenal committee. I think that committee was under the leadership of Alex Kudikoff, did really some great things. I think this is a group that really is reinvigorating. They're going to be having a publication coming out soon related to some areas of an unmet need, but is an area that they have really great educational resources for many of the clinicians in the room. And they have many projects, including updating our website related to characterizing adrenal tumors and various other projects that I think would be important for many of us to sort of lead. Last but certainly not least, I would say that the area of rare GU cancers is an area, many of the presentations just before this highlight, there's a great opportunity for partnership and collaboration. We clearly can't do it alone, but I think we should try to coalesce many of these efforts to try to answer really critical questions. I do think that there's also areas we're going to be focused on in the upcoming year, such as in GU sarcomas, melanoma, extrahepatic Paget's disease, a disease I actually see a fair amount in my clinical practice, that I think there need to be some critical projects related to characterizing these tumors and advancing, particularly in patients with metastatic disease. And more to come. I think the IBCG GSRGT initiative is one that's going to be long-term. I'm excited what we're going to do. And just to some of the conversations, I think there are some critical areas that we need to work and develop, such as looking at characterizing kidney cancer subtypes, particular variant histology. So more to come on that, but I definitely think great partnerships are ahead for us. Last but not least, the greatest part of these global partnerships are long-term friendships and collaborations. I'd say this is what's really special about this, is really working together collaboratively with friends who have the same vision related to focus on our patients and always clearly accepting that the bar needs to always be set higher in how we advance the care for our patients, because clearly they deserve it and clearly they expect that from us. Thanks so much for your attention, and looking forward to some discussion.
Thank you, my friend. And last but not least, Petros. You have to close the door to this session.
This is real collaboration.
We'll stop now with posting tweets. Now we are stopping now for a moment at least.
I can tweet at real time, right?
So the X-Wave will stop for a minute.
And the only thing I wanted to say was, Monty, if you figure out what works in his microbiome, we refuse to take oral fecal transplant.
I can tweet real time, right? I will put my phone here with AI. So first of all, thank you so much, Andrea and everybody, for bringing us together. I will start by just quoting what Phil just said. You know, this is the best anti-burnout mechanism, is this friendship, collaboration, and teamwork. And I think, Aziz, you said that to Neeraj and me one day, we're in a taxi going to the airport, and you said the quote, "The strength of the wolf is in the pack." So teamwork is what gets us there and upgrades the bar, as you said, to help our patients' needs. And the patients are the why of what we do every day. So thank you, Andrea, and everybody for bringing us together here. I see international group. I learn from my friends and colleagues every day, and today is a great example of that. So thank you. Grazie mille. So I will promise I give a talk in English, although, Andrea, I need to give this talk in Italian in the future. Next time. Perfect. I'll try to give you some examples. It's very difficult to cover all the totality of the important efforts that the cooperative groups in the United States are doing, and there are many of them, of course. SWOG, I know you guys are doing great work, Monty, Neeraj, Silpa, and many others in SWOG, NASLI. Of course, we have Alliance. I'm part of the ECOG Akron group, and of course, we have NRG. All of those are fantastic groups. These are my disclosures. And I want to start, I think Phil mentioned the role of genomics and the genomics subcommittee in the global site of rare tumors. ECOG Akron has a different, but very similar at the same time, approach. We have a developmental therapeutics committee led by Dr. Flaherty, who's in Boston. And we have also a genomics subcommittee led by Dr. Spencer, who is in NYU. And the goal of this committee is to develop a precision oncology approach, identifying biomarkers, either through genomics, as Jeff and others showed today, or other biomarker-based approaches, and translational research focused on therapeutics that have this individualized, personalized effort. Of course, there are multiple committees within ECOC-ACRIN that align with that mission and that goal: the Imaging Committee, Laboratory Science Pathology Committee, Therapeutic Studies Committee, and of course, Cancer Control and Outcomes. I'm honored to be part of the Executive Review Committee of ECOC-ACRIN, and we review protocols across tumor types, and we see how many of those protocols can go the next step through the National Clinical Trial Network, NCTN, through the NCI, the National Cancer Institute, to be developed as mature phase 2 and phase 3 trials. So I want to give you some examples. As I mentioned, it's hard to cover everything here, but through the ECOC-ACRIN Cooperative Group, which again, one of the 4 major cooperative groups in the United States, similar to what ERTC, GETUC, and others are in Europe, we have different platforms and venues to develop clinical trials. And that table here shows you some examples. ComboMats is a huge effort. I'm going to show you some examples in the next slide. The effort of ComboMats is to put together a biomarker-based approach and develop targets and of course, therapeutic approaches that are targeted to selective group of patients defined by these biomarkers in order to increase the therapeutic window and create target opportunities for precision oncology. It's a huge effort that goes through the National Cancer Institute, as I mentioned, the National Clinical Trial Network, and it involves robust preclinical work and maybe early phase 1 studies to look at rational therapeutic combinations of targeted therapies or chemotherapies or antibody drug conjugates. ECOC-ACRIN, as I mentioned, overall has a broader mission and includes ComboMats, but also other studies that go, again, as I mentioned, through the National Cancer Institute and has a lot of collaboration with industry. We have colleagues in the industry in the audience, and through agreements with the NCI, many of those trials are being launched, and many of them can change practice based on the impact and the size of those trials. PRECOG is a little bit separate mechanism. It's I would say, a clinical research organization, clinical research associate that is kind of a lean organization that can be the liaison between institutional efforts in different cancer centers in the United States and industry. For example, I worked with PRECOG before we published the trial recently, and I was the PI of the study. I had an idea. I went to PRECOG, and they were the middle person between my institution and 7 other institutions and the sponsor of the trial who actually funded the study. The difference is that ECOC-ACRIN and cooperative group trials, the funding comes from the NCI, National Cancer Institute's federal funding, while PRECOG, the funding comes from the sponsor, and again, PRECOG runs operationally the clinical trials, and the funding, as I mentioned, comes from industry through PRECOG to the different sites. Of course, the theme is collaboration, the theme of my talk, and tagging along to what others said before me, the advantage of a group like ECOC-ACRIN and others is the talent, right? You have key opinion leaders, as many of you here today in the panel and the audience, experience in running clinical trials, mentoring, of course, junior colleagues. There are many examples of mentorship that were discussed today. Of course, different portfolio of different trials and different disease groups, therapy settings, as well as different mechanisms of action of different drugs, and of course, multiple centers with a plethora of patients who are very well equipped, I think, to conduct phase 2 and phase 3 trials across tumor types, including rare tumor types, to follow up with what Phil said before. And of course, there are multiple goals of these trials. Many of them are registrational trials aiming to change practice, phase 3 trials in that example. And of course, as I mentioned, there is an opportunity to have this scale, and we have large phase 3 practice changing trials, also a little bit smaller phase 2 studies, and the smaller phase 2 trials usually are run through PRECOG, as I mentioned before, which is a little bit more flexible and faster mechanism. A few more words about the ComboMats. Many of you may remember back in the day, we had the NCI MATS trial developed about 10 years ago, and the NCI MATS was the first effort to, let's say, attempt to personalize oncology therapy, precision oncology paradigm. We had almost 40 different arms. When the trial was designed 10 years ago, there was, let's say, a single agent, monotherapy, trying to go after a target. For example, HER2 right? We had arm J, we tried trastuzumab and pertuzumab for HER2 amplified cancers across different tumor types. We learned a lot from this NCI match version 1, and obviously a lot of lessons learned. One of them was that the resistance can happen frequently in those cases if you have monotherapies, right? So combination therapies might be the way to go. At least if you combine different mechanisms of actions, you may potentially overcome resistance compared to a single agent. So that's how the idea of combo match, combination therapies, came about. And combo match is now running. I'll show you an example of ongoing cassettes and arms. And I would say it's fair to say that this is a hypothesis-driven trial. It requires significant preclinical data and potentially early phase trials. And because there's more than one driver, right, in the cancer cells and solid tumors, we tried with the combinations to have higher chance of response. More shots on goals, I will say, through reasonable and rational, robust combinations. And the requirements are very strict. You have to have some significant preclinical evidence of a synergistic or at least additive combination in vivo preclinical models, PDX or cell lines, in vitro PDX in vivo, or other xenografts. And as I mentioned, phase 1 trials are not mandatory but encouraged to generate data for a phase 2 trial. As I mentioned, you need to have this high level of evidence, and there is a committee, a group, and I'm honored to be part of this group of genes and agents working group that will actually scrutinize and review those concepts, and we try to select, filter out those that are most promising so we can move them on to the next stage, the next level, and go through the pipeline process in order to become a mature concept and an open trial. And of course, it's a lot of work going on into this vetting process, which I just try to be selective on which concepts have the higher chance to be successful. And of course, a lot of biomarker work is going on, whole exome sequencing, RNA sequencing, a lot of work happening at the same time in a biomarker discovery and validation, although these are usually signal syncing phase 2 trials. I can probably memorize the slides and yeah, there you go. So this is the platform of a combo match. As I mentioned, this is a number of patients who get standard of care genomic testing, through different vendors. If you get the report and you have an actionable alteration, the patient may be screened for the combo match study, eligibility assessment. Of course, there's a master protocol, and then the so-called match box may allocate the patient on the particular treatment arm. The patient gets treatment, and there is biopsies that happen to look whether you hit the target, and potential liquid biopsies with ctDNA, and ideally, if it's possible, biopsy at progression to learn about mechanisms of resistance. And this platform, I think, is a really, really promising way to develop rational combination therapies. These are just examples of how these combination therapies may look like and which targets we are going after. As I mentioned, there is a committee, working group that is vetting those different combinations and selects those that has enough preclinical and clinical evidence to move forward. And these are just examples, as you see, of different targets and different combinations that have made it to be activated, and these arms are ongoing now, are accruing patients. Hopefully, we're going to see results in the future. And these slides show other examples of combinations, again, based on the molecular targeted approach, based on a biomarker presence. Reasonable rational combinations that have been tested preclinically are being tested in a phase 2 signal-seeking study, and you see examples of those that are in development. This another slide shows a plethora of targets that we're going to go after. You see here TROP2 and many others. And of course, the goal here is, as I mentioned, to develop rational combination to go after those targets. I want to finish the talk just by showing some examples, moving a little bit further beyond what I showed you so far in the broader scale, go a little bit more specific to the GU committee. And of course, we have been honored to have great leadership there with Mike Carducci, and now Naomi Haas taking over. And more specifically in bladder cancer, the subcommittee is led by Noah Hahn, a good friend in Johns Hopkins. And we have a plethora of studies that we're working on over the last 10 years. And I want to show you just a few examples. I couldn't show you everything in the interest of time, of how much work is being done in the group and how much productive the group is. This is a slide I made a few years ago, and I use it in many of my talks, just to show you the high-level view of bladder cancer treatment. And we try to have trials in every single therapy setting and clinical space to make sure we fulfill the needs and the unmet needs that exist out there across the spectrum of disease therapy settings. I'm going to start with non-muscle invasive bladder cancer, and I'm sitting next to two urologists here on my left, and I will say that we're very proud of the BRIDGE trial that is being led by Max Gates and Johns Hopkins. BRIDGE trial is shown in this slide. This is BCG-naive non-muscle invasive bladder cancer. Assis and others showed you a lot of work being done defining endpoints in BCG-responsive disease. This effort, ECOCACNA 212, the BRIDGE trial, is testing the intravesical chemotherapy combination, gemcitabine docetaxel, compared to BCG as the first treatment in high-risk BCG-naive non-muscle invasive bladder cancer, with the primary endpoint being high-grade event-free survival. It's a non-inferiority trial. This is accruing very, very well. I think it may finish accrual in the next probably 6 to 9 months, probably as is. And we're very excited to have it open at the University of Washington Fairhurst Cancer Center. And I think this trial is important for many reasons, including the national BCG shortage that we're facing in the United States. So if this trial meets non-inferiority, then we'll give opportunity for intravesical combination chemotherapy to be added in the first-line setting. Having said that, we have to wait for the trial results. It's a big trial, 870 patients. Another example is localized muscle invasive disease, and of course we're very excited for upper tract urothelial carcinoma. This trial is being led by my colleague Dr. Jean Hoffman-Sensitz, and I am honored to be the co-chair of this phase 3 trial, along with Vitaly Margulis, UT Southwestern. This trial is for, as I mentioned, for upper tract urothelial carcinoma. Patients are being stratified based on the morphology of the upper tract tumor and also the location, kidney, pelvis, ureter, or both. And this has two components. We have the cisplatin-eligible patients with dose 10 vac plus minus durvalumab, and I think this is a very relevant and timely randomization in the context of the Niagara trial that Andrea showed earlier today in bladder cancer. And we have a cisplatin-ineligible cohort with gemcitabine durvalumab to generate data in cisplatin-ineligible population. I think that trial hopefully will help us define the future standard of care in this very challenging upper tract urothelial cancer. Moving along, bladder preservation is a big thing and I know Johan showed great trials in France. I'm very pleased to tell you that this trial finished accrual in February. This is the SWOG Energy 1806 trial. This is a trial for bladder preservation. Patients after maximum TURBT get randomized to chemoradiation concurrently versus chemoradiation plus atezolizumab. We give 9 doses of atezolizumab. Some of them are concurrently with chemoradiation, and some others are afterwards. And bladder intact event-free survival is the primary endpoint of this study. We're very excited that this finished accrual about 10 months ago, so give us about a year or so. Hopefully we'll have some data in the next year or two, a couple of years. And just to mention briefly, we have many trials in metastatic disease, and I want to just show you a couple of slides before I close here. Cancer screening using ctDNA is a big part of what we're looking for, and I put this bullet point just for your review or picture-taking purposes. The bottom line here is that there is a lot of effort by the NCI looking at ctDNA as a screening tool. We are not there yet. I'm interested to hear, Jeff, your thoughts and others, how you think ctDNA in the future. We're not there yet, but we're getting there probably in terms of cancer screening. I think many studies are needed in that regard to evaluate whether it's useful or not. A lot of buzz, a lot of noise, a lot of work in the United States is happening using that tool, but more trials are required to evaluate clinical utility. And these trials require, of course, funding, time, and collaboration among academic practices and community practices, also with the aim to eliminate disparities. And I think at the last slide here, I think there's huge opportunity with cooperative groups, the National Clinical Trial Network, NCI mechanisms. We have to look at trials with evaluating therapeutic response, resistance, detection of minimal residual disease, of course, biomarker exploration. The number of patients is huge through those big studies. Collaboration with industry is key, and of course, opportunities for real-world data, database, artificial intelligence. And as I said before, it's a working group approach, working with patient advocacy groups, and having this relevant infrastructure, resources, and team approach is probably the way to go in the future. A lot to cover, much more work is being done. Honored to be part of this cooperative group effort. Thank you so much for the attention and the invitation today.
Thank you, Petros. We have a seat here. So Maurizio, please come to the podium. Let's open the door to the discussion, a very, very quick discussion, 10 minutes. So please free to make comment, or do you have any any thought? Please take your seat. So I personally have a comment to make because hearing from you, from your talks, and thinking about potential collaboration, how can we establish collaboration? It's always tough when dealing at the single institutional level, when establishing partnership with networks. But I see here an opportunity, for example, to join the databases, you know, that you are collecting within each one of your networks. Like a possibility to create a repository for the big data, you know, for all the specific tasks and all the specific studies that you are doing. For example, you, Giuseppe, you have mentioned your studies that are ongoing with rare tumors, for example. For sure, there is an issue of data privacy and data disclosure. But once the study has been published and the data has been released already, we can, for example, collect the database of your study in a larger database like a GLSRGT or ABCG for a bladder cancer task. So I think that it could be a good start to think about something like this, coagulating databases from academic efforts all together. What do you think? Phil, for rare tumors, for example, that could be maybe a bit easier, you know.
Yeah, I definitely think that that's a critical need. Is clearly we know that many of us have collected quality data from reputable high volume institutions, which is an opportunity to sort of gather, learn from one another, and really make sure we have a global representation related to what the outcomes of our patients are. You know, one perfect example, when we were in India, they were highlighting to us the significant incidence of HPV negative penile cancer. They say about 60 to 70% of their penile cancer is HPV negative. That's a clearly very different disease than what we see in North America or many European centers. So I think it's very possible. We clearly know regulatory, it can be a challenge, but obviously with de-identified data, getting data agreements, understanding that this data is an opportunity for everyone to have representation, opportunities for publications. I think, you know, the days of one person publishing all the work is really long and gone. We clearly, by partaking and identifying what our critical areas of focus are and really in partnering together, I think we can answer some meaningful questions and at the same time elevate the quality of care for our patients. So it's a critical need. I think we are very interested. We started doing that with many centers in South America. In India now, we have partnerships that are in place. But clearly, no, there are some regular elements and loopholes we kind of need to sort of work through to make sure, from a regulatory standpoint, our institutions are supportive of these efforts.
Ashish, for example, when dealing with the variant histology bladder cancer, when we will never, or it's extremely unlikely that we will run a randomized study, you know, having a benchmark for database when comparing the data, what do you think?
You know, I think it's very important. Obviously, we want to do clinical studies and we want to do randomized trials, and that's level 1 evidence. But we all know, having done these studies, that when you translate that on a population level, the rates of response, et cetera, that you see in a clinical trial are not always seen in your patient population, right? So there is still a role to play for real-world data that's collected in a well-annotated fashion, like you said, and especially for more or uncommon tumors, or tumors that are more prevalent in different parts of the world. And the other thing really is that, you know, we've tried this over the last 25 years, and it's been tough to do because of the regulatory hurdles that you talked about, but in some ways it's getting easier now because we are able to do digital pathology sharing. We're able to do point of care assays and then share the results, genomic and otherwise. So that difficulty where we were trying to ship tumors from Italy, for example, to MD Anderson and then back to India and things, those days are less likely to be an issue, right? Jeff can do stuff where he is and then share the data with a whole bunch of people. So we need to use technology to our advantage.
Fernando, for example, when thinking about penile cancer, you know, we hardly succeed in doing penile cancer studies in Western countries, you know. We can do what we can do is, and what we did in the past, and we are doing is small phase 2 studies, but each single phase 2 study is adding a small piece in the way forward, you know. So what we miss today is to coagulate in efforts, you know. So we establishing some kind of, as Ashish has mentioned, artificial artificial comparison, or artificial coagulation of the data, or artificial handling of the data will be worth, in particular for rare tumors, What do you think?
No, I agree. I think that's one of the potential solutions. But other thing, I think it's going to be important, Andrea, like in the penile cancer proposal that you and other guys here are involved, we should build up in rare tumors like a coalition of the leaders and try to push the pharma to work globally by a global steering committee.
Yeah.
So I think it is. I mean, having indirect, conclusions for small trials, putting together the data. I agree. It's a way to do it, but the best way to do is that a rare tumor is not rare if you're going to do a global study, because every country or most of the countries have these rare tumors.
Penile cancer is not rare in Brazil.
Exactly. So no, including 10, 20, 30 countries, it's possible to do practice-changing trials with level 1 evidence. Like in penile cancer is an example. In Brazil is epidemic. And so far, Philip is running the biggest trial in the local advanced disease space. But that's the disease that has never been done ever a phase 3 trial, which for me it's inconceivable.
Yeah.
So again, we're trying again to put all the forces together to push the pharma to do this trial, and luckily it's going to be done.
Yeah. I'm sorry. Please.
I was just going to mention, Fernando just referred to the IMPACT trial, and I think Curtis Pettaway has been driving this trial for the last 10 years of his life. The study was supposed to accrue 400 patients. The accrual goal went down to 200 patients. It's taken us 5 years to get to 140 to 150 patients. So what Fernando did in his trial that he presented is monumental, but those are trials that clearly can't be done and replicated in an extensive fashion related to running 4 or 5 clinical trials in penile cancer or in certain types of germ cell tumors or other types of rare cancer. So clearly it takes a global, I would say, initiative, effort, to the point that was brought up. These prospective trials are only going to be successful if we get parts of the world where clearly a huge patient population are being seen for penile cancer in South America, in India, and even, I will tell you, what we've learned from even the IMPACT trial is, even in North America, the number of centers that are committed to doing these trials are very few. They're on a hand. There's about 4 or 5 centers that are actually actively participating in IMPACT. And in Europe, there's only basically 2 centers that are accruing patients. So we need to be mindful that if we're going to advance the field, we need to get the centers that seeing the patients are committed to it to work together.
Yeah.
From a pathology point of view,
please.
There is also an interest to standardize the diagnosis in rare tumors because they are rare, effectively. And recently, in this year, we had 2 consensus about sex-core stromal tumors in testes, and now we have a molecular classification about these tumors that change the way to see and to report these rare tumors of the testes. And as ICCR, International Cancer Reporting, we have report now a final reporting for penile cancer according to the College of American Pathologists, ESP, and other important society of pathology. So it's important also to start with a basically standardized approach for diagnosis, because otherwise we have incorrect data. And about one of the most important debated issue today, for example, the divergent histology in bladder, we now have with Indiana University and other 10 United States centers of pathology, we are collecting the data about divergent histology, but in particular to standardize the report of divergent histology in bladder cancer, because also WHO has not so defined the criteria to distinguish these settings, subset of patients that have a different behavior, respect also the treatment.
A few final words for the good mentors, Petros and Monty. What do you think about the possibility of having young guys, rising stars, growing their career through the academic networks. What do you think? Few words.
It's super important to think about mentorship and think about it programmatically. I think mentorship should be a passion, should be something that should be part of your academic curriculum and should be formalized. So I think to quickly answer your question, through cooperative groups, and Monty is doing it in SWOG, I'm trying to do it in ECOG Akron, we try to have innovative ideas and have a champion who may be a junior faculty who has the drive, the energy to go through that process, learn from it, because if you teach them how to fish, they can fish for life, right, and do other trials. So I think it's a priority. It's something we love to do. And the last thing I would say is mentorship is also very important, not only for the mentee, but also for the mentor. I'm learning so much from my mentees. Monty?
Yeah, I agree with everything you said. Actually, I had a question for the panel that ties directly into what you just asked us. I think that, it's quite intuitive, for many of us to put our fellows first when it comes to projects looking at databases or, genomic characterizations of certain populations, maybe even single institution ISTs, where I think we really struggle in SWOG, and I wonder if you guys have the same issue, is how to prioritize young investigators for clinical trials at the cooperative group level. These are big, either randomized phase 2 or phase 3 opportunities. They're going to take a decade or so to run. By that time, many of us will be, moving on to other things, right? So how do we actually, make sure that the young investigators get a chance in that pipeline? I find that to be incredibly challenging to figure out who to invest in.
Yeah, maybe, for example, establishing by default the possibility of having at least one young guy, junior faculty in the advisory board as a steering committee member of international trials, it could be a good step, first step. Being involved in steering committee, may provide them with the opportunity to have also a possibility to publish not just the primary results of the study, but secondary analysis of the study, or having presentation in big meetings. So I think that we should start since the very beginning, offering them not just having a retrospective data set, but putting in them the key for the Rolls Royce, not just the 500 Fiat, yeah, this is my thinking. No, with all the respect of Fiat, we are in a very bad situation. There is today we are no more Italian, but anyway. It's
a couple of quick comments,
not
perfectly on topic, but have been mentioned. Firstly, and I think Fernando can comment on this, when HPV is a biomarker for studying a type of cancer, it's critical to know the time on the course of the patient when the HPV test was done. Because many patients who do have HPV-driven disease, when the disease begins, will convert to HPV negative as TP53 mutations take over and test negative for HPV, and although their disease initially really was HPV-driven. The second comment has to do with the real-world testing. A couple of limitations on that is most of these huge real-world databases use a single electronic medical record database. The one we use, the clinical genomics database, is EPIC only. So it's only for institutions that have their medical oncology records and outcome records, therapy records in an EPIC database. And that's the only way it can be accrued. For rare tumors, the companies that do this, like Flatiron Health, they build these on the major cancers. So they'll have bladder cancer, they'll have prostate cancer, but they won't have rare tumors. It's expensive for them to build a database of therapy-specific outcome. So that's a challenge to the rare tumor clinical outcome studies, is that there aren't these electronic real-world databases for them, even though if you combined everyone, you could get enough patients.
Yeah. Yeah, great. And you should be applauded for all your work that you are doing in affording the career and the possibility of young fellows to have a first name in the abstract from the work that you did from genomic databases or a real-world genomic Flatiron Health FMI database, and putting young guys on the podium of ASCO-GU meeting, main ASCO meeting. So you should be applauded for sure. So thank you, guys. We have to move to the next session. Thank you. And it's my big pleasure to introduce the keynote speech. Shilpa Gupta. Shilpa is part of the family, you know. It's part of the big family. Doesn't need any introduction. So Shilpa will touch, as we did last year, a very, very important topic that is related to geographical, and I think not just geographical, disparities when dealing with the treatment of GU cancers. So Shilpa, the floor is yours.
Thank you, Andrea, for the kind invitation. I'll pose properly so you don't have scary pictures of me. This topic is really very important, especially coming from India. You know, there's a big difference in how we treat patients in the US or the Western world and rest of the world. And thank you, Andrea, for giving me the opportunity, and really excited to be here again for the second time. So as a background, our current state is that disparities in GU cancer care and outcomes are really rampant within countries and globally. And the desired state would be to improve survival of patients worldwide, no matter where they live. And Dr. Necki showed this morning about how a patient's future and cancer outcome totally depend on where the patient may be, if their bladder preservation options or other novel therapies are available or not. And that's really a sad state of affairs right now. And the gap is to remove barriers of access and disparity globally and identify a path forward. Now, the 5 key social determinants of health are listed here. We all are aware of these. These are multifactorial, could be the economic status of the patient, like poverty, employment, food insecurity, and a lot of places in the world now dealing with wars and all these other tensions, education, healthcare access, affordability, whether there's health literacy or not, and environment, about the basic needs. You know, the healthcare needs come second to basic needs of food and shelter, crime, violence, etc. And then the social context of one's religious preferences, discrimination, and other issues like incarceration, etc. And we know that equality is very different from equity. You know, even if we can't choose to provide the same resources to everyone around the world. It has to be tailored to where they are and where they are in their life and what they need, as this picture depicts. And achieving health equities through a multifactorial lens which will address their social environment, education, transportation needs, services, employment, financial stability, etc. So we have to treat the patient as a whole with respect to their social determinants of health. And just talking about the cancer trends in Europe in 2040, as we can see here right now, the patients in 65+ age group represent 60% of all new cancer cases and 3/4 of cancer-related deaths. And in 2040, it's only going to become a bigger problem, not just in Europe, but around the world. And the new cancer cases, of course, are going to increase with better screening and people living longer, and we have to be prepared for that. And coming to GU cancer specifically, the burden is humongous. You know, with the population growth and aging, the incidence and mortality of all the GU cancers are increasing rapidly despite new drug developments. And approximately 445,000 cancer cases and 67,000 deaths occurred in the US in the last couple of years, accounting for 23% of all cancer cases and 11% of all cancer deaths in the US. And prostate and male bladder cancer represent more than 46,000 deaths annually, which is 15% of all male cancer deaths, which is quite significant. And in addition, there's a humbling mortality trends based on where a patient lives. And this is talking about the USA, not global. And if we look at the annual age standardized rates for GU cancers, we can see here it's divided between male and females and the various ethnicity. This paper just came out last year from Dr. Karen Knutson's efforts. And you can see here that there's a discrepancy between whether one is Black or Hispanic and how the mortality trends are featuring. And when we look at other countries relative to the US, it is all the more humbling that, you know, countries which have a larger population The mortality is even higher, obviously, and this could be related to a lot of different factors, whether there's screening or not. Patients are diagnosed at later stage. For example, in India, there's not a lot of screening efforts, so a lot of patients get diagnosed later on for prostate cancer and bladder cancer, and lack of access to novel drugs and trials, of course, adds to the complications. And this is again showing for kidney cancer and testicular cancer, and here very well represented are our Latin American countries as well. Now, this was, in the US very recently, I don't know if people are aware here, the biggest insurance company CEO for the United Healthcare was murdered in cold blood in New York by a person whose mother was denied health care multiple times by the insurance company, and this was a student from Ivy League University who took it upon himself to take revenge, and it's all over the news. And this was the interesting title of the news, because after the death of the CEO, people were actually, posting happy thoughts on social media, and how, this was long time coming, even though it was not that one person's fault. But this brings to the important question of the impact of zip code, area deprivation, and insurance status on cancer outcomes in the US. I won't say this is true for other countries, and there's a lot of work published on this, and there's a lot of data how in bladder cancer, just where one lives determines how their outcomes will be from similar kind of treatments. Lack of private insurance is even leading to higher mortality across chronic diseases and cancer in the US, and more money equals more health care and longer life, even in a country like the US. Now, coming to global disparities in the cancer access, which is more important as we've been discussing since this morning. If you look at the entire global scenario here, and when we look at the trials available, we see that some countries are totally not even there on the map. Many countries in Asia, and we heard Fernando talk about the excellent efforts in Latin America, but that has taken them so long too, and they're doing their own trials. It is not like the pharma companies are going and giving opportunities to all the countries equally. And there's a lot of reasons for this, not just one reason. They could be just in certain countries, what is the price of drugs, what is the barriers, red tapes, and the solutions can be many depending on which country we're talking about. There could be evidence-based drug pricing, increased availability and participation in trials, working with the national regulatory agencies, focusing on big centers like a hub and spoke model, so that, if there's big centers doing the trials, they can take them to rural areas. Like in the US, there's this Montana project, which ASCO has worked on, so that rural areas receive the same care, and that's a pilot project right now. And more importantly, involving all stakeholders in the negotiations. And so these are some of the challenges which a whole team at different levels need to work on. And just a stark contrast on the total health expenditure per capita in the US in dollars by the WHO, as you can see, the net patient economic burden in 2019 was $3.3 billion for prostate cancer, just in the US, around $1 billion for bladder cancer, and $800 million for kidney cancer. And this is really very high compared to all other countries in the world. Now, we have a lot of industry partners here, thanks to Andrea for having them as stakeholders here, and I think it is very crucial for them to help academicians and drug developers to tackle the gaps in drug access. And this is just not to put any one company on the spot, but we see the basic shortage of drugs like BCG in the US, drugs like cisplatin, which are so cheap, and we see the shortage of these drugs. We never really see shortage of expensive drugs in countries where they're available. So this really impacted how we were treating our testicular cancer patients, lung cancer patients, bladder cancer patients, and all other patients for cisplatin shortage. Like, we literally had to ration it out where we could substitute with carboplatin. It was a sad state of affairs, but only in the US, nowhere else. And everyone here is aware of BCG shortage and the crisis. And then there's another important topic about, are we using too much of the newer drugs? You know, immunotherapy has been a game changer for a lot of cancers in the last 10 years. But the fact is that in the early phase trials, the maximum tolerated dose was actually much lower than what the phase 3 trials used for approval and marketing. And this is across the board for many cancers. For example, in kidney cancer, the phase 2 study demonstrated similar overall survival using 0.3, 2, and 10 mg per kilogram of nivolumab every 3 weeks, but the phase 3 trials used the 3 mg per kg dose every 2 weeks, which is 15 times the lowest effective dose that was actually needed. And for pembrolizumab, the data suggests that PD-1 receptors are occupied at doses more than 1 mg per kg for at least 21 days, but the phase 3 trials use 2 mg per kg. For atezolizumab also, it's the similar thing. Disparities in drug pricing is not a new topic for us, and it is just to highlight the difference in the cost in US and UK itself, because UK uses the NICE system where they push for adjusting the price of the drug, and pharma companies sometimes do that. But if you look at the pricing, for example, for pembrolizumab, the difference in the cost between the US and UK is quite striking. Same for atezolizumab, because they also go on the quality of life adjusted years. And now the big question is, you know, having myself had several friends and family members dealing with cancer in my country, it's really a matter of how much immunotherapy can one afford, because it's all out of pocket, and the best schemes could be buy 2 doses, get 1 for free, and, you know, looking at this price, this is the equivalent people have to pay in low-income countries, which is really not practical. So now talking about all the newer drugs like enfortumab vedotin, it's like per vial it's going to be $3,000 some, and I think it would be really interesting to see how the rest of the world will be able to have the uptake of this. It's obviously going to be very select patients who will have access. And this slide needs no description. If you look at the number of trials in the world, look at the ones in the US, and this slide is actually from 2023, and look at the rest of the world where majority of the population resides. So we really have to do better, and again, our pharma partners have to help for this. And I think this was a really good study we saw at ESMO last year, the Reno-TORCH study, where this came from China. They have their ingrown checkpoint inhibitor, toripalimab, and when they combined it with axitinib in frontline kidney cancer, it showed results which was similar to the initial axi-pembro study. And this, I think, is really important for countries to develop their own agents. And I think once these agents are developed, it may help reduce the cost burden in other countries. And we all talk about the cancer moonshot. It is a priority for the government in the US, but I think we really need to address the basic gaps in disparities before getting to the moonshot. There's a lot we have to do at the ground level. And there's a lot of strategies to close the gap by making health equity as a strategic planning priority, learning and improving from our work. So, you know, a lot of policies to prevent and early detection, going to the people as opposed to expecting them to come to the hospital. Just like in India, I remember as a medical student, we used to go door to door in the villages and the cities and give the polio vaccine to the kids because expecting them to come to the hospital was really not practical, and that's how India was able to eradicate polio, which was an epidemic. And we need policies to tackle environmental and occupational exposures, social support for the aging population, improving trial access, and of course partnerships with global regulatory agencies. And there's a lot of work being done, and you know, Ashish and Phil gave this beautiful overview. Andre has been involved with all these efforts. So from the ASCO point of view, from the European Cancer Inequities Registry, and a lot of different organizations are taking steps to work on disparities, which is really great news. So it's not all doom and gloom, and I think that's my last slide. It would be great to see the same trials available for everyone around the world and not just a few countries. Thank you.
Thank you, Shiva. Outstanding talk. So let's open up the door to the last session. I will give the keys to the young faculty. So young rising stars will take the action here for the update of clinical trials that are ongoing on prostate, renal, urothelial cancer, and rare Jew tumors. So, Brigida, the floor is yours. I give you my seat.
Well, I'm going to stay here forever this afternoon.
Good evening, everyone. Good evening to the survivors. Last but not the least, let's start with the updates from clinical trial. Very happy to co-chair this session with my dear colleague Chiara. So, Chiara.
So, welcome again to this last session. We are going to start with Professor Giorgio Gandaglia from the Department of Urology here in San Raffaele, which will present us an update on prostate cancer. Please,
Thank
Giorgio.
you. Thank you very much. And I should say that the level of the meeting is very high. This is the most stressful presentation for me in the year, and I'd like to congratulate with Professor Necchi because it's really incredible to have such stars, not rising stars, but this amount of keynote speakers here in Milan, in San Raffaele. So thank you very much, and I'm really, really honored to be here. And my task today, I am a urologist, and I will present you an update on prostate cancer and on the clinical trials we have. And this is basically just the conflicts of interest. Before starting and to set the stage, I'd like to stress the concept of the importance of terminology. And this is also for our residents in the room. In medicine, you have words which have power, and we need to have a standardized terminology, and we have many different words to define prostate cancer, metastatic prostate cancer, castration resistance in prostate cancer, RPs, etc. And during the APCCC meeting this year, actually there has been an effort to standardize the terminology used in prostate cancer, and when we talk in meetings, we should always refer to these terms to allow for standardization of care and comparable, to talk the same language, let's say. Moving to clinical trials in prostate cancer, we have different settings, and currently we have 17 ongoing prospective trials. And for the ones of you who were here last year, you will see that some trials terminated and have been completed over the last year, and we are very happy about it. And we have new trials to present you. And the 9 trials are academic-driven, while we have 8 industry-sponsored clinical trials. I will mainly focus on academic-driven clinical trials tonight, and the first concept I'd like to introduce is the role of PSMA PET in the setting of localized prostate cancer. We know how important it is to have a PSMA PET to correctly stage our prostate cancer patients. At the same time, there is increasing evidence nowadays that PSMA PET can also play a role in the setting of diagnosis and active surveillance patients. And the reason is that the PSMA expression correlates with a grade, so a higher PSMA expression correlates with grade group 2, 3, 4, and 5 prostate cancer. It correlates with, and it is actually a biomarker for response to androgen deprivation therapy and radiotherapy. This is a study we are conducting together with our nuclear medicine physician department, and the study aims at assessing the role of PSMA PET at the time of MRI in patients considered for a prostate biopsy. We aim at enrolling more than 150 patients, and all patients will be actually receiving a PSMA PET with concomitant multiparametric MRI followed by a biopsy. And the aim is to reduce the rate of false negative findings and to improve the rate of true positive findings, actually, so to improve sensitivity and specificity. And as you can see, PSMA PET was able to identify one additional cancer which was otherwise missed by MRI. We're talking about an initial small sample size, and we're talking about approximately 20 patients, and the sensitivity and the negative predictive value is 1, which is excellent in this setting. We have still to work on the specificity, and this also varies according to the definition we use to define a positive PSMA PET, and we are testing different cutoffs. We are also testing the role of PSMA PET in the active surveillance setting. These are preliminary results, and we focused on a small cohort of patients who received the PSMA PET. These are active surveillance patients. They were staged with PSMA PET, or they were actually staged with a biopsy, and the biopsy was evaluated with immunohistochemistry, and PSMA PET immunohistochemistry was evaluated using a standardized score, which is the H score. We enroll approximately 71 patients, and you can see that PSMA expression correlated with the ISUP grade group at confirmatory biopsy, and it was also associated with active surveillance status, where patients who discontinued active surveillance due to disease progression had higher PSMA PET expression. And this was confirmed both using the SUV max, so quantitative parameters at PSMA PET, and also when evaluating immunohistochemistry expression of PSMA PET in the first biopsy, so at the level of the diagnostic biopsy. And here you can see the Kaplan-Meier analysis where the median time to active surveillance discontinuation was substantially shorter in men with higher PSMA expression compared to the ones with lower PSMA expression. These preliminary data allowed us to submit a proposal which was recently accepted and funded actually for a grant on a prospective study aimed at assessing novel biological pathways and the role of next-generation imaging with PSMA PET in the setting of active surveillance patients. So this study will start the 1st of January, and it will enroll 74 patients with grade group 1 prostate cancer, and we will assess whether higher PSMA expression is actually associated with biological pathways of more aggressive diseases in low-risk prostate cancer. Moving to neoadjuvant therapies, we have a phase 1 study aimed at assessing the role of IL-15, and this is an intraprostatic injection of interleukin-15 in high-risk locally advanced prostate cancer patients. This study is done together with the King's College of London, and we will do it thanks to a grant from Dr. Recordati, actually. When we look at staging, we have a randomized trial which has been designed, and Dr. Armando Stabile is the PI of this study, together with Professor Briganti, aimed at assessing the role of a pelvic nodal dissection in the PSMA PET era. And the aim is to compare patients treated with radical prostatectomy and pelvic nodal dissection with patients treated with radical prostatectomy alone. So it's a little bit different compared to what has been recently published on the role of nodal dissection, and the Memorial Sloan Kettering trial actually compared the limited approach to an extended approach. Here, patients will receive a pelvic nodal dissection versus those who will not be treated with a nodal dissection. And the aim is to assess the impact of this surgical procedure on oncologic control and early BCR. And this is another study we're doing thanks to a grant by Dr. Recordati, and this study is aimed at assessing the role of AI in prostate cancer and the role of novel AI methods to predict survival in prostate cancer patients and also functional outcomes. And these are the preliminary results, and you can see that when we look at the C-index of the novel AI-based tool, it is substantially higher compared to what is available in the literature for patients with localized prostate cancer, and we compared it to the MSKCC, to the CAPRA score, and other available tools. And finally, we have ongoing studies also in the setting of castration-resistant prostate cancer, and I will be very quick on this because it has already been presented by Professor Agrawal, and basically we are interested in exploring the role of novel drugs such as ARV-766 in the context of metastatic castration-resistant prostate cancer. These are the preliminary results which have been presented at ASCO meeting, and hopefully we will be able to test this molecule also in earlier disease stages. With this, I'd like to thank you and to thank the entire prostate cancer research team at San Raffaele Hospital. Thank you again.
Thank you, Giorgio. Please take a seat after your wonderful presentation. It is a pleasure to introduce another colleague, Antonio Cigliola from Milan, with updates from clinical trial of San Raffaele, and then Professor Sadeghi from the University of South California for update of clinical trials from Extra San Raffaele. Go, Antonio, thank you.
Thank you, Brigida. Good evening, everyone. So here are quick updates from clinical trials on urothelial carcinoma. So in San Raffaele Hospital, we try to give our patients with urothelial carcinoma the most innovative treatments throughout sponsored and academic clinical trials, internal and international collaborations for translational research, but also a dedicated group of oncologists, nurses, and study coordinators. And here we will make a focus on our key research in 2024 and the most promising clinical trials that we have in our institution. Let's start from non-muscle invasive bladder cancer. Here, an off-label use of intravesical docetaxel and gemcitabine. This work is led by our urologists, and in this work, patients with BCG failure or intolerant non-muscle invasive bladder cancer are treated with the combination of docetaxel and gemcitabine. There is a phase of induction and a phase of maintenance, and we have the preliminary results with the first patients treated with these combinations. 25 patients were treated between 2023 and 2024, and 10 patients completed the follow-up with at least one complete induction course or at least one follow-up cystoscopy. Median age was 71, median follow-up was 5 months, and the results showed that no patients has received radical cystectomy yet, no progression or high-grade recurrence were documented, and 6 months disease-free survival was 8–9%. Let's go to muscle-invasive bladder cancer. This year, the results of NURE-COMBO trial were published in JCO. NURE-COMBO is a phase 2 study of neoadjuvant nivolumab and nab-paclitaxel, followed by post-surgical adjuvant nivolumab for patients with MIBC. The results showed that the combination was safe, and in terms of efficacy, there was a pathological complete response of 32.3% of patients, a pathological downstaging in 70.9% of patients, and 12 months EFS was 89.1%. Our biomarker analysis showed that a lower baseline fraction of PMN cells and intermediate monocytes were associated with pathological complete response. But this year we presented also the preliminary results of SURE-1 trial at ASCO 2024 at ESMO Asia 2024, in which patients with PT2-4 and 0 M0 histological confirmed urothelial carcinoma were treated with 4 cycles of neoadjuvant sacituzumab govitecan. And the preliminary results of the study, as presented by Brigida at ESMO Asia, with 36 patients, showed a pathological complete response of 37.5%, a pathological downstaging of 78.1%, with a 12 months EFS of 84.4%. 9 patients received the RITU-RBT after refusing radical cystectomy. 8 of them refused a radical cystectomy after a clinical complete response, while 1 of them refused it for patient decision. And another interesting topic of the study is the amendment. In fact, after the first 8 patients, the study was amended due to toxicities with sacituzumab govitecan reduction to 7.5 milligram per kilogram, primary prophylaxis with GCSF, and the exclusion of patients with greater than or equal of 3 risk factors for febrile neutropenia. And after the amendment, the treatment was gave good results in terms of safety, with not a lot of G3/4 adverse events. Biomarker analysis in this case are ongoing. But in San Raffaele Hospital, we have also the SURE-2 trial in which the neoadjuvant treatment with sacituzumab govitecan is made with perioperative pembrolizumab. So 4 cycles of pembrolizumab before radical cystectomy and 13 cycles of adjuvant pembrolizumab after surgery. But for the preliminary results of this study, we have to wait next ASCO GU. As mentioned by Professor Necchi this morning, we know that GDF15 prevents the transmigration of T cells to tumor site. And so blocking GDF15 with inhibitors such as visugrumab, we can enable T cells to infiltrate and destroy solid tumors. And the last days, a paper was published on a phase 2 study with visugrumab used in solid tumors together with immunotherapy, and focusing on urothelial carcinoma cohort, we can see that the results are very encouraging. And in San Raffaele Hospital, we have for patients with muscle invasive disease a clinical trial in which visugrumab is used in the neoadjuvant setting. This trial is interesting because surgery is evaluated on the response, on the clinical response, and so patients can undergo radical cystectomy or RTRBT, and the study is ongoing. Another promising drug that we have for patients with metastatic disease is BT8009, which is similar to enfortumab vedotin, because also in this case we have an anti-Nectin-4 molecules, but in this case we don't have an ADC, but we have a complex and small molecule characterized by low molecular weight, short plasma half-life, and rapid tumor penetration without internalization. And here we have a phase 1/2 study of safety and activity of this drug in patients with Nectin-4 expressing advanced malignancies. And this year, the results of the metastatic urothelial carcinoma cohort were presented. And also in this case, we have very interesting and very encouraging results. And finally, focusing now on rare tumors of bladder cancer, here a study we published this year in which we analyzed 133 urachal and 328 non-urachal adenocarcinoma of the urinary bladder from the Foundation Medicine database. And our results show that most frequent genomic alterations in both tumor types were TP53 and KRAS, and genomic alterations characteristic of colorectal adenocarcinoma were more common in urachal adenocarcinoma, while TERT and RB1 were prevalent in non-urachal adenocarcinoma. But we saw also that both urachal and non-urachal adenocarcinoma presented possibly targetable genomic alterations, in particular in PIK3CA and RB2. Both tumor types didn't have biomarkers associated with the potential benefit from immunotherapy. And thank you. Thank you.
Okay, please, Antonio, sit. Thank you, Professor Sabeghi, for your intervention. Please.
Good afternoon, everyone. Thank you for having me here. Thank you, Andrea, for inviting me. We had a very productive day today. I learned a lot, and we had discussions about, are you able to queue up my slides? Yes. Yes. So we had this theme today that, especially for urothelial carcinoma, we are doing everything for everyone. We are throwing the kitchen sink at them, and treatments are more or less the same. So I'm going to talk a little bit about some of the data that's coming out that could potentially help us select patients for certain treatment. This certainly could inform some trial designs and allow us to look at this from, look at it as a spectrum, that from one end we could have patients that could be treated with what we see today as the standard of care, or patients that could be treated more on an individual basis, and also potentials for bladder sparing. So enfortumab vedotin has certainly dominated urothelial carcinoma field. In the metastatic setting, it's the preferred standard of care in the US. And in the same ESMO presentation, in the same ESMO that this study was presented, EV302, Gemcis and nivolumab was presented, and of course it was overshadowed by the success of enfortumab vedotin plus pembrolizumab in metastatic setting. We know the mechanism of action. It's an antibody-drug conjugate, sits on Nectin-4 and is internalized. The payload is released, it's highly cytotoxic, but there are also additional mechanisms that are attributed to enfortumab vedotin. One is immunogenic cell death, and the other one is augmented response by to PD-1, PD-L1 treatment. That may be the rationale for the combination. So, but is it for everyone? I think I mentioned that this is, in the US, is the preferred standard of care. But data is emerging. Over the past year and a half, we're seeing very interesting studies. This is from Jonathan Rosenberg's group. They looked at the primary biopsies from urothelial carcinoma and the metastatic biopsies and looked at Nectin-4 expression. A few things that we can take from this slide is that in the course of the disease, 59% of times Nectin-4 expression goes down. In 19% of patients, it goes up. That's a net 40% decrease in Nectin-4 expression. In the bottom, you see that 39% of patients are Nectin-4 undetectable. This is not what we expected. And then these are patients that are potentially going to be unresponsive to Nectin-4 treatment, to enfortumab vedotin. On the other end, we have maybe 36% of patients being moderate to high expressors of Nectin-4, and those are the patients that we expect would be excellent responders. This is another very interesting study by a German group, Nicholas Klumper and Markus Eckstein. They reported this in JCO. They looked at 108 patients that were treated with enfortumab vedotin. They looked at the expression, and they identified that some patients actually have Nectin-4 is amplified. 28 such patients were in this series. 27 of them were responders, so 90+% response rate if Nectin-4 is amplified. On the other hand, if Nectin-4 is not amplified, then those patients had about 30% response rate. If you look at those survival curves on the right-hand side, those are patients that are non-enfortumab vedotin treated, and the curves are separated based on Nectin-4 amplifications or non-amplified Nectin-4, and the curves are overlapping. So what we can take from that is that Nectin-4 expression doesn't seem to be a prognostic marker. And this is the slide that we have seen before. This is the newest version, I think. Dr. Tom Powell's presented this in response to these questions about whether we should check Nectin-4 status before treating patients with enfortumab vedotin. And the takeaway from this is that they drew the line at 275, H-score of 275, presumably because that's around the median for expression. Half of the patients express higher levels. And then they showed us this slide that when we draw the line and separate patients, Nectin-4 high, low, still everybody seems to be responding. So it may not be necessary to check for Nectin-4. I'm going to leave this here. I'll get back to this. At USC, for the past 10 years, we've been developing a target, FRNB2, for treatment of urothelial carcinoma. FRNB2 and FB4, there are two transmembrane molecules. They're part of FRN and F family of receptor ligands. They are mostly expressed in the embryonic stage of life, and they are key parts of new vessel formation. If you knock it out, capillaries don't form, veins and arteries don't meet, and it's a deadly knockout. So, and we know from TCGA data that FRNB2 and FB4 expression both are negative prognostic markers. So we designed this clinical trial because the studies that we had done at USC showed that in a lot of tumors, these markers, FRNB2 and FB4, they are expressed again. It's not just during embryonic life, they are expressed again in the carcinogenesis. So this was a clinical trial that we did for platinum refractory patients. We combined this SFB4-HSA, which is an inhibitor for FRNB2, in combination with pembrolizumab, usual CT scans to monitor for response. We put 70 patients on this study and the usual endpoints. And this is what we found. We found that pembrolizumab in post-platinum setting by itself is expected to have a response rate of 21%. And we saw that in our patient population, we had a response of 37%. But in the subgroup that expressed FRNB2 as high, this response was upwards of 50%, and just the CR rate was 23%. So this combination seems to work, and there may be ways to select patients. One question that came our way from the FDA granted breakthrough designation, breakthrough therapy designation to this drug. They asked if, is it possible that just immunotherapy by itself overcomes the negative prognostic effect of FRNB2. We knew that during the era of chemotherapy, but nobody had looked at it for immunotherapy. So we put together this series of 159 patients from USC, Dana-Farber, UC Irvine, and University of Colorado. and looked at this question closely. So I don't know if we have a laser pointer here. Oh, here, okay. So this, if you look at the objective response rate for all comers, it's 20%, exactly what we would expect for monotherapy. These are patients treated with just immunotherapy. If we look at the FRNB2 low cases, 38% of these patients had FRNB2 low. And the objective response rate was 33%, higher than you would expect for just pembrolizumab. But look at FRNB2 high expression. Response rate, objective response rate, 12%, so much lower than you would expect. So this is not only, this still is a negative prognostic marker for immunotherapy as well, and by inhibiting it, we showed that the response rate goes, for B2 positive patient, goes upwards of 50%. The same, a similar pattern is seen when you look at the overall survival. So it's in the same direction, and the effects are statistically significant. So going back to Nectin-4, I got the specimens from Klumper Group, and we ran them for FRNB2 in our lab. And I tried to generate a similar graph to what Dr. Powell's showed. This is what we could do. So that curve goes like here, but we are much more modest than that. And we have a lot more patients that are negative for Nectin-4. And as you can see, the responder is represented here in green. They are towards the higher end of the expression for Nectin-4. This table summarizes the same data. We used the 275 cutoff that they used. We added a 200 and a 100. This is the H-score for Nectin-4 expression. And if you look here, if Nectin-4 positive, we consider that base responders. The majority of patients are responders in this blue box up here. But if Nectin-4 is negative, you can see it's the majority are non-responders when treated with Nectin-4 targeting drug enfortumab vedotin. This, as we drop this to 200 and 100, the p-value improves and becomes statistically significant, which essentially means that if you are H-score of lower than 100 and Nectin-B4 is negative, you're statistically significantly more likely to be a non-responder than a responder to enfortumab vedotin. So this begs the question, can we use this for patient selection, and should we actually test for Nectin-B4? I added some additional information here in these orange or pink boxes. This is FRNB2 expression combined with Nectin-4 expression. So if you have Nectin-4 expressed and B2 is negative, then again, you're more likely to be a responder. And as we go down, the majority of patients are going to be responders. But for the patients who are Nectin-4 non-expressors and B2 positive, the box shows that they are very likely to be non-responders, almost 4-to-1 here, and the results are statistically significant. So based on this, we are doing additional clinical trials looking at using this combination in patients that are Nectin-4 negative and express the target for this drug in metastatic setting in frontline and in neoadjuvant setting, hopefully launching the neoadjuvant one in January or February of next year. So I think it is possible to do patient selection. I think this is one of the ways that we can look at patient selection. We have talked about circulating tumor DNA, and I think this adds to how we can look at this question and look at design of clinical trials. Thank you.
Thank you, Dr. Samed. Well, now it's a pleasure to invite on stage my co-chair and friend, Dr. Brigida Majorano, which will present us an update on the San Raffaele research on renal cell cancer, and then she will share the stage with Dr. Nazli Disman from MD Anderson Cancer Center. Please, Brigida.
Thank you, Chiara, for the floor. Thank you to Professor Necchi for having organized this meeting. It is the first time for me. I'm flattered for the participation. Buonasera, everyone. Just for not repeating myself. Please share my slide. Okay. These are my disclosures. I enjoy to describe the therapeutic evolution of RCC as a journey starting over 30 years ago in the Stone Age of cytokines, and then continuing through the target therapy era and the immune checkpoint inhibitors as monotherapy era, ending in the combination therapy era. Indeed, the approval of IC-based combination has redefined the first-line standard of care for patients with MRCC. But despite the undeniable advantages of these combinations, most patients eventually progress, requiring subsequent therapies. But there are no standard of care for second-line and third-line options, and this is, in my opinion, one of the most important unmet needs, even in the golden age of MRCC. Indeed, if it is reasonable to assume that any TKI not previously used could be utilized in subsequent lines of therapy, there is a lack of head-to-head comparison and few evidence about from prospective trials, and therefore this underscores the importance of enrolling such patients in clinical trials whenever possible. Also, the concept of easy re-challenge, which has few evidence, could be potentiated with the introduction of therapies designed for addressing specific mechanism of IC resistance. So, in this context, it is a pleasure to present the study that we are conducting with the Genenta Science, which is an Italian biotech founded as an Ospedale San Raffaele spin-off with experience in ex vivo gene therapy using autologous hematopoietic stem and progenitor cells, which are genetically modified and re-administered to the patient in the context of a stem cell transplant. Here, a number of trials has been conducted using the gene therapy with the lentiviral vector-based technology to transfer a variety of transgenes into hematopoietic stem and progenitor cells, starting from a monogenic disease and then aiming to treat cancer patients. And indeed, the Temferon has been designed to deliver interferon alpha within the tumor microenvironment. Temferon consists of frozen autologous hematopoietic stem and progenitor cells transduced ex vivo with a lentiviral virus vector encoding for interferon alpha. It is formulated as a cryopreserved intravenous injectable solution, which bears the capability with a single administration to achieve a potentially lifelong response. It is agnostic, so useful for solid and hematological malignancies. From preclinical data, we know that Temferon is able to inhibit the proliferation of tumor cells by antagonizing angiogenesis and reprogramming both the innate and the immune cells to mount a specific anti-tumor response. This rationale seems particularly attractive in the context of a disease such as the renal cell carcinoma, which is linked with angiogenesis, and in which the shift from the M1-like to M2-like terms is associated with the disease progression, or in which a high presence of CD8 positive T cells is associated with a poor prognosis. The Temferon technology has the possibility to assess some of the major challenges of immuno-oncology, for example, achieving durable responses, selectively delivering the payload within the tumor microenvironment, maximizing efficacy, and also avoiding or limiting systemic toxicity, and switching a cold to a hot tumor microenvironment. The first study with the Genenta has been conducted in the glioblastoma, which is a rare but aggressive brain tumor. It represents the most common primary brain tumor, very aggressive with a poor prognosis, 2 out of 3 patients dying within the first year, carrying hallmark of immunosuppression and neoangiogenesis. It is treated with a combination of surgery and chemoradiotherapy. In the TEM-GBM phase 1-2 trial, patients were included in case of unmethylated MGMT glioblastoma undergoing complete or partial tumor resection and a candidate for adjuvant radiotherapy. Starting from 2019 up to October 2024, 24 patients were treated, 5 patients were alive, and the median overall survival after the first surgery was 17.8 months. At the interim analysis at 2 years, there was a survival rate of 28%, which was higher than that reported in literature from patients treated with radiotherapy plus temozolomide in the same setting. So not only the treatment had a biological activity, but it was also safe because there were low levels of interferon alpha detectable in the plasma. And indeed, the majority of severe adverse events were related to the conditioning chemotherapy and to the disease progression. There was only one serious adverse event related to temferon, which was a highly persistent elevated level of gamma-GT in a long responder patient. The treatment was also tolerable with no dose-limiting toxicity today. This represented the rationale for designing the TEM-GU study for patients with MRCC progressing to at least 2 lines of therapy, to study the possibility of temferon of potentially restoring the immune response to immune checkpoint inhibitors, but also to evaluate the biological effects and safety of temferon alone, and in case use cabozantinib as a rescue, and finally to evaluate the combined effects of temferon plus pembrolizumab or cabozantinib on the tumor microenvironment. Also, TEM-GU is a phase 1-2 study with a co-primary endpoints in the first phase of assessing over the first days from temferon administration the tolerability and safety of both the conditioning and temferon, and also the biological activity of temferon. These are some of the key inclusion and exclusion criteria. Patients will be included in case of histological diagnosis of advanced RCC with at least 1 clear cell component, aged from 18 to 70 years, progressed after at least 2 lines of standard of care treatments in good general conditions and with a normal organ functions, and excluded in case of prior severe adverse events to IC or TKI, or in case of concomitant active autoimmune disease or use of immunosuppressive treatments, and in case of liver or cerebral metastases. This is the TEM-GU overview of study procedures. After the screening, the harvest of CD34 positive hematopoietic stem and progenitor cells will start. Temferon will be manufactured. Then patients will undergo a conditioning with busulfan. Then temferon will be administered, and a follow-up phase will start after 30 days. There will be 2 cohorts of patients according to the previous use of an IC. Patients assigned to the IC cohort will receive pembrolizumab 400 milligrams every 6 weeks until PD. Patients receiving an immune checkpoint inhibitors in the previous 6 months will be evaluated for cabozantinib. In case of no progression, cabozantinib will be withheld and started as a rescue only in case of disease progression. So we will update you next year, maybe with the first data of TEM-GBU. Meanwhile, I would like to thank you for the attention and to leave the floor to my colleague Nazli Ditzman from the MD Anderson. Thank you.
Thank you, Brigida.
Good afternoon, everyone. First, I'd like to thank Dr. Neki, Chiara, Brigida for the invitation and warm welcome here. It's been an amazing meeting for me. I got to meet a lot of people, learn a lot from the presentations, and hopefully we'll start new collaborations from here. I am a HEMONC fellow at MD Anderson, so my research portfolio is a lot different than a lot of my colleagues here who have large clinical trials, but I'll walk you through my own journey. I'm originally from Turkey. I did my training and medical school in Turkey. Then I slowly went west and ended up in the western side of the United States in Los Angeles and started working with Monty Paul in 2017. Since then, I have been doing GU medical oncology research, but I moved around. I did residency training at Yale, and then I am doing a fellowship training in my second year at the moment. I first started my research projects at City of Hope, doing review articles, retrospective projects, as well as some translational work on genomic characteristics of GU cancers and their relationship with outcomes. Then my interest evolved and has focused on microbiome, which has been an emerging field as we've seen immuno-oncology emerging as well. As you know, microbiome is a huge component of our body, and some calculations estimate that we have more microbes in our body than human cells. So we started investigating this with the mentorship of Dr. Monty Paul. Our initial studies looked at microbiome in patients receiving VEGF-directed therapies for renal cell carcinoma. In those studies, we were able to identify a few species that are related with better outcomes with targeted therapies. And they actually were in parallel with some of the findings reported by other groups suggesting that similar species are associated with response to immunotherapies as well. This includes Akkermansia mucinifera in this slide. Then we went ahead and analyzed a cohort of patients receiving immunotherapies for kidney cancer. And in that cohort, again, we were able to demonstrate the same species increasing in responders compared to non-responders with immunotherapies. Next question we asked was whether we could modulate the microbiome to improve outcomes. Okay, great. In this project, we collaborated with a Japanese pharmaceutical company that has been producing and distributing a product called CBM588, which is comprised of Clostridium butyricum, which is a butyrate-forming bacterium, so it generates short-chain fatty acids in the gut lumen, and short-chain fatty acids have close links to systemic immune responses and anti-tumor immune responses. We studied this compound in patients receiving nivolumab and ipilimumab in first-line setting of renal cell carcinoma in a randomized setting in a small trial with 30 patients total. Our findings were interesting. We hypothesized that Clostridium butyricum would increase bifidobacterium species based on studies in the literature suggesting this in vivo models. But in our study, we didn't see a significant increase in this beneficial species. However, we found an increase in stool microbiome profile of patients in bifidobacterium species if they received CBM588 and responded to treatment. So our take in that was that perhaps a certain population of patients get benefit from this compound, have gut microbiome modulation, and also respond to treatment. We've also looked at the clinical outcomes in this trial. We're very surprised, in fact, because in the group that received CBM588, we've seen a higher response rate, 58% versus 20%, and a longer progression-free survival, 12.7% versus 2.5%. These findings were interesting, and our next approaches were to look at the mechanisms in which CBM588 may be improving outcomes. In parallel with the first study that I mentioned, we conducted another trial looking at addition of CBM-588 in a randomized setting again in patients receiving cabozantinib and nivolumab in first-line setting. We found similar impressive improvement in response rates. The impact of this compound to progression-free survival was not as significant as the study nivolumab, ipilimumab, but the follow-up period for this study is pretty limited at the moment. As I mentioned, the next question was to understand what this compound do. Is this a magical bacteria that could change everything and make it better, or is this bacteria causing a major shift in the microbiome or its function and that helps improve immune responses? We started looking at short-chain fatty acid levels in blood in these patients. We found that isobutyric acid has increased in responders that could be associated with altered amino acid metabolism as well. So this part of the study is still undergoing a further analysis, but we are hoping to understand the impact of this compound better, going back to lab, collaborating with scientists at MD Anderson and testing this compound in mice models. Next, I'm gonna transition to future goals. My interest so far has been definitely in GU oncology and mostly in the area of microbiome. At MD Anderson, I'm working with the melanoma group and learning from them how to study microbiome in large settings with including several different factors such as host factors or microbiome, metabolome of the stool, circulating metabolome or metabolomic characteristics of the tumor. And I'm hoping to use these skills in developing a microbiome protocol and a database in an institution that I'll be moving after MD Anderson. I haven't mentioned it here, but we also have a chromophobe RCC database that is from several institutions in the United States. We have a few projects ongoing with that. As we've been speaking about collaborations, I wanted to mention if anyone is interested in collaborating in that as well. I'll finish with that, and thank you all for listening to me, and thanks to all my mentors, and a lot of them are here, and collaborators for their help with all these studies and for their leadership.
Thank you very much, Nazli. Please join us. And it is a pleasure to introduce the last speaker of the day, our dear colleague, Valentina Tateo, talking about rare GU tumors.
Thank you, Brigitta, and thank you to the survivor for being already here with us. Okay, I'm going to talk about rare GU tumors. Rare cancer are defined as tumor with an incidence lower than 6 per 100,000 person year. And in the genitourinary district, several cancers are defined as rare cancer because of the location, the primary location, or of the histology. And today I'm going to talk on testicular cancer, which are the most frequent rare GU cancers. Testicular germ cell tumor cancer are globally rare tumors, but there are significant worldwide imbalances with some regions in which actually they are not rare. Testicular cancer are the most frequent cancer in young white men, but the epidemiology is rapidly changing in the last decades, and we are observing an increase in incidence also in historically low incident regions. But we will focus on this topic in the next slides. Testis cancer are characterized by excellent outcomes, but there are persistent unmet clinical needs, in particular the optimization of the risk-benefit balance in curable disease and the improvement of treatment strategies in the poor prognosis platinum resistant disease. As I said before, the epidemiology is changing, but the incidence is still higher in Western countries, with an incidence that overcome the threshold of rare cancer definition. But in the last decades, there is also an increase in low incidence regions, in particular in Asia, for example, Japan, Thailand, and Korea. And the prediction for the future are of a continued increase in incidence, especially in Europe, that is the region with the highest incidence. We recently conducted a systematic review with meta-analysis on epidemiology and risk factor for developing testis cancer, and these are the results of the meta-analysis. As you can see, the stronger results are for prenatal and early life factors, with a significant 44% increase in risk of testis cancer. This highlights the need to work on a modifiable early life risk factor to reduce the increase in incidence we are observing. Indeed, testis cancer is a cancer characterized by an important interplay between the genetic predisposition and the environment. There is a genetic predisposition that influences the baseline risk, but environment could modulate the risk across generations. A further research is needed on socioeconomic factors, since industrialization and high development of the countries are risk factor for are associated with an increased risk of developing testis cancer. Moreover, we need to bridge the gap in genomic data, because currently genomic data are focused only on European ancestry, leaving other ethnies underrepresented. Considering the rising global testis cancer burden, there is an urgent need to identify modifiable risk factor, improve early detection, and think about preventive strategies for high-risk groups. Shifting our focus on treatment needs, in clinical stage 1, we know that patients have an excellent outcome, but we have to consider that we are treating really young patients with an excellent outcome, so the benefit and risk balance is extremely important. In non-seminoma, we know that the adjuvant one course of BEP is associated with a number needed to treat to prevent one relapse of more or less 2 patients, with a really low residual risk of relapse after adjuvant chemotherapy. Different is for seminoma, in which the number needed to treat to prevent one relapse with one course of adjuvant carboplatin is of 15-20 to prevent one relapse, and a higher residual risk of more or less 9%. This highlights the need to improve the patient stratification, the risk stratification. These are the results. Recently has been published in JCO this year a new proposal of risk stratification in seminoma clinical stage 1, highlighting the need or improving the stratification, adding more further risk to define the patient which are at really high risk, and so in which adjuvant chemotherapy is justified. Moreover, since the residual risk after chemotherapy with carboplatin is quite higher, there is ongoing an escalation phase 3 trial in clinical stage 1 seminoma that is ongoing, the ABC trial, in which patients were randomized to receive carboplatin, standard of care treatment, or one course of BP, and we are waiting for the results of these studies. Regarding the metastatic disease, also metastatic disease has a really good prognosis, with the exception of the poor prognosis disease. And so these escalation trials are currently ongoing. There are several trials. The SEMITEP trial, the results have been already published and show how this escalation strategy in good risk seminoma with a good response to the first part of the chemotherapy chemotherapy is a feasible strategy that need further validation. There are other trials which are focused on the escalation of both chemotherapy or radiotherapy, or the role of primary retroperitoneal lymph node dissection in stage 2A, 2B seminoma, and other trials also presented before by Dr. Loriot. Regarding the first salvage therapy, we are still waiting for the results of the TIGER trial. The TIGER trial is a phase 2 trial in which patients were randomized to receive high-dose chemotherapy versus conventional dose chemotherapy. The accrual ended more or less 2 years ago with 420 patients enrolled, but we are still waiting for the results. The results of this study are really important since we help us to define which is the best first salvage therapy for those patients. And then the poor prognosis, platinum-resistant disease. This situation occurs in more or less 10% of patients with advanced germ cell tumors, and the therapeutic options are extremely limited, so we need new therapeutic targets, and Claudin-6 seems to be a really promising target in these patients. Claudin-6 is one of the 26 Claudin proteins present in the human, and are proteins associated with tight junctions. Claudin-6 normally is expressed only in pluripotent stem cells and is suppressed in normal adult tissues, but in cancer is frequently overexpressed, including in germ cell tumors. So several drugs targeting Claudin-6 have been developed in the past years. The first is a monoclonal antibody, but the phase 2 trial in refractory germ cell tumor was early terminated for futility after the enrolling of only 19 patients. A more promising strategy are ADC targeting Claudin-6. Currently there are 2 ADC trials enrolling patients, the TORL-123 and the DS-9606. The first is a ADC anti-Claudin with a MMAE payload, and the second is a ADC anti-Claudin with a PBD payload. These are the results recently presented at the ESMO Congress about TORL-12301 trial. The trial enrolled a patient with Claudin-positive refractory tumors, including testis cancer. Only 5 patients with testicular cancer have been enrolled in this trial, but the drug showed a promising activity, and the safety profile was manageable and tolerable. Another trial with ADC anti-Claudin-6 is the one with DS-9606. Also, the results of this trial have been recently published at ESMO Congress. In this trial, 11 patients with germ cell tumor have been enrolled, and these are the responses in heavily pretreated germ cell tumors. As you can see, we have patients with good responses and long-lasting responses, that it is outstanding results for heavily pretreated patients. Also, with this drug, the safety profile is manageable and tolerable. And then the B and 3 specific antibodies. Currently, there are ongoing 2 studies with B-specific antibody. The first is a T-cell engager against Claudin-6 and CD3. The second is a T-cell engager against Claudin-6 and CD137, that is a co-stimulator of the T-cells. And the other is a 3 specific antibody against Claudin-6, CD3, and CD137. All these trials are currently enrolling, and we don't have at the moment updates. Then the BNT142. This is a lipid nanoparticle encapsulated in RNAs encoding for a bispecific antibodies against Claudin-6 and CD3. The trial is enrolling patients with Claudin-positive refractory tumors. We don't have at the moment any updates on this trial, but it seems a promising strategy. And then last, the CAR-T. BNT211 is a treatment with Claudin-6 CAR-T and Claudin-6 CARVac. The trial is composed by two parts. The first part is a Claudin-6 CAR-T monotherapy, and the second part is a combination of the CAR-T with the CARVac. CARVac is a mRNA encoding for Claudin-6 encapsulated in liposomes that have the role of boost the effect of CAR-T. The rationale is that CAR-T has a rapid depletion in blood of patients, and so the co-administration with CARVac in theory should improve the persistence of CAR-T. The results have been recently published at ESMO. In this trial, 30 patients with testis cancer have been enrolled. And the safety profile is consistent with the safety profile of previous published studies with CAR-T. So it's a toxic disease, it's a toxic treatment, but hopefully promising. These are the response in heavily pretreated germ cell tumors patients. As you can see, we have really good responses in a subset of patients, durable responses, and as hypothesized, the adding of CARVac improve the CAR-T persistence. So concluding, testis cancer are rare, but in some regions exceed the definition of rare cancers. The epidemiology is changing with an increasing of incidence also in historically low incidence populations. The outcomes are generally favorable, but we need to optimize the risk-benefit balance in these patients. And there are ongoing trials focusing both on intensification and de-intensification strategies. The platinum-resistant disease remain a poor prognosis disease, but Claudin-6 seems to be a promising approach. So we need to wait for the results of these trials. Thank you.
Thank you, Valentina. Now we arrived at the end of this day full of very interesting lectures from great physicians from all over the world, we can say. And now I invite Professor Necchi maybe for the final remarks, just to say, just the final.
Like the receptors under the antibodies, you know, you should be exhausted. You know. So I cannot thank more all of you for and the people who stayed here until the end for joining us today. I think that we have improved friendship, we have improved collaboration, we have expanded our collaborating potential. So it's a really good thing. We are already looking forward to 2025. I would like to thank all of you, the faculty team. I would like to thank the Expo Point team, Clarissa, Elena, and Marco, and the supporting staff who did a very good job. Please make an applause to them. Really good job. And they will do tomorrow an even more challenging task, you know, with a very strong task for the virtual connection, you know. So all of you who are interested to join us tomorrow, the entrance is free. So we will deal, there will be a roundtable and a virtual discussion with the people connecting, but the meeting is open to all of you who will like to attend. And thank, finally, to the sponsors who made for the industry, who made this event possible, and very much looking forward to the next year. See you.